Good morning. I'm here. Right. I'm glad you're here. They're just out there. I don't know if I can start or not.
Yeah, I know.
Yeah, Jim. Okay, good morning, everyone. Good morning. Welcome to day 2. We appreciate everyone being here. Can we settle in the room? Thank you. Thanks, everyone. So good morning. I want to say we're really happy about how day 1 went. Thank you all for your presentations yesterday. We just want to say a few words to encourage everyone for the end of today. We're aiming to get really great ideas, new ideas about how we can move forward to make sure that we do right by all the people living with dementia and their care partners. We want to really try to help make this meeting help to really advance the field so that we can get people better diagnoses faster and hopefully treatment. I want you to try to think boldly. Feel free to suggest ideas that seem wild, because we really want to make this work. Deb, did you want to add something?
No, I just want to add to what Nina said, that we need your help. So any brilliant idea, we're the government. What can we do, right? We need people with brains to help us out here. So please, please, tell us what you think is really interesting. Tell us what you need. Tell us where things are going, so that we know where to put the money, hopefully.
And so our last session today is going to talk about what resources we have already available, which presumably everyone in this room already knows about, but and online. But just to set the stage for what on top of that, what we can do that's needed. So I'm going to turn over to Dr. Chen Plotkin, who's online, to moderate this session. Alice, are you there?
Yeah.
Yes, give me a sec. Yes, I'm so sorry I couldn't be there. I actually had a conflict. So I'm in California in a hotel room, but I am really happy to have the slate of speakers. And I think the first one is Debbie Swang, who will be talking about actigraphy and sleep monitoring. So Dr. Swang.
Thanks for inviting me. Can you hear me? Everybody online too? Great. So, hey, Deb. I need money. So, thanks for inviting me to give this talk. How do I advance my slide? Keyboard. Oh, forward, I'm doing that. I am. So far for digital biomarker. Anyway. Oh, battery, is it? Okay, great. So I am a clinician and geriatric psychiatrist at the VA Puget Sound and also University of Washington. So this clinical question came to me that ended up being research. I was recruiting for the Dementia with Lewy Body Consortium that I'm a part of. Jim Leverance is the consortium PI. And so I saw a 78-year-old man who had Parkinsonism, and he reported a history of RBD, but he didn't have PSG documentation. He had no visual hallucinations or cognitive fluctuations, MCI, but no frank dementia. And despite my trying to get him into doing additional workup, like coming in lab for a PSG or a spinal tap or DAT scan or anything, he said no, 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 and no, and no. So despite like 5 attempts, I didn't want to get reported to our, patient advocate department. So I started thinking, wouldn't it be great if we could send him home with devices that he'd be willing to wear at home? That we could then collect data, and not only would it help with diagnostics, but it would help us with follow-up, because we would see these kind of patients every 6 months clinically. So that then drove my next quest of trying to look for in-home monitors that might be useful for early diagnosis of cognitive impairment and progression. So in general, you could do this in 2 categories. There could be participant smartphones that they could tap on or turn on or do cognitive testing on their phones. But then alternatively, some of these patients appreciate, and their partners appreciate, remote passive monitoring. And that's where we then, of course, this audience, we don't need to review the core Lewy body symptoms. So then we came up after much research and talking to a bunch of biotech mobile device companies. We came up with actigraphy, a medical grade that could measure physical activity and therefore proxy for motor dysfunction. And then, as we've heard plenty yesterday, sleep is obviously a big issue too. So then we thought, and actually Brad introduced us to a company in Carlsbad that did sleep monitoring. And that is the device. It's like a headband that could measure. And Brad assured me that they had validity through their in-house. His mouth is full, so he can't speak. Anyway, so then we got funded for R21 this is TED, the Technology for Early Detection of Dementia. And these are our baseline characteristics. And I know it's a small sample size, but we had to start somewhere. And with the R21 that converted to R33, we subsequently could increase our sample size. So this is a description of our sample. And because we recruited mostly for the VA, we had mostly male patients. And the age was in the 70s, MoCA, moderate stage, and UPDRS. No surprise, the part 3 higher in the DLB subjects, and MPI, obviously delusions and hallucinations are higher. And then RBD, 5 of our patients had reported RBD, and they had OSA. And of course, they were on cholinesterase inhibitors. And the AD patients, 4 additional ones were on Namenda. So, and Cinemet, about a quarter of our DLB subjects were on Cinemet. And then the SSRI rate was about higher in the AD subjects. And then as we heard yesterday, sleep disturbances and DLBs are under study, not in people in this room, but in general. But about 80% of patients or higher have sleep disturbance. And so poor subjective sleep quality, excessive daytime sleep, RBD. And we also heard yesterday from our caregiver as well that obviously it's a critically important for the caregivers to be able to sleep, and sleep disturbances in DLB patients increases caregiver distress. And it obviously exacerbates medical, cognitive, and psychological outcomes. So this is our remote monitoring device for DLB. And as I mentioned, it can measure all stages of sleep. And our patients report that they're pretty comfortable with it. And as with all investigative devices, I had to try it myself first, okay? Because I just felt like to be a good investigator, I have to be able to wear something that my patients would tolerate. So this is what that looks like. And then, as I mentioned, it records EEG, EOG, EMG with some mental leads. And then we added an arm lead too recently to detect motor movements. And patients were able to wear these for 2 consecutive nights every 6 months. And then accuracy, as I mentioned, is equivalent to PSG-based manual staging. So these are our baseline sleep profiler results. And the sleep efficiency is pretty much on target with age groups, normal age 70-year-olds. Sleep stage as far as N1, N2, and 3. In the AD, they actually look pretty comparable to age match control data. However, I point you to the percentage REM in the DLB subjects. They spent 6.2% in REM. And when you talk about in number of hours, it's like 0.3. So they spend very little amount of time in REM. And that was the key for this, even though it's a small sample. We have seen it replicated in other larger cohorts. And these, Brad and I and Dan Lewanowski were in a paper to discover this novel biomarker called non-REM hypertonia. So in the muscle tone is also increased significantly in patients with DLB. So these are just the box plots, and you could see that the percentage in hours spent in REM and hours spent in non-REM hypertonia. And I just point your attention to the DLB subjects and hours spent in REM, how it's significantly lower. And, you know, one thing that I learned from the sleep docs is you cannot score non-REM hypertonia. Or right, not non-REM hypertonia. REM without, do you call it WSA? RISA. So REM without atonia. So you can't score that when hardly any, you observe any REM. So we did, Eric St. Louis, who worked on this from Mayo, he did detect 2 patients with RISA, and those were the people who had more than half an hour in REM. Okay, so this was, and I know these are small sample sizes, and we're in hopes of, we have 20 more sleep studies that we're gonna be scoring in the next 6 months or so to replicate these findings. And these are not patients from a sleep center. These are patients from my memory clinic, mostly. Okay, so this is fun and messy, and I wasn't going to show this, but I thought it's important because it shows that with hours spent in REM, there is some variability from baseline to 6 months to 12 months. So this is one of the few longitudinal studies of DLB with sleep. And I think we were able to do it because this is in home, and patients were fairly cooperative and willing to do it. But overall, you still see that that low number of hours spent in REM is pretty consistently low across time, the 1 year. And whereas the AD patients, their mean number of hours spent in REM is fairly consistent over time, even though we still some bouncing around. And these were statistically significant at between groups at all time points. So sleep neurobiology went through this yesterday too, but that there's solid lines in the brainstem depict pathways that are active during REM, and dashed line depicts pathways that are inactive during REM. And we could speculate and hypothesize that these are the areas that are mostly involved in DLB, and that's maybe simplistically, I mean, there's a lot of people doing different kind of animal work to study the mechanisms. Okay, so now next we move to remote monitoring using medical grade actigraphy. And this is a watch, much like our iWatches, but they don't have tell time, but they're triaxial, and they could detect subtle functional declines in walking pace, number of steps, distance covered, day-night reversal. And we had our subjects wear these for 2 consecutive weeks during day and night for every 6 months. And before we started, while we're waiting to collect data, we accessed the publicly available database in a nationwide representative sample called the NHATS. And we obtained actigraphy data for 104 dementia patients, and no dementia, 634 subjects with actigraphy data. And as you can see there, so the blue area is the no dementia subjects with a 95% confidence interval around the dotted lines. And the orangish is the dementia patients. So what we saw is an expected age-related decline. So older NHADS participants with and without dementia were less active than their younger counterparts. So I'd like to just mention you should go out for a walk, all right, during lunch to keep active. So, and the negative association, you could see the slope is more gradual for NHADS participant with dementia than those without dementia. But physical activity might decline precipitously prior to the onset of dementia and remain low at all ages after onset. So this then helped us to consider that we might want to be we're not doing this yet, but we are trying to target MCI subjects who might be converting to DLB, and they need to have another symptom. And after this conference too, I started thinking if they have Parkinsonian and smell deficits, hypoxia, or if they have another symptom, maybe those are the patients that will be in the conversion zone. So then this is now going back to the TED study. We found that DLB subjects had a smaller or lower number of daily activity counts compared to our AD subjects. And as you can see, there's people who were very high in their daily activity counts, and then we have people who are very, very low in their daily activity counts. And then again, looking at longitudinal findings over 12 months, DLB subjects consistently are lower compared to AD subjects. But again, you see this, the red dots on the left, which are the DLB at baseline, extremely variable in their activity counts. And then, thanks to tennis, we have the male fluctuation scale, and we compared it in male fluctuation with physical activity, with activity counts. And what we saw is, let's go through this first. The left side panel are AD subjects, and only 2 of those were considered fluctuators. Okay, so the bottom is yes or no fluctuation or not. So fluctuators are 2 out of 4 positive on the male fluctuation scale. So you see on the left panel, 2 of those were fluctuators. On the right panel are DLB subjects, and a majority of our DLB subjects are fluctuators. And that's no surprising given that that's in the diagnostic criteria. So it's circular, but we looked at the physical activity. And as you could see, the right hand, the DLB subjects, the fluctuator had lower activity counts compared to the non-fluctuators in DLB. So it might be capturing fluctuation as well as an objective measure. And we put in a R01 to hopefully study this further. And then, of course, we engaged our participants in traditional neuropsych measures, and we chose the R bands because we were able to give those every 6 months. And these are the domains covered. And I just want to show you a baseline between actigraphy and neurocognitive domains. We had predicted that higher physical activity was going to be associated with higher neurocognitive domain. And we did not see that except for the visual spatial, the pointer here, the visual spatial domain in the AD subjects. So that was the only group that had a positive correlation with physical activity. And this is baseline and observational study. We're not talking about interventional studies. So obviously we have to get more data to look at this. But these are the 2 last with the fluctuation as well as this one are preliminary data for us to do more studies to look at these. And I really think that actigraphy and these sleep monitoring devices are well tolerated in patients with dementia, and they can reliably collect valid activity and sleep data between clinic visits. And as I shown, participants with DLB had significant lower activity counts as measured by actigraphy at baseline, 6-month and 12-month than participants with AD. But they also had more variability in their activity counts. And participants with DLB were less or more likely to experience baseline 6-month and 12-month sleep disturbances as measured by the sleep profiler, with fewer hours in REM and more hours in non-REM hypertonia. And so we are advancing forward in our R33 right now to get a larger sample size. And we are also started recruiting with Cleveland Clinic participating now to recruit subjects with MCI. So passive monitoring studies still require the participation of caregivers. For example, the devices need charging and they need assistance in putting on these devices. So obviously the early ultimate goal is for early detection of dementia. And as we talk about early treatment with neuroprotective strategies, I think these type of passive monitoring devices could be helpful in future clinical trials. So these are my collaborators, and I thank the NIA for our R21, R33 funding, and the NINDS for the UL1 that funds the DLBC. And we also like to thank the Lewy Body Association in helping us to advertise. And of course, we're so grateful to the study participants and their caregivers that help make these studies possible. So thank you.
Find the next book. There we are. Okay. Good morning, everybody. Firstly, thanks to the organizers for putting together this great conference. I'm going to talk about fluid and skin biomarkers for alpha-synuclein and talk about the potential interactions between Alzheimer's and DLB pathology. There are many other things that could interact with DLB. We've heard about vascular disease and TDP-43. At the moment, we don't have skin or fluid biomarkers for those, so I'll focus on what we do know. These are my disclosures. And we've heard a lot about staging for alpha-synuclein pathology yesterday from the neuropathologists, where there may be slight differences in how PD spreads versus DLB. There might be some semantic arguments about this. We've heard cases for and against, and at the moment we don't have a biomarker that actually allows us to determine what is spreading or how. Maybe imaging will come to the rescue. If we think about some interactions with Alzheimer co-pathology and Lewy body disease, this is an interesting, recent and very provocative paper from Tom Beach and his group. And they've analyzed a large number of patients who have clinical characterization and then autopsy determination. And within this group, you can see the characteristics with regards to age and different clinical diagnoses at the table in the top. They looked at what factors predicted any kind of alpha-synuclein pathology. And obviously, you'd think if you have Parkinson's disease, you're going to have a strong prediction. So age was a little bit of a predictor, but that's it could have been stronger if the cohort was a bit different. Sex, there was a male predominance. ApoE4, there is a risk factor, but people who had a high degree of plaque and tangle pathology, in particular plaque pathology, had a statistically significant prediction of any alpha-synuclein pathology, and this survived in multivariate analyses. When they looked at prediction of neocortical alpha-synuclein pathology in Parkinson's disease, so this might be PD dementia or DLB, depending on the timing of onset, the strongest predictors were both plaque scores greater than 5 or tangle scores greater than 5, and other predictors kind of dropped out by the wayside. So one conclusion they suggested was that Alzheimer's disease might be driving the presence and accumulation of synuclein pathology to some extent. And so that's kind of provocative, but something we can think about and may be able to try and characterize and test. If we think about Alzheimer co-pathology and how it impacts Parkinson's and DLB, sometimes we see these in a fairly pure form, sometimes we see these mixed. In PD, AD co-pathology is associated with older age of onset. somewhat greater likelihood of the postural instability gait disorder phenotype, worse cognitive decline, faster time to develop dementia, and cognitive deficits more likely in domains of naming and episodic memory. Within DLB, the more AD pathology there seems to be a lower likelihood of hallucinations or fluctuations. There are additional, again, cognitive deficits in naming and episodic memory and faster progression. And there are a host of studies, almost too many to fit into the slides, that support these contentions. So if we were going to try and bring a bunch of this neuropathological stuff to life, it would be great if we had biomarkers to improve diagnostic accuracy. And so what has transformed how we think about synucleinopathies are alpha-synuclein seeding amplification assays. I think probably everybody in the room is familiar with them, but the general principle is that whatever sample is going to be tested is added to a microplate. If the sample contains pathogenic seeds, then a bunch of normal wild-type alpha-synuclein fuel is added. The mixture is shaken, kind of like a James Bond cocktail, shaken and stirred, and then allowed to relax. The seeds collide with the fuel and corrupt some of the fuel to make new seeds and new aggregates. They go through repeated cycles where they keep on corrupting more of the normal synuclein. They form little fibrils that fragment and break off. And over time, these things take on an amyloid configuration. Thioflavin is a dye, a fluorescent dye that binds to amyloid, and it's added to the microplates. And over time, fluorescence is measured, and you end up with a curve, as is shown at the bottom. And this idea actually came out of what was called RT-quick assays for prion proteins in Creutzfeldt-Jakob disease. So this is a summary. It's not complete, but these are a number of medium and large scale studies showing that CSF alpha-synuclein seeding amplification assays have very high sensitivity and specificity across a variety of Lewy body disorders. And you can see that this includes Parkinson's disease, DLB, REM sleep behavior disorder, primary autonomic failure, MSA, where there may be a different characteristic depending on the assay that's been set up. Some assays can detect MSA type seeds. And then early or de novo Parkinson's disease and REM sleep behavior disorders. And so far, the largest study to date was the PPMI study. And again, sensitivity and specificity above 90% in these studies. In the PPMI study, we found that there was a lower rate in people who were LRRK2 carriers, but we know from autopsy studies that some people with LRRK2 don't seem to show alpha-synuclein pathology. The alternative approach has been to look for abnormal forms of alpha-synuclein in skin biopsies. This is a sample from a study by Chris Givens and colleagues that have gone on to form the company CND, and they do immunofluorescence staining with a phosphoserine 129 antibody. They also stain the number of normal nerve fibers, and so they can quantify the amount of abnormal synuclein against a background of how many autonomic nerve fibers they are seeing. And by combining these two ratios, they actually are able, as was shown in the study, to distinguish MSA from Parkinson's disease, even though both have inclusions that, at least abnormal forms of synuclein that stain positive with PSER 129. And again, this is a selection of immunohistochemistry studies that have shown generally high sensitivity and specificity. To some extent, this depends on how many biopsies are done, where they're taken from, and what the procedures are to read the biopsy. Because Givens recently published a paper looking at PD-MSA and primary autonomic failure and showed remarkably high sensitivity and specificity. And we'll see if more data emerge from, there are ongoing studies of DLB and DLB-MCI from this group. There are some suggestions that the density of alpha-synuclein deposits may correlate to an extent with disease severity and duration of Parkinson's. So maybe there's something quantitative that can be assessed by the skin biopsies. And there's a different, as I mentioned, different density and distribution in PD or DLB relative to MSA. There are very few comparative studies that have looked at immunocytochemistry versus RT-QuIC on CSF versus actually doing RT-QuIC from the skin biopsy. This is one of the few that was published from an Italian group. And they found that they were more or less comparable. In fact, in their series, the skin immunohistochemistry performed slightly better than skin RT-QuIC or CSF RT-QuIC. We need more data that actually do involve head-to-head comparisons to be able to assess this, and in particular, to assess this in the earliest stages of disease possible, rather than looking at established patients with clinical diagnoses. So what are we actually measuring? What has a positive SAA test? So there are a number of different studies that have now commented on this. I was involved in two, the study from Arnold et al. And Hall et al. And in general, it seemed that the more restricted the Lewy bodies were, the less likely there was to be a positive SAA reaction. So in amygdala-limited pathology, there is some variation across studies. In our study, we found the lowest rate, 14%. The highest rate was in the Hall study, 64%, somewhere in that range. And we need to try and figure out why it is that not everybody who has amygdala antibodies releases seeds into amygdala synuclein deposits, releases seeds into their CSF. For limbic and neocortical, on the other hand, there's a much higher rate of positivity. For brainstem, interestingly, there is some variability. Some of the brainstem pathology in these studies were incidental Lewy body disease and not necessarily Parkinson's disease. So we need much more clinical autopsy correlation to really get an understanding of what's going on. So we do not know if a positive SAA test in CSF relates to an overall burden of synuclein pathology, whether there's some degree of accumulation within a vulnerable set of neurons that then results in release of seeds, whether there's some aspect of the aggregation of synuclein truncation, post-translation modifications, or whatever. And I think we're going to end up needing some kind of in vitro models to try and figure out that aspect. Turning to how we do in clinically diagnosed dementia with Lewy bodies, we earlier this year looked at data from the DLBC and from some samples that were available from a number of other U01s funded by the NINDS Parkinson's Disease Diagnostic Program. And in this study, we obtained 191 CSF samples from people with clinical diagnoses of DLB. A few had DLB MCI. We selected some cognitively normal controls and analytical or younger controls, and everything was run blindly by Amprion using their clinical assay. There is a fair amount of standardized clinical data. I've listed some of the rating scales here collected on patients. And we were able to try to derive the DLB core clinical features from these U01s by using the ratings and scales I've listed here. Having said that, there are some potential confounds with how we interpret these. Fluctuation as rated by the Mayo fluctuation scale, while it is increased in DLB, same sorts of symptoms can occur in Alzheimer's and in vascular cognitive impairment. Hallucinations can occur in other disorders and can occur in delirium. Parkinsonism, I think, is one of the most difficult things to rate in some of this type of patient cohort, in that the UPDRS3 instructions are to call it as you see it. And a few non-specific aspects of slowing and postural tremor and so forth are fairly common in older folks. So an exact cutoff for Parkinsonism can be quite tricky. REM sleep behavior disorder we assess through questionnaire and not through objective testing. So having said that, these were the characteristics of the cohort. The mean MoCA was 19.5. They had clear Parkinsonism. The UPDRS mean score was 31.5, and that was the prevalence of other core features, hallucinations, fluctuation, and so forth. We also had olfaction data on these folks, which turned out to be quite interesting. And we found an overall positivity rate of CSF synuclein seeding of 72%. So 28% disagreement with the clinical diagnosis. What could be going on? We tried to break this down by features that might differ between the positive and negative SAA subgroups. And in general, there were no obvious demographic differences, a very small degree of cognitive severity. The MoCA was a little bit lower in the positives versus the negatives. There was more Parkinsonism, but clearly if you look at the standard deviations, a lot of overlap in Parkinsonism and even in specific kinds of Parkinsonism. Maybe bradykinesia did a little better than rigidity or tremor, but a little bit more Parkinsonism, but some overlap. An increased history of RBD, although we did get a history of RBD type symptoms, at least by questionnaire, in the negatives, and not much difference in history of hallucinations or fluctuation. When we looked at olfaction, on the other hand, and we took either the total upset or we had normative data from the PPMI study on olfaction using the upset. When we looked at people who scored below the 15th percentile adjusted for age and sex, we found that there was a significantly higher representation of olfactory loss in people who tested positive versus negative. If we tried to look at numbers of different core features, there was a difference, but it seemed to be similar across however many core features we counted. There was no center difference, so every center got similar numbers of cases right and wrong. And the rates of, the rates of SAA positivity did not differ. So we were left with the notion that, in fact, the upset and testing olfaction turned out to be a useful additional feature in this cohort. And clearly, we need better ways to try and operationalize the regular core clinical features of DLB if we're going to try and match them up with SAA as a gold standard. So the second part, I'm going to cover how Alzheimer's disease pathology might interact with Lewy body pathology and take SAA in CSF as being an indicator of Lewy body pathology. And a couple of questions here are whether comorbid Alzheimer's changes some of the clinical features or the progression of DLB. I've sort of given this away earlier, but that was based on clinical or pathological studies. And then if you have a clinical diagnosis of along the Alzheimer's spectrum, if there is a positive SAA test in CSF, does this actually change some of the characteristics of what's going on in what looks like Alzheimer's disease? So looking at things first, and these are data that we haven't yet published, but have analyzed from the DLBC study. Unfortunately, we have limited cognitive longitudinal data. So this is a look at the MoCA. And in this study, we compared people who had positive AD defined by CSF biomarkers who are SAA plus, or negative AD biomarkers who are SAA plus. And there's a fair amount of scatter, but overall, there is significantly faster progression on the MoCA in people who are have the combination of AD and SAA plus versus SAA plus on its own. And when we looked at MoCA subscale scores, a number of subscales contribute, in particular fluency, which is only scored from 0 to 1, but nevertheless, it did jump out, abstraction and orientation. Clearly, we could do with more detailed cognitive profiling. We're trying to get a little bit more of this out of the study, but we won't have the ideal cognitive battery to study this. Other groups have looked at plasma biomarkers for Alzheimer's disease in people with clinically diagnosed DLB. And this is a study from a European consortium that was published a little earlier this year. They looked at a number of different biomarkers measured by the Quanterix platform. They looked at A-beta 42/40, which Quanterix is not a great assay for those particular markers. GFAP, neurofilament light, and p-tau 181 and 231. They didn't have an assay for 217. They found that NFL, p-tau, and GFAP were all increased in people who had AD plus DLB versus DLB on its own. And if you had this combination of, rather, if you had higher baseline p-tau 181 suggesting that's AD co-pathology, there was faster cognitive decline. There was also faster cognitive decline if there was a higher baseline plasma GFAP. GFAP seems to be more associated with AD co-pathology than with DLB. It certainly isn't increased in Parkinson's disease, for example. So this suggests that some peripheral markers related to AD pathology, these may not be the best yet, still do help to predict progression in DLB. The next series of studies look at what happens if you have a clinical diagnosis along the Alzheimer's spectrum, and in fact, a biomarker-proven diagnosis along the Alzheimer's spectrum. The first is an analysis of the ADNI data, where more than 1,600 people who had contributed CSF underwent SAA testing. There is certification of Alzheimer's pathology by either amyloid PET or CSF biomarkers. And so if one looked at what determined the rates of CSF positivity for alpha-synuclein, and remembering that ADNI has people who are cognitively normal, MCI, and Alzheimer's disease, it turned out that there was positivity that increased with age. Even in normals, there's a base rate, and this is an interesting phenomenon that we need to know more about. Are these people at risk for something happening to them over time? In MCI, the rate went up a little. It was in the 20% range. And in people who had AD with mild dementia, the rates of SA positivity went up as high as 39%. Does this matter, and does this make a difference? And this is a slightly busy slide, but this was a look at a number of different cognitive domain scores in ADNI, and a question about whether there are different rates of decline in people who have Alzheimer's disease with or without a positive SAA biomarker. Interestingly, the biggest effect seemed to be in the cognitively unimpaired, although there's a lot of variability. And there are effects on different cognitive domains in MCI and in Alzheimer's disease, but they vary across cognitive tests, suggesting that there is different sensitivity. Another large study that has done something similar is the Swedish Biofinder study. And there are two publications that were relevant here. Cross-sectionally, when they looked at a group of people with MCI and dementia, again, they could be verified as being MCI or dementia caused by AD, by biomarkers, or not caused by AD, and then with or without added alpha-synuclein pathology, certified by a positive seeding reaction. Those people who had Alzheimer's and SAA plus were associated with greater olfaction loss. They had an olfactory test built into their battery. Mild Parkinsonism, they did a Parkinson motor exam. And on their cognitive battery, they found that there was greater impairment on a number of different domains. But if you look at the graphs at the bottom, the last one on the right in figure D shows visuospatial tests. And there's a marked effect in the people who are AD plus, SAA plus, in the visuospatial domain compared to other kinds of tests. So it seems that having a combination of Alzheimer's disease and SAA plus does result in an alteration of the phenotype with some recognizable features and with worsening of progression overall. Again, there's a lot of variability, and it would be nice if we had quantitative markers of synuclein burden to be able to, or the impact of synuclein burden, to be able to try and chart this in a little bit more detail. So what can we do beyond doing lumbar punctures to try and determine whether people have synuclein pathology or not? So in terms of looking at seeding amplification assays, there's been a fair amount of work on skin biopsies. The findings are a little variable across studies. The low end seem to be close to 80% sensitivity. This is even in milder cases, versus a few publications that have approached 100% concordance with CSF SAA, even going early in RBD, and very high accuracy in a post-mortem skin study. I think we need to harmonize protocols for skin biopsies, where we take the biopsies from, how many biopsies, the conditions of storage, homogenization, and so forth. Some of those studies are underway, and it's hopeful that we will be able to come up with a universal skin protocol, for want of a better term for it, that might give us very similar accuracy to CSF. Nasal brushings have been studied since there's olfactory loss and some interest in trying to access markers related to olfactory neurons. An Italian group developed a technique that actually looks quite brutal if you look on YouTube. It looks a bit worse than the COVID brushings, but anyway, when they did theirs, they had a publication with an initial rate of only 44%. Saliva, a couple of people showed some proof of concept that one could do an SAA reaction on saliva. The most recent study I could find had positivity of about 76%, which wouldn't be too bad for a screening test, but we'd like to beat that with skin or other sources. What about blood, plasma, or serum? There have been a number of publications claiming positive results, and these are all very inconsistent. When I've spoken to other people who have tried to replicate, none of these have been replicated. There are studies where people have tried to immunoprecipitate and pull out seeds with antibodies, do multiple centrifugation steps, purify exosomes, and so forth. And so far, no two labs have come up with the same result. It doesn't mean it's impossible, but it seems that there are some interfering or inhibiting substances in plasma and maybe greater dilution of the seeds that make this very, very challenging. And this bullet may disappear next year for all we know, but for right now, this is where it stands. So to summarize, we've made a lot of progress. The CSF alpha-synuclein seeding tests are highly sensitive and specific for synuclein pathology. They're somewhat lower when we have amygdala-restricted cases. This positivity begins very early during prodromal stages of Parkinson's disease and dementia with Lewy bodies, and even in association with aging in a percentage of people. Skin histology seems to be probably as sensitive as CSF, although we need more data to definitely be able to make the claim. The co-occurrence of Alzheimer's disease pathology in people who have Lewy body disease is associated with faster progression. And if one has what looks like an AD phenotype, if one has a coexisting biomarker of synuclein, it seems to increase as cognitive decline worsens. So the rates are higher in dementia versus MCI, but it also is associated with faster cognitive decline and with at least some of the features, some Parkinsonism and so forth, that we would expect to see in DLB. So what are some of the opportunities thinking about this going forward? There are a lot of ongoing efforts to try and make SAA quantitative. A number of groups, I've worked with some of these, have tried to analyze kinetic aspects of these seeding reactions, and they give us maybe 5% more prediction, but they are not super quantitative at all. There's some efforts to come up with things like digital SAA reactions, something similar to the Quanterix type of procedure where a whole lot of microbeads are diluted into wells, and maybe something will happen there. There may be some new technology to try and come up with an estimate of how many seeds there are. We're going to see SAA in skin and hopefully some good news about blood. We are now seeing the opportunity to combine Alzheimer blood-based biomarkers in stages of prodromal dementia with Lewy bodies to help us with early diagnosis, staging, and prognosis. And we appreciate some of the proteomic talks yesterday that there are lots of other potential biomarkers to tell us more about biological processes. For example, GFAP, neurofilament light. I've shown some data about dopamine decarboxylase came up as a really interesting biomarker of presumably nigrostriatal dysfunction in a number of different studies. And we heard about a number of interesting biomarkers yesterday emerging through proteomics. And one thing we'd like to do or like to see happen as an immediate implication is, can we apply all of this to clinical trials? And one question is, will anti-amyloid immunotherapy impact progression in people who have this double combination of Alzheimer's and Lewy body dementia? I mean, another application could be if we were able to select people with pure Lewy body disease and we have an anti-synuclein therapy. Are there biomarkers we could use to try and indicate target engagement and some initial indices of improvement? So I think there are some exciting opportunities ahead. And I'd like to thank a number of people who have collaborated, made studies possible, funded studies, helped us to identify participants and get the word out. So thank you very much for your attention.
So thank you, Doug, for a great introduction on SAA assays. And I wholly agree that there's so much to be learned about these proteins in these settings and as it relates to biomarkers. And I think a lot of this can be sorted out with application still in brain. So for the purposes of my talk today, I'm really going to focus on work that we've done looking at tau and alpha-synuclein seeding and Lewy body and Alzheimer's disease. And so for over a decade, my research has really been focused on understanding these corrupted protein shapes that we see in neurodegenerative disease and the when, where, and how they become related with disease processes in the brain. So we don't understand why the shape corruption happens in the first place, but we have certainly, and in recent years, begun to appreciate the shapes that these proteins can take, with an example shown here. This is the case of a prion, but shown tethered to that cell. So we see these striking, ladder-like arrangements of these misfolded proteins that go on to accumulate in the brain in larger assemblies, as you can see here in the middle, and as can be marked with histologic techniques. And so, everyone in this room is aware of the challenges here in detecting corrupted proteins to help diagnose and prevent neurodegenerative diseases. In trying to address these challenges, how do we look at the brain and biological biomarkers of what is going on that is characteristic of these disease processes? We know that different neurodegenerative diseases have overlapping clinical symptoms. And so how do we definitively identify which disease a patient has? And how do we follow patients and identify them for clinical trials as it relates to the corrupted proteins specifically? And so this is why we study corrupted proteins. We know that these disease processes occur decades prior to clinical signs, and the corrupted proteins are implicated at the earliest stages. And definitionally, they really indicate the type of disease that might be found in the brain. And so as we look to address and overcome these clinical challenges, we can study these corrupted proteins and use assays that, as Doug described, really exploit this propagation capacity to measure specific forms. And so with recent cryo-EM structures, we've now learned that different corrupted protein shapes occur in Lewy body disease and Alzheimer's versus other diseases. And so in the case of Lewy body disease, and very interestingly, we have a shared cryo-EM, at least core structure, as is indicated for DLB and PD. But this is distinct from other structures of tau or alpha-synuclein structures in the case of multiple system atrophy. However, how one structure fully encompasses the clinical heterogeneity that we observe in Lewy body and Alzheimer's disease is less clear, and as an important consideration for future research studies. So really understanding the biochemical features as they relate to mixed pathologies, I think is really important as we define these processes in the brain. And so broadly, and I just wanted to highlight some aspects of amyloids and as they would relate across these different corrupted protein shapes. So we know that amyloid accumulation is characteristic of neurodegenerative diseases, and they have these disease-specific and stereotypical accumulation patterns that I think was discussed probably at length in the sessions yesterday. And so we know that, here is an example of a single protofilament of an amyloid with that three-dimensional architecture. But we know that amyloids can also assemble into these larger multimeric deposits like amyloid plaques, neurofibrillar tangles. What has also been identified is there can be auxiliary associated non-proteinaceous cofactors associated with and have been identified for tau, alpha-synuclein, and prion-based amyloids. We also know that they can co-occur in the brain and in some occasions proximal to other amyloids. What are the biochemical features when we think about this? Now, it's these structures and the propagation thereof that really forms the basis of the hypothesis of protein-based templated propagation, whereby that monomer is stacked on these fibrillar shapes, the shape is corrupted, and we get extension of these amyloid fibrils to lead to these characteristic 3D architectures that have been identified via cryo-EM. Also note that these structures harbor the characteristic post-translational modifications that can be identifiable of different protein forms as they relate to disease processes. And this has been used to propose really the structural basis of disease that I highlighted with those cryo-EM structures. However, just because an amyloid can be formed does not necessarily mean it poses a hazard to its host. And this is a slide I like to come back to because I think this concept is really important. We have examples in biology of functional amyloid formation. And so biochemically, these are likely different, but formation of these amyloids actually confers a physiologic benefit to the host. Now, this is in contrast to amyloids we understand in the case of neurodegenerative settings, where they're certainly, pathogenic within that. What still remains largely unclear is the extent to which amyloids populate along this spectrum. And I think this is really important as we consider relevance of structures that are found in the absence of disease, including, an early accumulation of these corrupted proteins in the brain. And so as we consider these structures and this amyloid spectrum, when do self-propagating proteins really become associated with clinical disease? Can one structure explain this clinical and neuropathologic disease heterogeneity? And what are the implications of these mixed pathologies with more than one misfolded protein? And I think with application of amplification assays, we can really sort out the biochemistry and as it will inform biomarker studies. And so specifically, what I'll focus on today is how these co-occurring protein seed pathologies correspond with or contribute to neuropathologic and clinical outcomes. And so Doug's already gone through the premise of, these seed amplification assays or RT-QuIC, whereby you have a reaction mixture and you can exploit this property of protein-based propagation with shaking cycles and incubation over time. But what I do want to note is with application of these assays to brain tissue, we are able to semi-quantitate seeds. So using endpoint dilution analysis, we're able to calculate seeding doses in the brain. And as it relates, this may inform how we turn SAA into more quantitative approaches. And so Doug's already highlighted, seed amplification assays in synucleinopathies. And so I won't go through this again, but the sensitivity of these assays is allowing us to look at stages such as RBD cases as indicative of prodromal synucleinopathy, and as well as look at these mixed pathologies to better understand how seeds mark different diseases. Apologies. So as it relates to tau-based seed amplification assays, I do want to note a few examples, and these have been developed for application primarily to brain tissue at this juncture. But we do have platforms where we can detect and differentiate free repeat tau seeding activity, as it would be indicative of 3R tauopathy, from that of 3 or 4R tau seeding activity of AD, CTE, and also primary age-related tauopathy. We can also look at 4R seeding activity as it would relate to 4R tauopathies. And additional features of these assays are the ability to indicate PSP from CBD based on amplitude readouts of these RT-QuIC assays. And so there's been some early reports of detection of 4R tau seeding activity that might be detected in skin punch, although I think early days and this needs to be confirmed and with additional studies. And so last year, we published a study looking at 3R, 4R, and alpha-synuclein seeds in the frontal lobe of AD and non-AD cases across different Brock stages. We use the semi-quantitative endpoint dilution analysis approach to estimate seeding doses, looking at Alzheimer's disease, but also Lewy body disease, inclusive of cases with a dementia with Lewy bodies in life. We also looked at 4R tauopathy compared to controls of Brock stage 2 or less. Now, what we observed is that 3R, 4R tau seeding activities are at much higher levels, logarithmic, 1,000-fold more in AD, and this is concordant with other studies looking at seeding doses in Alzheimer's. However, we do know that we saw significant seeding activity in the case of the Lewy body disease cases, and this is 3R, 4R tau seeding activity, 4R tauopathy, as well as controls. Now, this is in frontal lobe tissue, so we wanted to look at the relationship of these seeds to the overall histologic Brock staging in the brain. So we saw that higher seeding doses corresponded with higher Brock staging of disease. However, we were able to observe seeding activity that occurred at lower Brock stages of disease, including in some examples in the absence of overt neuropathology. And so I think this speaks to the sensitivity that can be achieved with these assays and to map seeds in the absence of neuropathology or as they might precede this pathology. Now, when we incorporate measures of A beta with overall AD neuropathologic change, again, we see that these 3 or 4 tau seeding activities correspond with overall change, again, consistent with an AD diagnosis. But again, we are able to observe seeding activity, albeit at logarithmic lower levels in the absence of AD neuropathologic change. And so my group has a fundamental interest in understanding what the biochemistry of these really early seeds might represent. Again, the sensitivity of these assays has allowed us to explore this more extensively. And so such techniques that you might use and are commonly used in the field are looking at measures of sarcosylin solubility or protease resistant as indicative of to what degree are those early seeds structured. And so that we saw that tau seeds that occur both early and late stages of accumulation are largely protease resistant and sarcosylin soluble. And so, the goal in a lot of our work is where do these distinct protein seeds and protein seed networks intersect? How does this relate to neuropathology and disease? Again, what are the biochemical features of early versus late diseases? Do they differ in mixed pathologies as it would relate to detection in diagnostically relevant tissues and as well as clinical outcome? And so given the prevalence with which we observe tau seeds in Lewy body disease, we've since expanded our study to consider tau and alpha-synuclein seeding activities across different stages of low and high Alzheimer's disease neuropathologic change, and also primary age-related tauopathy. And so Art provided an example of a pathology with comparatively mild absent clinical signs and cognitive impairment, but accumulation of tau tangles comparable to early stages of AD. And so as Pathologically part is defined by the structurally comparable 3R, 4R fibular tangles in the absence of significant A beta. This provides a tau comparison group without A beta. So we looked at a total of 77 cases, 20 Lewy body disease, 19 part, and 30 AD neuropathologic change that were further divided into 25 low and 13 high cases. So what we observed is that we were able to detect alpha-synuclein seeds. And again, this is in a cortical tissue, both at neocortical, but also limbic stages of disease as representative of the subcortical phase of Lewy pathology. We did also observe alpha-synuclein seeds in the absence of Lewy body pathology, again, albeit at much lower levels. So we have the semi-quantitative readout of the different levels of seeds that we can detect. We expanded our study to include 4 additional cases of amygdala predominant Lewy body stage. Again, looking at midfrontal cortex, we were able to detect some, although much less alpha-synuclein seeding activity in these cases. And so when you look at this summarized across the cases, we see that alpha-synuclein seeding activity, again, is detectable in the absence of overt neuropathology, but also it co-occurs and in line with the pathology frequently in frontal cortex of AD and C and part cases. And so the positivity is shown here on the left across those different cases. And so while we detect different levels of alpha-synuclein seeding activity across these cases, and in ways we continue to be examine how this relates to pathology of the disease, we do see this prevalence of seeding activity. So again, tau and alpha-synuclein seeds, both are detectable prior to overt neuropathology and prevalently occur across neurodegenerative disease. But we were able, in our measurement of both, to look at the relationship of the tau and alpha-synuclein seeding activities. And so markedly, and while controlling for Brock stage, we see this relationship between the seeding activities. Certainly limitations in the analysis being conducted here are that we're not looking at the spatial resolution of these co-occurring seeds. And so we continue to examine this and the relevance to pathologies and biomarker readouts. And so what I wanted to highlight here today is that these platforms and with application to brain can still help us define and in quantitative ways what the seeds that you'll then detect in these diagnostically relevant specimens look like in the brain and at earliest stages of disease. And so looking across the cases here, again, we have 100% detection of alpha-synuclein in a Lewy body disease case in frontal cortex, but we are able to measure co-occurring alpha-synuclein across AD and C and 4R tauopathy cases. Likewise, we see high levels of 3R, 4R tau seeding activity in AD and C, but also frequent co-occurrence, at least in the aged cases we've looked at here. 4R tauopathy marks, or 4R tau seeds mark 4R tauopathy, and we are able to detect some of these co-occurring proteins. And so here is just some example of some of our unpublished data in the lab. And this is really only to make the point that I think it's so important to continue to do this work to define the biochemical features of these seeds and these structures as they occur in the brain across stages of disease and the relationship as this has to biofluid or peripheral biomarkers. And if we can then apply these quantitative approaches, that would be important to define these processes. And so in summary, we've observed in brain tissue, and again, concordant with other studies looking at tau seeding in the brain, that these occur broadly across neurodegenerative diseases, including Lewy body disease. We observe alpha-synuclein and tau seeding activities at 100% prevalence in Lewy body disease cases, although I think the amounts differ of the respective seeds and from co-occurrence and levels thereof in part or 4R tauopathies. And so this certainly suggests that the biochemical complexity of the seeding proteoforms differs in these distinct clinical pathologic microenvironments. And so what does this mean for the prognosis of disease? Why can we detect some amygdala predominant cases with SAA and CSF, but others not? And so better defining this in the brain, I think is very important. And so with that, big thank you to my lab who really enjoys doing these assays and understanding the biochemistry, and collaborators, including those highlighted here, provide the neuropathologic and clinical expertise that allows us to layer these types of studies onto relevant cases.
Hello, everyone. I just want to start by thanking Nina and Deb for organizing this excellent conference. And I will start us off with imaging sessions. There will be 3 more imaging sessions after this. And I'm going to focus on what we can do with imaging to fill the gaps for drug development and clinical trials. So I will focus on 2 critical gaps where I think imaging would be really useful. One of them is biologic characterization, and there has been several papers coming out in this area, and imaging is playing a central role in biologic characterization, as well as biofluid biomarkers. And development of disease-modifying therapies really needs good biologic characterization to apply the right drug at the right time to the right patient, as we discussed yesterday. And then imaging can also be useful in tracking disease progression, and which is really critical for drug development, because you need to know if the drug is working the way it's supposed to work, and you need smaller sample sizes where imaging would be really helpful compared to clinical outcomes, especially in the early stages, because that's when the disease-modifying treatments are most useful. So I think the most studied technique in dementia with Lewy bodies is structural MRI. There has been many studies very early on in early 2000s demonstrating that hippocampus is spared in dementia with Lewy bodies, and that's part of the criteria now as a biomarker in the 4th consortium criteria. But we have been also doing some work in the prodromal DLB phase, as I said, is really important for early interventions. And there has been others who have demonstrated insular atrophy in prodromal DLB, and also again, hippocampus sparing in prodromal DLB cases compared to prodromal AD. But I would like to point out this study where we demonstrated basal forebrain atrophy in prodromal DLB cases, the MCI Lewy body cases. And this is prevalent both in stable MCI Lewy bodies and progressor MCI Lewy bodies, those who progress to DLB. So it seems to be a very early structural change that we're observing in the brain. There are other regions involved, but the basal forebrain atrophy was the most prevalent if you look at the scans cross-sectionally. However, when you look at them longitudinally, there is a profound involvement across the brain, particularly involving the limbic regions. And even though we saw the basal forebrain atrophy cross-sectionally, it didn't hold longitudinally. So longitudinally, there was more cortical atrophy, but the basal forebrain atrophy longitudinally was not the most significant, which suggests that perhaps that atrophy has already occurred and perhaps maybe reaching a plateau when we look at the scans longitudinally. Now, this longitudinal pattern really suggests involvement of the cholinergic system. First of all, we have the basal forebrain atrophy cross-sectionally, which includes the nucleus basalis and the diagonal band where we see the cholinergic nuclei. And then longitudinally, we see this increased rates of atrophy across the limbic cortices or association regions that receive a lot of cholinergic input. So, so it suggests that, you know, this basal forebrain atrophy perhaps is influencing atrophy in other places across the brain that is innervated by cholinergic system. Now, these focal atrophy or focal involvement in dementia with Lewy bodies is also present in the brainstem in the substantia nigra. And one of the techniques that we can measure substantia nigra involvement is with quantitative susceptibility mapping, which shows us the iron accumulation in that region due to neurodegeneration. And this is a study by Shin et al., who was a fellow in my lab, who looked at isolated RBD, MCI, Lewy body, and probable DLB cases. As you can see, the susceptibility is increasing as the disease gets more severe. And this was also studied by Patricia Diaz-Galvan, looking at whether this holds pathologically. And she studied the autopsy-confirmed cases that have Lewy body disease present versus absent. At the top, you can see most of them are diffuse Lewy body disease cases. And on the right, you see the absent cases, which most of them are Alzheimer's disease. And when you look at these two groups, we also parcellated substantia nigra into pars compacta and pars reticulata regions. The pars compacta region is the region that contains the neurons that are involved in the dopaminergic system. And particularly in that region, we saw that susceptibility is significantly elevated in Lewy body positive cases, and it's correlated with the UPDRS scores. Another technique that has been very effective in detecting the involvement of the substantia nigra and other brainstem nuclei is neuromelanin sensitive MRI. And particularly in the pars compacta and locus coeruleus, these melanized neurons degenerate profoundly in synucleinopathies. And neuromelanin sensitive MRI generates this hyperintense signal in these nuclei. And with that signal, it's possible to estimate the volumes of the nuclei. And when this is data from Dan Huddleston from Emory, looking at IRBD, PD, and DLB cases and showing that it is this melanin imaging is demonstrating volume losses in the substantia nigra pars compacta and locus coeruleus as early as the isolated RBD stage. Okay, now I would like to switch gears to FDG PET. And this has also been studied a lot in the dementia with Lewy bodies. And this is one early publication from the Australian group, Chris Rowe's group, showing that there may be a specific pattern in dementia with Lewy bodies, which we call singlet island sign. Although the classic pattern of occipital hypometabolism has a high sensitivity to detect dementia with Lewy bodies changes, the singlet island sign, which is a relative preservation of the singlet gyrus metabolism with respect to what's around it, has the highest specificity in distinguishing DLB from Alzheimer's disease. So here's some data from our group looking at autopsy-confirmed DLB and AD. You can see the difference between the two scans with the singlet island signs showing up in DLB. And you can calculate a quantitative metric off of this by dividing posterior singlet FDG uptake to cuneus and precuneus FDG uptake, which gives us a singlet island sign ratio. And you can see it's pretty elevated in DLB compared to AD patients. And how about the prodromal stage? Can we see the singlet island sign in the MCI Lewy body cases? And these are both prodromal DLB and prodromal AD cases. And on the lower left-hand side, you see the singlet island sign ratio again being elevated at the prodromal stage. In the middle is the medial temporal lobe uptake. And you can see that, again, similar to what we see in MRI, the medial temporal lobe FDG is relatively preserved in MCI-DLB compared to MCI-AD. And then, interestingly, we also saw hypometabolism in the substantia nigra in MCI-DLB. And then the best metric that distinguished MCI-DLB and AD was the ratio of medial temporal lobe to substantia nigra. So that, because they go in opposite directions, taking that ratio really distinguished with 91% accuracy. And of course, FDG PET involves radioligand injection, and it's maybe less accessible than MRI. So we looked into perfusion imaging to see whether FDG PET and perfusion imaging can show us similar results. And this is work by Susanna Nedelska, showing that the pattern of ASL hypoperfusion really is very similar to what we see in FDG PET. And how about the singlet island sign? Well, you can visually see the singlet island sign in perfusion imaging, and that's in the middle, the same patient showing the singlet island sign with perfusion and FDG. And when you look at the correlation between the two, when you look at the quantitative ratio, well, there's a really nice correlation. So even though in our calculations, the accuracy was not as high as FDG PET for looking at hypoperfusion, it still can be a good screening approach when we are doing, MRI anyways. We could perhaps also look at the cerebral perfusion maps to visualize singlet island sign. Now, if we go even earlier to isolated RBD, the picture is a little more complicated. So this is isolated RBD cases compared to controls for FDG PET. In the blue areas, you see hypometabolism. So these are areas that are frequently affected in the prodromal stages, the retrosplenial cortex, substantia nigra, angular cortex. So these are the regions that we saw are affected in MCI Lewy body cases as well. But then we also saw hypermetabolism in the amygdala. And that was interesting because, we know amygdala is significantly affected by Lewy body disease. So there can be possible explanations that we still need to understand better. For example, lack of inhibitory input on amygdala, hyperexcitability because of that, maybe a compensatory mechanism, or possibly microglial activation, which was shown to influence FDG PET signal in Alzheimer's disease models. So potentially, perhaps that may be contributing. Now, FDG PET does change longitudinally in dementia with Lewy bodies and also at the prodromal stages. So on the left-hand side, and this is work by Danny Ferreira that is not published yet. On the left side, you see the longitudinal change in MCI Lewy body in blue, and then in the orange and red colors, the change in DLB. Obviously, it's more profound in DLB patients, but it does start changing as early as the MCI Lewy body stage. We created this longitudinal FDG meta ROI, as you can see on the top right-hand corner, which tells us the best, the most significant rates of change in both MCI and DLB patients. So the change is occurring very early on in these regions on FDG PET. And it's different from controls, as you can see from the lines, both in MCI and DLB cases, and it correlates with clinical disease progression when we look at CDR sum of boxes. Now, we also calculated the sample size estimates for a hypothetical clinical trial in DLB. As I mentioned, maybe their imaging biomarkers can help us work with smaller sample sizes to demonstrate efficacy. And nonetheless, actually, FDG can give us about half the sample size we need to determine efficacy with 25% or 50% efficacy in perhaps even shorter periods of time. Now, there is pathologic heterogeneity in DLB, as we have been talking about since yesterday. And we have the tools with imaging to measure amyloid and tau deposition. And on the right, you see data from European DLB Consortium and Mayo Clinic data combined in a large sample. And about maybe more than 50% of patients are amyloid positive. Tau positivity is quite prevalent as well. About a third of them are tau positive, and only 39% are negative for both amyloid and tau. So it's a very important imaging biomarker we need to work with. And there is a good pathologic, very strong pathologic correlation between what we measure with amyloid imaging and what is present as amyloid density. And when we look at the tau phase and in patients with a spectrum of Lewy body disease and also Alzheimer's, a few patients with Alzheimer's we had to include just to make sure we have the reference points. And you can see there's a good correlation with tau phase as well. Now, in this study, because we have been seeing diffuse plaques a lot, Dennis Dixon always tells us that diffuse plaques are more prevalent in dementia with Lewy bodies, as well as Melissa here. We wanted to look at whether diffuse plaques or neuritic plaques are contributing most of the amyloid signal we're seeing in dementia with Lewy bodies. And this study, we had pathology data in those patients who underwent amyloid imaging. And we included both neuritic and diffuse plaques in the same model to detect whether either one of them are contributing. We also looked at their interaction, but it seems like diffuse plaques are the major contributors of global cortical PIB uptake in this case in patients with both Lewy body disease and mixed Alzheimer's and Lewy body disease. Now, amyloid retention is important, and it's also associated with clinical disease progression on CDR sum of boxes, and also longitudinal rates of atrophy. So the more amyloid someone has, they will have more neurodegeneration down the road. And amyloid deposition also occurs as early as the MCI Lewy body stage. This is a study looking at different groups of patients with isolated RBD, MCI, and DLB. And as you can see, the amyloid positivity is increasing as the disease is becoming more severe. And amyloid also is higher in women than men across all ages, and also higher in those who have APOE4 positivity. There is longitudinal change in amyloid over time in DLB patients, and this is the curve we came up with when we looked at amyloid deposition longitudinally, and which was also associated with clinical decline. And when we compare these curves with what was published in the Alzheimer's spectrum, the Villamagna study was mostly normal controls. The JACC study was more Alzheimer's and normal controls. So in the JACC study, you can see the amyloid levels are going up to almost 3 SUVR. In the DLB study, the amyloid levels are stopping around 2.3 or so. So we don't have the representation of very high amyloid levels in DLB patients. Therefore, we probably are not seeing that plateau at the end that is present in the Alzheimer's group. Now, again, the sample sizes are much lower for if we use amyloid imaging to detect change over time versus clinical measures. And it's important for the designing of clinical trials. And how about tau? Well, tau is present much less in DLB compared to amyloid, but it is there. And the distribution is interesting in that it spares the hippocampus. So medial temporal lobe is not involved with tau pathology in DLB as measured with tau imaging. And you can see on the left that DLB patients have higher temporoparietal and occipital tau, but not medial temporal tau on the right. In fact, you can distinguish Alzheimer's and DLB patients almost fully if you look at medial temporal tau deposition. Now, these are a couple of other studies that looked at tau distribution in PDD, DLB. And you can see that on the left, Gompertz showed a similar pattern involving the inferior temporal cortex, but not so significantly in the medial temporal lobe. And then Mack et al. Also showed that medial temporal lobe uptake distinguished DLB and AD groups pretty effectively. Now, longitudinally, tau increases over time in DLB, and it kind of overlaps with the regions where we see gray matter atrophy. So the gray matter atrophy mostly is present in the inferior temporal, parietal, and occipital cortices, and that's where we see also tau deposition. And in the middle, the figure is showing the correlation, region by region correlation between tau deposition and gray matter atrophy, which suggests that, in fact, tau may be contributing to gray matter atrophy in DLB. And this also correlates with the clinical progression of the disease. Now, final words on imaging biomarkers for alpha-synuclein PET radioligands. We're really waiting for Dr. Mack's talk on this, and it's really exciting us because this will for imaging in dementia with Lewy bodies. However, it has been quite difficult, and you will hear about this in the next talk. Probably I won't go into it more. So some of the gaps we talked about, I think we have enough data to say that multimodality imaging is really critical in DLB because of the multiple etiologies contributing to the clinical syndrome. And AD biomarker positivity, knowing about it is also important. And we see greater rates of atrophy, faster progression, lower survival in those patients who have AD biomarkers. And both MRI and FDG PET show abnormalities as early as the prodromal IRBD phase. So there's great potential for those biomarkers as well for the temporal evolution of Lewy body pathology. And what are some of the opportunities that we still need to work on? Of course, radioligand development for alpha-synuclein, and knowing the presence, topographic presence of alpha-synuclein will enable us to design clinical trials to and also understand topographic interactions between different proteins, because we can image tau and amyloid, but not alpha-synuclein at the moment. And amyloid PET is critical for refining the cohorts with target pathology, evaluating target engagement and efficacy if we are to employ amyloid modifying clinical trials in Lewy bodies dementia.
Question it again.
Really?
Yeah, I just wasn't sure, so maybe she's unaware.
Right, so we will need somebody to be able to put in petty cash.
The longitudinal neuroimaging with MRI and PET, I think these are critical for quantitative outcomes. And finally is my last slide on thanking my colleagues in NIH for funding our studies.
Okay. Well, I'd like to begin by thanking the organizers for inviting me to speak here today. I think this has been a really outstanding workshop. I've learned a lot, and when I go back to Philadelphia, I'm gonna have a whole different perspective of dementia with Lewy bodies than I had when I arrived. But what my talk is going to focus on today is a topic that has come up more than one time over the past 2 days. It came up in the past 2 minutes. It's the development of PET radio tracers for imaging alpha-synuclein. I'm also going to talk about our tau PET radio tracer development and how we use computational chemistry to basically identify lead compounds for tracer development. And then I'm going to walk you through the steps we take in going from a structure on a computer screen up to making decisions for our first in human studies that we're doing. And this work I'm going to present is funded through a U19 center from the NINDS and NIA. It's a center. The participants are shown on this slide. And these are the participants for the first round of funding. It's kind of contracted a little in the competing renewal, but the work I'm going to present today really has been a team effort of all the people shown on this slide, all the institutions shown on this slide. So I'll start with alpha-synuclein. There are 2 strategies we've used for identifying PET tracers for alpha-synuclein. Strategy 1 on the left is a straightforward SAR study I'll go into in a minute. And strategy 2 on the right is our computational work, which I'll spend more time discussing. But the strategy 1, this was our SAR studies. This was a study that was aimed to try to solve the problems with the radioligand shown at the top left, the BF2846. This compound was identified through the Michael J. Fox Alpha-Synuclein Imaging Consortium. It had a high affinity for alpha-synuclein fibrils. Its problem is it had a higher affinity for A beta. So it really didn't pan out, and we tried to, through the consortium, to dial out the A beta binding affinity, and it had very little success in doing that. But when I revisited this at the start of the U19, I looked at that structure and I thought we could probably make some progress by getting rid of that piperazine ring, that 2 nitrogen heterocycle in the middle. Let's see if this works, that ring, and replacing it with this granitane ring system. Piperazines are notorious for binding to a lot of different binding sites, and I thought that if we could replace that piperazine with this azagranitane here, this ring system, it might get rid of the A beta affinity. And that's exactly what happened. So it retained its affinity for alpha-synuclein, A beta dropped off, and we had a compound that bound the alpha-synuclein. Right, so we went to evaluate this compound. It had high affinity in the recombinant fibril assay, low affinity in the PIB counter screen, so they didn't bind to A beta. So the next step in the process, what we do is we radio label with carbon-11. And you may say, well, that's a little bit early in the game to look at PET imaging studies. But the reason why we do it so early is that if a PET tracer is going to work for imaging these proteinopathies, it has to have 2 features. It has to get in the brain, high brain uptake, and it has to have a rapid washout in a non-human primate so that you can see a good signal to noise ratio in these insoluble aggregates, which are likely going to be present in relatively low density in the brain. So we want a compound to get in the brain and wash out, and we like this peak the 60-minute ratio to be greater than 2.5. That's our go, no go criteria. And you can see this compound had a ratio of 3, so it met our go, no go criteria. The next thing we do is we label with tritium, and we do detailed in vitro binding studies. And the data on the right shows the in vitro binding studies of this at recombinant fibrils. You can see its affinity is around 4 nanomolar. In the Banner PD tissue, it's about the same, around 4 nanomolar. And MSA, similar, around 4 nanomolar. So this is a radioligand that binds the recombinant fibrils, and in tissue homogenates binds the PD brain and MSA brain. That's interesting. Now it gets even more interesting. And this is a perfect example of all the twists and turns we encounter in trying to develop an alpha-synuclein ligand. Because when you then take this radioligand and you look at it in postmortem tissue sections, you can see it binds very well to MSA brain, but it does not bind to PD, PDD, DLB. And so all the Lewy body-like pathology, it does not bind, but it binds to the GCIs and MSA brain. So this ligand which looked very good for binding both PD and MSA and tissue homogeneous, in autoradiography appears to be referring to the MSA-like pathology. Okay? So that's the first ligand. I'll come back to this in a minute, is why I chose this. So the next one is this second method we use, which is an in silico method. And it's called the exemplar method. Now, this is I think it's a really neat method. And let me just walk you through this. So what we did is we took a structure of alpha-synuclein. And at that time, the only structure we had to work with was the Reams or a solid state NMR structure. And we looked at potential binding sites for small molecules in this structure. And we focused on this one, site 9. And site 9 is shown here. I can't remember the exact amino acids that involve site 9, but this is a pocket in the alpha-synuclein fibrils that small molecules can bind to. So we wanted to develop and find a ligand that would bind to this pocket. And the method we use is called the exemplar method. And that's shown here. And you can see the little balls. Let me explain to you what the balls are. The balls are carbon balls, hydrogen bond donors, and hydrogen bond acceptors. So if you look at that pocket where a small molecule can bind, and then you pack that space with these little 1 angstrom balls, what you generate is called an exemplar. And you pull that exemplar out. And what that is a pseudostructure of a small molecule that should bind to that binding site with high affinity. So we generate this exemplar, we pull it out, and then we do this in silico screen. The 40 to 50 million compounds I showed on the previous slide were actually converted to 3.2 billion low energy conformers, so we could do a 3-dimensional search of it. So we go to this large database and we look for small molecules that look like our exemplar. So we find the small molecules, you get millions of in silico hits, and then you're struck with, now we have to narrow this down to something manageable. So we run this through a series of molecular filters, and we do what you heard Dr. Murray mention, just principal component, k-means clustering and principal component analysis, visual inspection. And we take this very large number of compounds and we narrow it down to something manageable, a couple hundred compounds that we can then buy and then run it through a high throughput screen set up in my lab. And that's shown here in this heat map. Here are the panel of compounds that we screened. And this compound came out as M503. It looked interesting. So we took M503, we put it through the competition curve, it had an affinity around 5 nanomolar, did not bind to 8 beta in the PIB counter screen. So it looked like a good candidate to advance. Again, the next thing we did, we labeled it with carbon 11. It has high brain uptake, rapid washout, ratio 2 minute to 60 minute, 3.2. So it met our go no go criteria. And then we labeled that with tritium. And we looked at it in fibrils, 4 nanomolar. We looked at it in the banded tissue, affinity drop to 12 nanomolar. And it also, I didn't include the graph for it, but because it was noisy, but it also binds the MSA tissue. All right, so this looks, again, a promising candidate. How does it look in tissue sections? In the tissue sections, it looks great. You can see it does not bind to MSA, but it does bind the PD, the PDD, and for this audience, Dementia with Lewy bodies, the LB brain actually binds very well, and that's controlled. And you see the binding of the ligand actually tracks quite nicely the alpha-synuclein pathology that we see in the antibody studies. So this ligand now actually looks pretty promising because it in autoradiography studies, it looks like it's going to be able to label and image Lewy body-like pathology, but it doesn't label the GCIs in MSA brain, right? So now we have 2 compounds, one for MSA, one for PD. Now, one of the things we do, and this topic, this is probably one of the most difficult targets PET radiochemists have ever gone after. And people have been trying to develop PET probes for well over 10 years, including me and including my lab. And one of the things that we've encountered in my years of doing this is that the data you get is very, very confusing. It can be quite confusing at times. And we're often asking ourselves, is this real or not? And one of the nice things that the U19 enables us to do is we have the resources now to basically cross-validate everything. So if I see a ligand that looked good in my assay, I send it to Chet Mathis in Pittsburgh, who had radioligand binding assay set up. I said, Chet, run it in your assay, because he does his assays a little different from how we do our assays. And Chet would run it, and if he gets similar results than I do, that's good. Another thing we do is I showed you autoradiography data. I sent the ligands to Paul Kotzbauer's lab at WashU, and I asked him to do autoradiography studies. And you can see he does it a little bit different. He does nuclear emulsion autoradiography. And sure enough, he found that HY215 binds to alpha-synuclein and MSA. This is the antibody labeling. It binds very weakly to the Lewy bodies in Parkinson's disease, whereas M503 has a reverse specificity. It binds to the Lewy bodies in PD and binds weakly to the GCIs and MSA. So based on the results that my lab got with Chet's binding assays and with Paul's autoradiography, everything was consistent. So these look like good candidates to advance forward. And that's what we've done. Now, one of the things that we wanted to do is we're really focusing on the Lewy body pathology in Parkinson's disease. And it's clear the fibrils, the recombinant fibrils, are a good tool for doing high throughput screening and identifying leads, but they're not really going to provide us a lot of information as to how well something is going to work in PD brain and Lewy body-like pathology. So the next thing we did is we said, can we actually come up with a disease? And what Paul Kotzbauer has done through his U01 grant is he's been looking at the synuclein seeding assay. So he's taken alpha-synuclein from PD brain and he's seeded it and he's generated fibrils from PD brain. And that structure is shown here. He just published it in Nature Communications earlier this year. And you can see that structure from PD brain is very different from what we were working with the Reemster structure from recombinant fibrils. You see, first of all, site 2 is a little different from the Reemster structure. Some of the amino acids along this face of the fibril here are now in site 2. So the amino acids in site 2 are different from what we were working with in the Reemster structure. But the biggest difference is in site 9. This is the Lewy fold that you heard about. Here's site 9, which is what we were going after. Site 9 is completely different in these PD-seeded fibrils. So the question we asked, and if you look at MSA, actually the structure of the fibrils, alpha-synuclein and MSA, is very similar to the Reemster structure. So we then took the Kotzbauer fibrils, and Paul sent us some from our lab. We want to see how well these fibrils can predict the behavior of our PET ligands. All right, so can these PD-seeded fibrils actually predict the binding of our radioligands to PD brain? That's the question we asked him with his fibrils. And lo and behold, here's the answer. So here, autoradiography, this is HY215, this is MSA brain, this is PD brain. You can see it binds very well to alpha-synuclein and MSA and not PD. When you look at the PD-seeded fibrils, noise, no binding whatsoever. We then took M503, here it is, autoradiography, see it binds very well in PD, does not bind to MSA, there's control brain, very nice binding in the PD-seeded fibrils. So this is important because we now have a fibril-based assay that we could use for screening compounds that should give us better compounds for imaging Lewy body-like pathology. So this really was an important step forward for our center because we now have a fibril-based assay we could do for screening compounds. And the reason why that's important is M503 is just the first ligand that we're taking in the humans, and we're doing first in human studies in it right now at Penn and at Yale. But I have 20 other compounds that look good in recombinant fibrils, and we can't do this for 20 compounds. We have to narrow it down. So how we're doing that is we're going to screen these in the PD-seeded fibrils, and we're going to look for compounds that have much higher affinity than what M503 has. And that's how our approach will be going forward. Okay. All right. The next method I'm going to talk about is a different in silico method. It's how we identified our 4R tau ligand. And every time I give this talk, I'm amazed this method actually worked. Okay. And the person who did this was Tom Graham, the brilliant medicinal chemist, was working in my lab, and he came up with this approach. And what he did is he created this fingerprint strategy. What a fingerprint is most of you heard about fragment-based drug design. Well, a fingerprint is a fragment of a fragment. So if you look at like this region here, this molecule, this ring system here is a fragment. A fingerprint is like 4 or 5 atoms within that fragment. And he generated a bunch of fingerprints of compounds that are known to bind to tau. All right. And what we wanted to do is we wanted to find a compound that behaved like PMPBB3. PMPBB3 is probably the best 4R tau ligand that has been generated. It's just that it's a horrible ligand to work with because of this dyeing here. It's photoinsensitive. So when you work with PMPBB3, you have to work with it either red light or green light, because if you work in ambient light, it isomerizes very, very quickly. So we wanted a compound that would bind to the PMPBB3 binding site in 4R tau, but didn't have the baggage of the isomerization of PMPBB3. So we did this fingerprint search, and he ran it through a large screen. It's like 3.4 billion compounds. We got a large number of hits. And what we then did is he did a similarity search, looking to find compounds within this screen that was structurally similar to PMPBB3. And the compound that came out of the wash is down here below, the Z compound, Z, I think it's 3540. And if you look at this structure, and then if you look at the structure above the arrow here, CBD, I think it's 2115, you jump to the conclusion, you're like, yeah, of course this is going to bind to tau, because this structure actually looks very much like CBD 2115, so they're both going to bind to tau. As a chemist, I look at that and I say, yeah, that compound should bind to the CBD binding site. But with the program, this just shows you how powerful these programs are. This program says, no, that does not bind to the CBD binding site. That binds to PMPBB3, even though you look at that and say, how can that be so? But when you do the binding assay, you can see that this compound has very low affinity for displacing tritiated CBD 2115, 250 nanomolar, but 20 nanomolar affinity for displacing PMPBB3. And the reason why I made that point is that it really shows you how these methods are extremely important, because they're unbiased. It overcomes the bias I would have in looking at a structure and thinking how it would behave in vitro and potentially in vivo. So we labeled this compound, Neovasta, labeled it. It actually defluorinates very rapidly. It's a horrible compound to make. So we didn't advance it. But what Jeff Stewart did is we used it as a lead compound for SAR studies, and Jeff Stewart's at Pittsburgh, and he made this compound, JSS, I think it's whatever. And it's labeled with F18, and you see the compound gets in brain very well. It has this 2-minute to 60-minute ratio of greater than 3, so it meets our go, no-go criteria. And the tritiated compound binds very potently to 3R, 4R, and AD, the 4R tau and PSP and CBD. This is a 4R tau animal model. And it also binds potently to the Pick's disease, which is a 3R tauopathy. It has low binding in control brain, doesn't bind to synuclein or TDP43. So this looks very good for a tau ligand. We did competition curves. You can see this compound Z3540 displays it very well. PMPBB3 next, but the CBD compound didn't displace it very well at all. So even though it looks like CBD, again, it does not bind to that binding sites. We know there are probably at least 3, more likely 4 different binding sites in tau for small molecules. And this appears to be a unique site or very similar to the PMPBB3 binding site. So we did a bunch of autoradiography studies. This is AD. We compared it with PI 2620 and T807, I believe, for Tausipir. You see it binds very well to AD. That's not terribly interesting because there are plenty of good ligands that bind to 3R, 4R tau and AD. But what is interesting is it looks like it binds much, much better than those 2 other tau tracers in the 4R tauopathies. This is CBD. and this is PSP. So the other ligands, they bind, but if you look at the specific binding of the JSS compound, it's much, much better than PI 2620 and certainly much better than T807 or flutalsapir. We looked at it in the synucleinopathies. We see there's no binding in the synucleinopathies. This DLB section here is one that was from the striatum that had low tau pathology, so there's no binding to that. We also looked at it in TDP43, no binding to that. So it looks actually very good. So what have we been able to do during this the first round of our U19? Well, we've identified 2 compounds that we've advanced to humans. HY215, which is specific for MSA, M503, which is specific for Lewy body-like pathology. This compound is not ideal because it also binds to tau, it binds to 4R tau. It's probably not going to really advance very further other than our first human studies, but we have reasons for advancing this that I won't get into. And we have this ligand JSS, which we're just getting ready to submit the IND on next week that binds to the 4R tauopathies. All right, so that concludes my talk. And as I end, I'd just like to show this slide. I'm not going to go through this. This is actually the small army of people who were involved in my U19 center that really are responsible for just about everything I presented today. So with that, I'll finish my talk and we can continue our discussions later.
All right, I believe I'm the last talk of this session. So my name is Beth Romina. I'm an assistant professor at Stanford. All right, so I'm gonna start with a very brief background, then I want to touch on kind of molecular imaging that's currently in place to understand Lewy body diseases. So I just want to go through some dopamine imaging work, and then some work that we actually heard some really nice data already from Kajal from the Mayo cohort, looking at AD copathologies as measured with PET. So I guess my disclosure to this group is I'm an AD researcher. So I'm coming from a different lens. And in AD, I mean, relative to what I've heard this last day and a half, I think we have it pretty easy compared to the complexities that this group is dealing with. So for Alzheimer's disease, we kind of think of this as a very long cascade. It begins during the clinically unimpaired stage. We know that amyloid begins early, also tau. We can measure amyloid with 4 different PET ligands. We can measure the 3R, 4R tau with also a handful of ligands. We can measure these processes with CSF and also with blood. So you can really deeply phenotype the AD profile very easily. And these markers all emerge very early too. So we're quite interested in this concept of early detection. As these biomarkers progress, we also see changes in neuronal function, neuronal loss, and ultimately clinical symptoms of the disease, mild cognitive impairment and dementia. So I attempted to kind of switch around my boxes and think like, what might this look like for Lewy bodies? And to me, this seems like, potentially, I guess, one big gap right now is that the natural history of this disease, it seems to be quite complicated, and I don't think we know how these biomarkers track. It seems like a lot of the uncertainties too have to do with the heterogeneity in this disease. So if I were to guess, it seems like maybe there's 3 or 4 different versions of this that exist when we think of Lewy bodies. So one commonality, I think, with the AD space is that alpha-synuclein starts before there's symptoms. Where it starts seems to vary. It seems like there's this bottom-up progression, and then also this more cortical limbic progression that's possible. And then downstream to that, there's issues in the midbrain, in the substantia nigra, there's dopamine dysfunction, and then also changes to metabolism, and also perhaps atrophy as well. In terms of Lewy body disease, it's probably, starts with an unimpaired phase and then goes to an MCI phase and dementia phase, which we've heard a lot about these clinical collections of symptoms during yesterday. But luckily, from the biomarker perspective, it seems like we're very well positioned to measure these different components of the cascade. So as we heard from Doug, we can now measure alpha-synuclein, just a binary readout in the CSF. Dopamine imaging, there's many different techniques to get at this. And this has widely been used in this space. And then we have things like FDG PET to get at metabolism. Oh, sorry. Is that better? All right, dopamine imaging. So there's many different tools to get at the dopamine system that have been used in both Parkinson's disease and dementia with Lewy bodies. These target the presynaptic kind of side of the synapse. So there's an emphasis on things like the dopamine transporter, but there's other targets as well. The DAT scan in particular, it's is a SPECT scan that's FDA approved, but there's other ways of getting at the DAT transporter as well. And I was very impressed going through the literature. I mean, there's a lot of papers published with dopamine imaging to understand these diseases. So here's one example, an older paper that is putting forward, how these, in this case, 2 different PET ligands can be used in the context of differential diagnosis. So on the top row is an amyloid PET scan, in this case PIB. On the bottom row is a PET scan that gets at the VMAT2 target. So here's 3 different profiles of different cases with dementia. With AD, we would expect a positive amyloid scan and then preserved striatal signal. With DLB, we might expect, although not always, a negative amyloid scan combined with dropout in the striatal signal. And then with FTLD, we would expect a normal amyloid scan, so amyloid mean scan as well. So these, because of this ability for differential diagnosis, these DAT scans have been approved over 10 years ago for Parkinson's disease to differentiate between essential tremor, and more recently with DLB specifically to differentiate with Alzheimer's disease. So here's a really beautiful postmortem DAT imaging study comparison, which I think really highlights, both the correspondence between pathology and this imaging tool, but also some of the limitations or this mismatch cases, which are very interested in terms of thinking about this potential cascade. So this study looked at about 50 folks clinically diagnosed with either dementia with Lewy bodies or with Alzheimer's disease. And then based on the path diagnosis, as expected, a couple of cases switched around. They weren't actually matching their clinical guess by the clinicians. But importantly, of those that had pathological Lewy body pathology, 80% of them were picked up with the DAT scan. So that's, pretty sensitive. It's not perfect. And then importantly, of those that did not have a Lewy body pathology, the majority of them, 92%, were negative on the DAT scan. So these, the mismatch groups, I think kind of summarize, what the DAT imaging is telling us. So of the 6 DAT normal dementia or Lewy body disease cases, they all actually did not have alpha-synuclein in their brainstem and instead had a more limbic neocortical presentation. So this kind of makes sense that the DAT imaging is not going to capture, this kind of flavor of dementia with Lewy bodies. And then in terms of the false positives, so those that did not have Lewy body, but did have a positive DAT scan, an abnormal DAT scan, they both did have impairment in their substantia nigra. It just wasn't due to alpha-synuclein. So this kind of gives us a sense it's, it's not completely synonymous with what's going on with Lewy bodies, but it does tap into this dysfunction within the substantia nigra. Projecting to the striatum. So I started going through this windy path with trying to connect the FDG literature with dopamine dysfunction directly. And I will say, I think this is actually quite unclear, the direct relationships between the two. So here's one study that did show using DAT signal, dopamine transmitter signal as a continuum, just simply asking if you have more reductions in this dopamine measure, do you have more hypometabolism? That's in fact what they found with this posterior pattern. They also did some nice mediation analyses where they showed that most of this was mediated. Most of this relationship between DAT and cognition was mediated by metabolism, but not always. Sometimes it was an independent predictor. So this kind of helped me with this idea of this cascade. But then there's been some work that shows the opposite, that actually shows like hyper metabolism in relationship to reduce dopamine signal. So I think the FDG story is probably a little more complicated, and maybe a comment on the heterogeneity, or maybe these ratios are needed to kind of tease this apart. But it seems like the literature is a little unclear, definitely on the direct relationship to this dopamine imaging signature, at least. All right, so now I'm going to switch gears and talk about copathology, AD copathology as measured with our current PET tools in LB. So we just saw this beautiful study from Kajal, and this is really a tremendous cohort of individuals throughout the Lewy body spectrum, beginning with this kind of prodromal, very early stage with the RBD group, and then MCI, and then dementia with Lewy bodies. And as she told us, we do see an increase in the amount of amyloid positive individuals as the disease progresses, but there's a lot of heterogeneity. I mean, there's a lot of amyloid negatives as well as the disease goes on. So I don't think as simple as if you have one, you also have the other. So it's about 40% or so in the MCI stage, and then 60% in the dementia stage. And then so it does seem like there's this correspondence. If you're on this Lewy body trajectory, you're more likely to have elevated amyloid. Now, what about tau? So Kajal also showed us this, and I just want to kind of drive this point home a little further, because I actually think this might be inconsistent with the neuropath data. So there does seem to be that there's some elevations on the tau PET side, but it is very restricted in these Lewy body cases. Even so, this is Kajal's data, and also data from Penn on the right. So even when you break it up the group in terms of amyloid negative and amyloid positive, those are the two middle box plots shown there. And we see a couple cases, popping up, but even the amyloid positive LB cases have a very restricted range of tau PET values. So I'm going to show some data that we've been working with at Stanford that to kind of follow up on this finding. This is led by both Joe Weiner and Kathleen Poston at Stanford. And here's our Lewy body cohort. So I'm going to point out a couple things about this cohort. One, so there's a lot of heterogeneity in our approach. So we are enrolling folks that both have clinical PD, clinical DLB, but also have a range in terms of their clinical presentation. So we have PD participants with no cognitive impairment, with MCI, we have one with dementia, and we also have a range within the Lewy body group in terms of MCI versus dementia. And in part, we've taken this strategy because we're interested in this heterogeneity and how biomarkers relate to this heterogeneity within this group. And so here's our data up against the Mayo data. So in terms of the Lewy body group, now this is collapsed across all the different cognitive levels and the different clinical diagnoses. We see a similar rate to what Mayo sees. So we see about 40% are positive in terms of amyloid. And again, a lot of heterogeneity, negatives, positives, everything in between. The one big difference between our two cohorts is our healthy controls. We actually have a lot of positivity in our healthy control group. So we have similar rates of positivity in our healthy controls compared to our Lewy body group, compared to Mayo, which has the more expected 20%. This is probably a confound of our Alzheimer's Disease Center. We really focus on ApoE4 carriers, for instance, in the pre-symptomatic phase. But importantly for this talk, the rates of positivity are quite, I think, similar to the Mayo cohort. And then here's the same cohort now, again, with a tau PET on the y-axis. And now our groups are broken up by Lewy body, amyloid negative, amyloid positive. So those are the first two box and whisker plots. And then up against the healthy controls, also stratified by amyloid status. And lastly, our amyloid positive AD group. And again, we see the same thing. I mean, we do not see cases with overt tau positivity in our cohort. We see some slight elevations in the amyloid positive LB group, but again, nothing close to what we see in our Alzheimer's dementia cases. Here's an exploratory voxel-wise map just to make sure we didn't miss anything. So this is just showing our amyloid positive LB group, which is quite small compared to healthy controls with a very liberal threshold, showing that this kind of posterior pattern that Kajal kind of mentioned in her talk. So we do see, these subtle elevations, but they're very, very, very subtle and tend to be more posterior. So even though, it does seem like there's these subtle tau PET elevations, we were interested in, is this just noise or, is this real? So here's a plot just showing the continuous tau PET levels on the y-axis against our continuous amyloid measures on the x-axis, separated by our two disease spectrums. So the solid black line is the LB spectrum, and then that dashed line is the AD cases. And what we see here is the expected relationship. So as amyloid is getting higher, we do see this positive relationship with tau PET. And it's actually quite similar to the relationship with AD. It's just that AD is shifted in the plot. So with AD, we see higher levels of both. So again, just kind of highlighting that these levels we're detecting with PET, both on the amyloid side and the tau side, they kind of seem to be shifted towards the intermediate to lower range, but still have a relationship with each other. We also asked a similar question with cognition. So here we're looking within the Lewy body group. Do these subtle elevations in tau PET relate to cognition? And that's in fact what we do find. So interestingly, we don't see associations with memory, but we do see associations with executive function and attention. So this does kind of align with the LB phenotype and suggests that even though these are lower levels of tau, tau signal, they seem to be consequential for telling us about variability in cognitive function in these LB participants. Another thing that we've been doing with the PET data is exploiting the patterns of off-target binding in the substantia nigra. So for some reason, these tau PET ligands, one source of off-target binding is cells that contain neuromelanin. So we see these bright spots in the substantia nigra area with these tau PET ligands. We can actually kind of leverage this, the lack of elevation in this signal as a proxy for loss of these cells. So that's what's shown here for a PD case. We see a very low signal. Actually, in our DLB cases, we see some decent signal there in our healthy controls. And when we plot this substantia nigra PET signal, we see marked reductions in our PD group, indicating the loss of cells in this structure as a kind of bonus, from these tau PET scans. It's not meant to measure that, but might be able to be used as a proxy for cell loss in this area. I think the reason we don't see it in the DLB in our cases, most of our DLB cases are in the MCI phase, so they're very mild. So we don't see this loss just yet in them. And then when we correlate this signal with motor symptoms within the LB group, we do see that a greater signal in this area is associated with better motor scores as well. So this might be, another way of using it's the same scan to get both that AD copathology, but also a marker of neuronal loss within the substantia nigra. So just I'm going to have one final comment on the low tau PET or the low tau levels, and then we'll conclude. So as I mentioned in the PET studies, we seem to be seeing this restricted range of tau levels. And I think the same is true for these initial studies looking in AD cohorts using the seed amplification assay. So here's two different studies focused on AD cohorts. So the ADNI study, Doug showed this slide or part of this figure briefly, but on the top row, what we can see is that, so this is separated by clinical diagnosis. There's normals and then MCI and then dementia. What we see is that of the folks that are amyloid positive, they tend to be more likely to be alpha-synuclein positive as measured with the CSF test. So that's shown on the proportions on the y-axis. However, the opposite seems to be the case for CSF measures of p-tau. So if we focus in on this dementia group, so of folks that are tau positive with dementia, with AD, presumed AD dementia, there's a lower frequency of alpha-synuclein positivity in that group compared to those that are tau negative. So this is, I think, further evidence of seems to be some sort of trade-off in these biomarker cohorts between alpha-synuclein positivity and the presence of this tau AD biomarker. The plot to the right is showing similar data that includes BioFinder data from the BioFinder group. The first portion of the forest plot shows effects of amyloid and alpha-synuclein status. And again, we see this positive association. So greater amyloid positivity is associated with greater alpha-synuclein positivity. But the tau PET, it's a null effect here. There seems to really be no effect of tau PET positivity here in this cohort either. So it's not lower, but it's certainly not elevated in the alpha-synuclein positive group. So just a few concluding remarks. So as you guys, I'm sure, are very well aware of, there's multiple relevant targets for Lewy bodies that are captured via our molecular imaging techniques. It does seem like the natural history is going to be way more complex than AD. And I think this is probably due to the tremendous amount of subgrouping that is present within this cascade. I think, this point has been made over and over again, but I think an obvious missing component right now is an imaging measure of alpha-synuclein. We're not able to get at the regional involvement of this protein. Right now, the seed amplification assay, there's lack of clarity on positives that may only reflect limbic involvement. We don't understand that. We also don't understand the rate of spread across regions and how that differs across individuals. So this will be a tremendous, I think, advancement when we're able to measure the spatial location of this protein. I think also importantly from the standpoint of early detection. So my work in the AD space is mostly focused on amyloid positive and or tau positive normal controls and what happens to these folks when they're followed longitudinally. Now we can do that with these CSF cohorts. So this will be, I think, very interesting to do, with this cohort. But with the seed amplification assay, we have no idea, when this pathology started. So I think for early detection, it'll be very important to have an imaging marker of this pathology. And overall, it does seem like there needs to be more work with this concept of comorbid LB and AD. I think it gets very complicated with the subgroups. So there's potentially many subgroups clinically, but once we start stratifying individuals by their amyloid status, their tau status, I mean, the groups get very small. So I think we do need larger coordinated studies, to actually be able to truly probe these different subgroups if we want to combine AD and LB processes. And also, I think an interesting limitation is going to emerge too, is there's so many PET scans that are probably relevant to put in these participants, but we can't do 5 PET scans on a given person. So I think we need to get a little more clever on the PET side too. And I mean, there's work that has gone into unmixing, like doing 2 PET scans at once and unmixing that signal, thinking about designs that alternate PET scans every year. But I think we might be in a situation where we have a good problem that there's too many promising imaging techniques that are needed to truly provide an accurate profile for a given participant. So I'll end there. I just want to quickly acknowledge both Joe and Kathleen, who led the Stanford work that I presented today. So yeah, thank you for your attention.
Hi, so that was a great session, actually. I took 5 pages of notes, which is a lot of notes for me. I kind of wanted to think about like what we heard in a sort of a practical light. First, 2 things. One thing is basically that I think the people in the room are going to have their questions moderated by Nina or Deb, and basically the people who are in the virtual space, just put your questions in the chat, and I'll try to kind of pull those out for the speakers. I did have a question myself to just kick off, and I'm thinking about this very practically. I'm thinking about this with respect to, how we actually help trials, because at the end of the day, we have a disease that doesn't have sort of disease modification. And if we're going to get there, we need to be able to help trials. And it seems, I think one of the speakers was talking about, some of the purpose of biomarkers being to enroll the right people. And then I think importantly to try to track progression in order to kind of make trials a little bit more efficient. And as I'm like listening to everybody and thinking through the field, it seems like kind of with the CSF based seed amplification assays, we're at least getting to a proxy for synuclein in the limbic and neocortical areas of the brain. And certainly with the beta amyloid imaging, we get a sense of, who has beta amyloid in their brain. So that may be very helpful for enrolling the right people. It seems to me the bigger problem is how you track progression, right? So this is the question I have for the speakers. If we imagine like in the nearer term, let's say it's 2024 right now. So let's say kind of before 2030, not like somewhere in the super far future, where are you thinking we'll get help from biomarkers in actually basically tracking progression for the purpose of disease modifying trials? And I think, is SAA going to be more quantitative? Are we going to have imaging markers with respect to, synuclein tracers or structural MRI or some, dopaminergic modality? I don't know. I'm just curious what people think right now.
Well, thanks, Alice, for moderating. So I think an ideal tracking imaging biomarker should be accessible, cheap, and, can be applied multiple times over maybe every 6 months or so, which would be probably very important for short-term clinical trials. That ideal biomarker could be blood-based biomarker, but we don't have that. So if you're asking the question of what we have currently in hand, I don't think the CSF SAA or skin biopsy SAA has gotten to the point of longitudinal quantitative biomarker for tracking disease progression, but it may in the future. So, having said that, it doesn't mean that this is a dead end. I mean, it's gonna be a lot of work to get it to that point. Currently in the imaging biomarker field, we have several biomarkers in hand that are longitudinally stable over time, like atrophy rates or FDG PET hypometabolism progression. So I've shown that some data on FDG PET, which was exciting that we could maybe plan a clinical trial with 25% efficacy in 18 months. With less than 100 people, if we are to use FDG PET. But obviously, FDG PET may also require additional MRIs to do the quantitation very precisely. So it's expensive, it's maybe less accessible. So each biomarker has its drawbacks, right? I mean, it's not the ideal biomarker we would want, but that's what we have in hand. And amyloid imaging is being used in Alzheimer's clinical trials for target engagement and efficacy, at least at the beginning. Now, some of the trials don't need it, but at the beginning to demonstrate that target engagement is happening and with regional measurements demonstrating the efficacy, I think it was critical for at the beginning of Alzheimer's trials. And I think it will be important for as we plan trials for DLB as well for amyloid modification.
Doug?
I'll comment that I'd like to see markers that reflect neurodegeneration of relevant circuits and pathways. And again, this might be different for a proof of concept trial versus a larger phase 3 trial, where the phase 3 trial may have to be a little less burdensome. One could imagine serial CSF sampling for a proof of concept trial, but not being able to do that at scale in a definitive trial. We've heard, for example, about dopamine decarboxylase, about synaptic biomarkers, neurofilament light, a number of markers like that. MRI maybe could be promising, but we've learned from the anti-amyloid therapeutic trials that in fact, removal of amyloid is associated with increased atrophy in certain brain regions on MRI. So I'm not sure what the predictions could be. What is exciting is being able to image some of the brainstem relevant areas, locus coeruleus, substantia nigra, and so forth. And it would be nice to see work on trying to do this in a multi-center way where perhaps it could be translatable to trials. I'd be curious to hear what some of the other images think about that.
Yeah, I just want to, I guess my reaction to that question is I think it really depends on the stage in which the disease is being targeted, what sort of markers would make sense for progression. So I think coming from
I'm gonna up the ante. Let's say it's early stage, because almost all the trials are trying to hit those early stage ones. So let's answer that question, right?
Yeah, so I think early stage, I think could mean a couple of things, you know, depending on like the view, like that could mean MCI clinically, or that could mean you know, alpha-synuclein positive via CSF test with no symptoms whatsoever. So I think there's an opportunity to really target a very specific, you know, aspect of the disease, and then simply ask, you know, are the downstream changes that we expect, are they halted with a given drug? So I think if folks were to target alpha-synuclein positive completely normal controls, you know, then it would be interesting to look at, you know, whether or not dopamine and dysfunction, you know, does not emerge. I think that would be, you know, one reasonable, you know, downstream effect, but that would only work, you know, in a very, very early, you know, like
And you would
clinical
do
trial.
that by DAT, you think?
Yeah.
Yeah. Okay. So that's what you're thinking at the very early stage. And if we're thinking kind of positive and mildly symptomatic, what do people think? Because I was thinking about like the very first biomarker conference I went to in 2014, you know, and I was like, oh, I don't want this to be happening. I don't want in 2034, we're still saying, oh, you know, like this is what we need. I want to look at what we have. How can we use what we have, and how can we hone it so it can be useful, right?
So can I shift the focus? I know everybody
please do.
imaging biomarker and CSF biomarker. I think digital biomarker has a place to complement some the people who have CSF biomarker, the people who have imaging biomarker. I think because of the expense of those biomarkers, we need to move a bit more towards, in addition, adding the digital biomarker, because we could track people over 2 months, for example, easily with watches, for example. I don't think digital biomarkers per se will help with specific differential diagnosis or identifying the subtypes of DLB. But I think, for example, our heterogeneity in actigraphy, we're looking at the data more closely, but the people who obviously don't move as much probably have UPDRS, high UPDRS scores. So that's a potential subtype. So I would just like people to think about, and we need to look longer, along, you know, 18 months and 24 months to see how those digital biomarkers change. But I'm advocating that we add the cheaper, okay, biomarkers to the CSF and imaging markers in progression.
I think there might be questions in the room. So
Yeah, Alice, can we intersperse? Are we
please
done
do.
with this
Please do.
one? Okay, John, do you want to go ahead?
So I had 2 questions for Doug that are actually go to the initial comments from Alice. So the first question is the patients who are SAA negative but clinically have DLB. There's lots of everything says that they actually have a robust cholinergic deficit. And they probably have, by all the data, a cholinergic degeneration. Are those people, if we have a mechanism that's not targeting alpha-synuclein, why would we exclude those patients rather than actually including them? And well, why would we exclude them? Second question is just a little bit of comment and a extension on the question on, I'm surprised by your comment on GFAP, because it is actually in DLB does actually correlate very nicely to cognitive decline. It's not related to amyloid, but more to tau, and so with neurodegeneration. And even in the Bolshevik paper, there's no difference in GFAP levels in A beta, CSF, A beta positive versus negative. I actually do think, and it'll come out strongly in my talk, that GFAP may be a great marker of disease progression and neurodegenerative rate. So those are two questions.
Okay, so the first one is, I think we were talking about what we thought of as trials that would engage with alpha-synuclein or engage with amyloid and try and clear pathological hallmarks. There's room for all sorts of different clinical trials to try to ameliorate symptoms, to try to stabilize or improve cognition. And those may require different approaches, different biomarkers, different cohorts. But again, if one is, it's been tricky if one wants to, for example, work on cholinergic mechanisms. We don't have a robust screening biomarker of a cholinergic deficit.
But it's unaware of disease modifying towards
trial,
cholinergic.
Sorry, I'm unaware of a trial that has looked at NBM volume on MRI as an entry criterion for something like that. There are lots of post hoc analyses, so it's very reasonable to go after symptoms in any kinds of defined cohorts. No problem with that. If you have a heterogeneous readout of your study, you're going to have to go back and try and figure out who got in and why, but that's a different question. I think we were thinking about, are there studies where we are trying to target alpha-synuclein or target amyloid, and how would we use those for biomarkers? And the same category of biomarkers at stabilizing synapses or reducing neuroinflammation or cholinergic mechanisms or whatever. And I think those studies are going to have to look at whatever they want to adopt as a readout beyond clinical measures. Regarding the second question, I mean, if one looks at the amyloid antibody therapeutic trials, I mean, GFAP was highly responsive as a plasma biomarker. It was highly responsive to amyloid reduction. So while it might be related to tau, I'm not aware that it's increased in PSP or corticobasal, for example. So it does seem to be responsive to amyloid reduction, at least in those clinical trials. And we can debate how much tau and how much amyloid people with DLB had in a study like the Bolshevik one, where they didn't have tau PET, for example. I think, I would propose GFAP as being a readily accessible plasma biomarker, and seems to perform better in plasma than CSF. That could be worth.
But it looks like GFAP and NFL are also lower. So we can take that over. Now, the inclusion criteria for a DLB study, I learned here a lot, and not even for a Parkinson's study, I learned here a lot, that we do have to have better inclusion criteria, like whether it's CSF seeding or whether it's skin. But I think in terms of looking at progression, we can use p-tau217, NFL, and GFAP.
Alice, I'm going to turn it back over to you.
Yeah, so I have some questions that seem to have come in online. There is a question about alpha-synuclein folding. So I think maybe this might be good for Dr. Krause. Do we think that, given if alpha-synuclein folding seems to be somewhat disease specific, do you think there are differential steps in processing folding and deposition, or protofibril clearance that could eventually serve as therapeutic targets, so, and then the other thing I just wanted to ask you personally is, do you think there's just sort of 2 flavors, 3 flavors? How many flavors of snook, I guess maybe for Dr. Mock and for Dr. Kraus, how many different flavors? Is it 100, 5?
Right. The tough question. So, right, why do we get these different forms if we have the same polypeptide sequence and it's rearranged different ways? I think these are key gaps in knowledge. This is where layering such studies capturing markers of neurodegeneration on top of markers of these corrupted proteins. So as it relates to flavors, the structural studies of these ex vivo filaments are really indicating, slightly different orientation sometimes of the protofilaments, or as they're put together, but sort of these shared core structures of disease. But we don't capture everything. And so there's things outside those structured core that I think could be meaningful in these situations, PTMs, others, that we just don't understand how these all interact, such that are they really identical in their completeness of biochemical features?
Yeah, Alice, I think that's a great question. I don't know how many flavors we have. And it's one of the things, this is going to have a huge impact, I think, on the interpretation of our PET data. And this is where structural biology is going to be key in help guiding what we do going forward from ligand development as well as PET image analysis. And, the one thing I want to like to point out is that in the paper that published the synuclein structure showing the Lewy fold, there were other fibril structures that they identified, but they couldn't solve by cryo-EM. So there are potentially other fibrils in PD brain whose structure is unknown and is not clear if any of the ligands I talked about today can even bind to them. So I think we have a little ways to go in the structural biology to help identify these fibrils. Once the fibrils are identified, we need to have model systems like the PD-seeded fibrils that I spoke about that enable us to look at how our radioligands are binding to them. And then once we have this information, we'll be able to see how it all fits in a living brain.
And just to follow up on that in structural biology, right, we're not capturing via some of these techniques conversion intermediates. And so looking at these progressively across stages of disease really, I think will inform how these, relate when you have, just different ordinal scores. When you would look at the brain via neuropathology, what are we capturing?
And there's another question. This seems to be for for Doug Glasgow. And the question is, should we include hyposmia as a core feature for the diagnosis of DLB?
So that's a great question. I think hyposmia isn't specific. We do see it in Alzheimer's disease. We see it to some extent with aging. The question is it good enough on its own, or could we have 4 core features and try and do a number of different things to play around with them? I'm not sure. I think in order to do that, we would need some really large data sets and make it a data-driven exercise. I mean, I think it's an interesting observation at present, but I wouldn't elevate it to a core feature right now.
We have a question in the room. Okay.
We have
Welcome
2, I
ahead.
guess. Mine's a statement, I guess. I mean, I think I'm coming away from this thinking we need all of these markers in many ways at different stages of disease. And there are things, I mean, there may be some basics. The one thing I kind of like about the NSD criteria is that we start with a definitive diagnosis of, is there a synucleinopathy going on? You need to know if there's Alzheimer's going on. But then all of these other measures, non-biofluid necessarily tissue, are really telling us progression of disease. Many of them very approachable, right? FDG PET, something that we could really take a look at. ASL, these are things that the digital biomarkers, et cetera, can tell us more about progression, but I guess we all have to play in the same sandbox now, and in terms of biofluids versus in tissue, different markers as we move along. I'm curious about comments there.
Yeah, I totally agree with you, Jim. The challenge is, to do all of them in the same patient and do it longitudinally, we need large cohorts as well, given the heterogeneity of the disease. And how do you do this? I mean, it's logistically very hard, and coming together with different consortia and maybe merging data, maybe that's the way to go. Larger studies like Clarity may give us some of that data from various centers, ADRC. So I think the planning should be to enrich the samples and cohorts so that they reflect the heterogeneity and as many biomarkers as we can, I think that's the challenge.
I mean, I would add to that when trials
Doug, it's hard to hear you.
when clinical trials are done, I think it would be great if there would be data and sample collection and sharing, because those can also amplify longitudinal data that have been collected in a very rigorous way.
I had a question going back to the different conformations of the aggregates. There are quite a few groups that work on aggregation inhibitors for Alzheimer's, probably for Parkinson's, for anything. Given all these different structures, would we need different aggregation inhibitors?
Well, I'll take a stab at that question. My answer is no, but for a reason different from what you're expecting. Is I'm not convinced the aggregation inhibitors are going to be terribly effective. Okay, so yes, if you want to design things that can aggregate, yeah, there are multiple binding sites, particularly synuclein. I just mentioned 2. There are probably more binding sites for small molecules, and they could have an impact on aggregation. We haven't really found something that really is effective in doing that to date, but I'm not quite sure that's a particularly good strategy, though. Okay, but that's just, again, my bias.
I agree with you.
You agree or disagree?
I agree. Were you information?
Yeah, and then as it relates to inhibitors, because I totally agree, and it relates to also, proteins can misfold in different ways, and in vitro probably, and then there's very good examples, does not match in vivo. And so ex vivo structures don't necessarily look like those that can be formed in vitro. And, we had very nice data showing that the PD allowed for, seeding and in ways that you get these different affinities. So that's going to apply to tests of inhibitors too. So working in spaces, we expect or understand are relevant to the structural biology we see.
I think JP was first and then.
Yeah, so I'm going to bring it back to sci-fi and Douglas Adams, the answer to everything, and that life in the universe is 42. So there we are, solved. But 2 serious questions to Doug and Kajal. So Doug, I was very intrigued, of course, with the SAA, but what are the implications from the SAA in terms of how it performs in regard to peripheral alpha-synuclein, so the enteric system, the vagal nerve, etc.? Does that influence how we're going to see positivity or negativity? And then the question to Kajal, where do you see the place for electrophysiology biomarkers such as EEG or MEG in terms of mapping progression?
So for the first question about the periphery, I think the involvement of the vagal nerve and its various pathways is really fascinating in terms of PD and DLB pathogenesis and how these various synuclein aggregates or post-translationally modified forms of synuclein traffic up and down the vagus and its branches is it's to some extent unsolved and unknown. I mean, I think it's surprising to many of us that there are these positive skin biopsy findings. And I think we don't have a comparison right now of what an abnormal phosphorylated form of synuclein that stains in a skin biopsy means compared to what an oligomer or a seed means. Is the synuclein immunofluorescence actually staining oligomers, or is it staining something else? And I think we really need some very good comparative studies that haven't quite happened at this stage. I mean, it is intriguing that we've seen some RBD data that the skin changes happen relatively early. And the minimalist thing I would say is that we now know that there's trafficking of abnormal synuclein up and down the vagus nerve and its branches. And we can use this as a biomarker. We don't know at what point it becomes synuclein. I think that's a huge challenge. I mean, there's normal synuclein that has to do with a number of autonomic nerves and branches. I've seen some occasional claims for people trying to do colonic biopsies and things and trying to do SAA reactions, or some very brave souls trying to collect stool and do SAA on that. And I'd rather dabble with blood, to be honest.
Yes, the electrophysiology, unfortunately, we don't have a talk in electrophysiology here, but I think, I mean, it's not my specialty really, but I think there's a lot of potential in especially the RBD stage, the very early stage. And there's really good data emerging from the NAPS on electrophysiology, where people are doing sleep studies. Of course, to translate those measurements into clinically relevant outcomes and potentially be used in clinical trials, we need to think about like home applications, not just having people go through these sleep studies longitudinally over time, multiple times, but rather maybe take it home using digital technology, perhaps. But I think, I don't know, Brad, do you want to add anything about sleep? That's your area, really. Okay.
Thumbs up for Brad. Rachel, you want to go next?
So in listening to you, Allison, a couple of thoughts or questions were coming up. So first, you reminded us that not all amyloids are hazardous. And we've come to think that the hazardous ones are the ones that misfold and template, and propagate. And yet you showed us that in your tissue assays, you get seeding in normal controls. So what are you thinking about that? Is that because there's something different about the assay and it's an artifact, or is seeding of amyloid proteins sometimes normal?
So, we've done everything we can think of and will continue to do so to try and test, right? Are these seeds that we detect related to tau? Can we immunoprecipitate tau? Can we look at structural features, even at, the difficulty, very low levels? And so some of the biochemistry is more difficult. I think, and there's very good evidence and with application to brain, this speaks somewhat just to the sensitivity of the technique. You have these exponential amplification reactions. You can dilute brain tissue out 1 billion-fold or excess and still detect that seeding activity. And so this is really that huge dynamic working range. So as it relates to disease processes, the hypothesis of prion-like propagation and or templating, it starts, you would get it, it spreads. But within the host, this has to be managed against all sorts of clearance mechanisms. Other things that would go on. And so I think this is why it's so important to understand the first detection of such things, but then when they become associated with what we would understand for pathology, and then even clinical disease. So precedes clinical disease, but just these trajectories, it's a gap in knowledge, but I think an important one that we address. I hope that answers the question.
It does, but if we start using, for example, seated fibrils to make our targets for imaging, you know, are we using the right thing? You know,
Yeah, that's why I think the cross-validation studies that I showed are important, that the seated fibrils that we used actually predicted how our radioligands were behaving in tissue section. So I think, yes, you have to, they're fine as long as you can cross-validate it with something closer to the real thing. And we use autoradiography for that. Okay.
And I just want to add to the structures, and it was data I didn't share today, but you know, there are examples of shared core filament structures, and I'm thinking of primary age-related tauopathy and AD. These core filament structures are the same, but we have vastly different, you know, pathologic and clinical outcomes within these settings. And so again, understanding the layers of the biochemistry on the structures, on the microenvironments, on markers of neurodegeneration, just at least from the biochemist and molecular perspective, is really important.
Dan, go ahead.
Question, I guess, first for Debbie. So about the digital biomarkers, and maybe part of this, the first part is also for Brad maybe, but these really low REM durations, 0.3 hours, 1 hour. So I was just wondering what the normal REM duration is for an older adult. And then number two is your y-axis on one of the graphs when it talked about activity counts was like 2 million or something. And I don't know how people are supposed to understand that or interpret that. And three, when you said you might have expected a correlation between more activity and improved cognition, I guess you could also argue maybe in this population that higher activity levels might mean agitation, which might be a bad thing as opposed to a good thing. So I'm sorry for a three-part question, but.
So you expect me to remember all those? So, seriously, what can
normal duration of REM sleep in an older adult?
Yeah, so Brad, you could correct me if I'm wrong, but I think it's 7% in this age group. Approximately, there's a there's papers that talk about specific age range. So this is for the AD group, we found surprisingly, they were fairly in the normal range.
An hour is normal.
Yeah, yeah. And in the DLB group, it was surprisingly low. Brad, do you want to comment more on that?
Sure. In young people, 25% of total sleep time is typically REM sleep, and it goes down with age. So in DLB, down further compared to age. So, but even to do a polysomnogram, if you get a half hour of scorable REM, it may not be accurate, and not to get too much into the weeds, but these folks have very disorganized background EEGs with motion artifact. They're hard to score sometimes. So it's even compounded with ambulatory devices.
And if we want people to use digital biomarkers, it's just being one example. How are we to interpret 2 million activity counts? What does that even mean?
Yeah, so this is an activity count.
Okay.
Okay, so just by moving my hand, it's a triaxial. Okay. So those are activity counts. And there are already very well established algorithms so we're not talking about step counts. If we're going to do step counts, you have to do a waist actigraphy. So these are activity, just how you move your arms. Okay. So interpreting that, I mean, there's norms, right? Like NHATS, we get our norms from NHATS of what an normal age looks like, activity count. And then NHATS also with 100 subjects provide us for dementia. NHATS does not subtype the group, different kinds of dementia, because they do like a 5-minute assessment. So there was a third question, right? Okay, that's enough. Okay, good thing, because I can't remember.
Alice, I'm going to actually turn it over to you for the last comments or questions.
You know, this has been a great session. If I had like one kind of wish list, I wish you guys might kind of come up with, I know this is controversial. I know people will disagree, but if you could come up with almost like a little wish list of easy biomarkers that you'd want to see incorporated into trials, because I think that would help people at least come to some sort of consensus. You know, I heard some blood-based stuff. I heard neurofilament light, GFAP, maybe dopamine decarboxylase. Those can come up, p-tau 217. Those can all come off of a blood sample. I heard some structural MRI, maybe some disagreement about different, PET modalities. I heard basically kind of CSF, SAA, and maybe beta amyloid to figure out who has what proteins in their brains. Does that sound like kind of a menu that people are feeling some consensus around? I'm kind of curious. We don't have to discuss it all live, but I'm going to send everyone into lunch thinking about this a little bit. And, thanks for inviting me, even though I can't be there with you. I think you guys are going to lunch now, right?
We could take a minute or two to answer that last one. I'm not hearing stomachs rumbling, so.
I mean, I'd like to add synaptic biomarkers to that wish list.
Yeah, like which ones? I keep pinning people down because I want a sense, because people are going
Vote for your favorite biomarker.
Yeah.
Yeah. So if we're collecting CSF, then NPTX1, NPTX2, and neurogranin would be a very reasonable starting point. If we're only collecting plasma, it's difficult. There are some data on beta-synuclein as a marker of synaptic damage in the periphery.
Maybe I would also just point out, I think like with the plasma space, we saw some really nice talks from Emory yesterday and this NELISA panel, which has, many of these targets that you just mentioned. So I think that it was very easy, to integrate these promising multiplex techniques for plasma. And I think for the AD front too, I kind of don't think we need to do amyloid. I think we could drop amyloid PET and we could use a variety of blood markers. But I think now is not the time to go cheap with PET relevant for LB. Like I do think having DAT scans and having FDG and if possible alpha-synuclein would be absolutely critical to try to integrate into some of these trials to really kind of put the, some funding into those efforts. It will also help, I think, understand the course of the disease and how these things are connected to as like different interventions are being tested.
Can I just divert a little bit? My wish list is that we would have a more objective measurement of function, right? Everybody's measuring CDR sums of boxes, and that's great, but I would like to see a more objective functional measurement, because if you don't have an informant, then you can't participate in the trial. And the informant, if they didn't sleep well last night, they might give you a different answer. So I would like to advocate for a more objective, in addition to the CDR sum boxes, a more objective measurement of daily function. That's my hope.
So my wish list would be tracking biomarkers and screening biomarkers. They may be different. Blood-based biomarkers obviously would be very much desirable for screening. But then maybe tracking, you may want more specific measurements of where the drug is working for example, for amyloid modifying trials in DLB, which has never been done before. I think it's really critical to demonstrate target engagement and efficacy, which you may not be, it may not be possible by CSF or blood-based biomarkers. There, I think amyloid PET would be really useful for tracking.
SAA?
Of course, anything that to capture, right, these corrupted proteins, if you will, are characteristic of these disease processes. So capturing that, capturing other measures of PTMs that we think are relevant that also would occur on these characteristic proteins. So incorporation across these other measures, I think, is just so important.
And Bob, I think you got your marching orders here. Get going with that.
Yes.
No, but just a comment on that. I think this is where you have to understand, I'm a pet purist, so I'm going to look at this solely from the perspective of pet. But if you go back in history and you look at the impact that carbon-11 PIB had on our understanding of A beta and Alzheimer's disease. I mean, this is something that was perceived to be a marker that would be used to diagnose Alzheimer's disease. But the pioneering work out of WashU with the Diane study showing that it's more than just a biomarker for diagnosis. It's actually an antecedent marker where you can identify patients at risk, which should then really impact your treatment designs and how to absolutely critical in basing how we now approach Alzheimer's disease today. And that's where I really think the true value of a radio tracer would be, is we can come in and we can see how early does this pathology occur and how it can be used as a pharmacodynamic or therapeutic biomarker. And that's really where I think the biggest potential of the PET tracer is, once we can figure out how they're actually behaving.
Alice, last comments? Any last comments?
I don't. I'm just writing down the wish list
Okay.
and trying to figure out how to make it practical because I would like, I do think kind of this practical bent, figuring out how you can use what you have and what you nearly have, to start designing the trials that are going to happen, right? This is going to be important. And that's what workshops like this are helpful for. They bring together people who can sort of maybe agree a bit, right? So thanks, guys.
Thanks, everybody. I guess it's lunchtime now. Thanks, Alice.
Okay, welcome back, everyone. Now we're going to turn our efforts more toward the clinical trials side of things. And I'm going to just briefly say something about the three speakers, and then I'm going to ask you to also say something about yourself. In the case of the first speaker, he just wanted me to say his name was Jim, and that was it. So I'm going to leave it to him to tell you what he actually does in his day job. But what I can tell you about him, besides the fact that he's a professor of neurology at University of Miami, is that he's a great television critic. So if you're in need of any series to watch, you can go back in time, go to today's contemporary viewing. He's the person to talk to. Oh, and by the way, I didn't say who I am. I'm Rochelle Duty. So I'll be chairing this session. The second speaker is Laurie Ryan, just joining us this afternoon. And I can tell you that she is one of the great leaders championing and a champion for Alzheimer's disease, and that we really count on her in this field. She is the chief of clinical interventions and diagnostics in the Division of Neurosciences at NIH. And then the third speaker today will be Brad Bove. And again, you're all going to say what you do in your day jobs. But besides being in both the departments of neurology and sleep medicine at Mayo Clinic, he's really an excellent clinician. And I've had the opportunity to read many of his clinical evaluations and shared patients with him over the years. So that's something else you should know about him. So I will sit down, three of you come up, and maybe would you prefer to go back to your seat or come up here? Okay, so everybody stay up here. Okay. Jim?
Hi, I'm Jim. So for those that don't know me, Jim Galvin, I'm a neurologist, a professor of neurology, psychiatry, and behavioral sciences at the University of Miami. I'm the director of our Lewy Bodies Dementia Research Center of Excellence there, and I founded the Comprehensive Center for Brain Health, which is a multidisciplinary approach to brain health and memory disorders. So I'm going to talk to you a little bit about clinical trials in DLB. And
And my title is Where We Were and Where We're Going. So I wanted to first start off with a slide for all of the approved treatments for dementia with Lewy bodies. And I think this is a very telling slide. The second most common cause of dementia, and there's not a single approved, FDA-approved medication for the treatment of the, million or so people who have the disease. For Parkinson's dementia, we're a little bit better. We have rivastigmine, which was approved for the treatment of the cognitive symptoms. And we have pimavanserin, which is approved for the treatment of psychosis. But still telling, you think about all the Parkinson patients who develop cognitive and behavioral symptoms, and you think about all the dementia with Lewy body patients, we have very few options to offer them on label. However, we do have a lot of off-label treatments that are available. And so most of this has been through investigator-initiated studies, a few company-sponsored studies, and anecdotal experience. So that for the cognitive symptoms, we borrow the medicines from Alzheimer's disease, and donepezil is actually approved for DLB in Japan and the Philippines. There's plus minus data on memantine. For the motor symptoms, we use mostly carbidopa levodopa replacement. Very few patients with DLB are treated with dopamine agonist or other agents because of all the side effect profiles. Obviously in Parkinson's disease, other medicine, all the different motor medicines are used. And as Dan mentioned yesterday, the result of that is you see some impulse control issues in the PD patients that you do not see typically in the DLB patients. For the fluctuation and attention issues, we borrowed medicines from the narcolepsy field. And so modafinil and amidafinil. Behavior, basically borrow anything we can from psychiatry. And with the development of precision medicine approaches, we've been able to take a little bit more of a modern approach to doing this. But still, as Dan really eloquently mentioned yesterday, the medicines have efficacy, but they may not be as effective as we want. But we often have to offer something to our patients. And so we just take a very cautious approach to using these medicines. For sleep, as Brad mentioned, melatonin. Actually, so that's nice because it has, essentially no side effects. Where we have to go beyond that, we typically use clonazepam. And then if the people fail both of those, then we're really struggling sometimes to find something that'll work. And the autonomic symptoms, which drive patients and their families batty, really have very few options that are either effective or well tolerated. But there are a few things out there that have been tried. This is actually a review paper that I wrote, I don't know, it's a while ago now. I always say just a little while ago, and then I realized that a little while ago is getting farther and farther and farther away. And so back in the dark ages, I contributed to this paper where we just looked at the, in the PDD field, which there was a lot of clinical trials using cholinesterase inhibitors. And overwhelmingly, the general pattern is they are effective. So there is a clear cognitive benefit for cholinesterase inhibition in PDD. And anecdotally, everybody who's a clinician here knows that DLB patients respond actually quite nice to cholinesterase inhibition. So they're a little more attentive, their cognition's a little better, and there actually may be some effect in modifying some behaviors, particularly some of the psychotic behaviors. So that's kind of where we were and where we are heading in the moment. I think one of the great things that we've been able to do as a group, largely with the push of the Lewy Body Dementia Association, is sort of come together as a group and try to think about how we approach this problem. And one of the real problems is how do we design the right clinical trial? So even if we find the right agent, how will we find the right clinical trial? And I think, my opinion, in a lot of clinical trials, the trial fails not because of the agent, but because of the design. And so what is the right outcome? What do we have to look for? How are we going to optimize these clinical trials designs? How do we identify the right study population? And more importantly, how do we find what's the one, what we should measure, and two, how do we measure it for the primary outcomes? Unfortunately, we often just reuse all of the Alzheimer's disease outcomes. And it's not clear necessarily that those are the right outcomes to use in Lewy body diseases. So, we put together a paper. Jen Goldman first authored this paper, and we just kind of proposed what a mock trial might look like, and what kind of assessments, what kind of things should we do, how should we do it, what kind of biomarkers we'd like to have, whether we have them or not, what kind of study population we'd like to have, whether we can find them or not, because I think you have to start with a planning phase in order to really understand how we're going to address this. Now, the DLB outcomes that are currently used in some of the ongoing trials have varied. So from a global perspective, a number of trials have used the CDR sum boxes, and some other trials have used the Clinician Global Impression of Change, or CIGIC. And those two are probably the predominant global measures. From a cognitive perspective, this has been a real challenge. A number of trials have used the ADAS-Cog, but it's not clear that the ADAS-Cog is necessarily the best option. ADAS-Cog has a memory and language and a praxis component, but doesn't have really any attention or executive measures. And if DLB's cognitive picture is more of a attention executive format, is ADAS-Cog actually going to capture that? And the answer is maybe not. The R-bands has been proposed, which has a little bit more expansion and has a nice visual spatial domain, but also does not have an executive component. So then you have to think about how you're going to add to that. And there's been a lot of interest in trying to look at some of the computerized batteries, although no agreement necessarily on what's the best one. But because DLB is such a complex disease, as John Paul eloquently talked about yesterday, we really have to think about all of the other domains we have to capture. This is a challenge in the context of a clinical trial. So not only do we have to figure out how we're going to look at cognition, but how are we going to assess movement, behavior, fluctuations, sleep, daily function, autonomics, and we can go on and on and on. And all of these things are important. And the thing about a global score is if you just use sort of a traditional kind of CIGIC approach, you're going to not capture all of these other things, which may actually lead to global improvement in a patient. So for the CT1812 cognition therapeutics trial, I helped develop a sort of a cheat sheet for the CIGIC that was Lewy Bodies specific. And so we gave prompts to the investigator so they could ask the questions that would cover all of the different domains. So, what's going on in the clinical trial world? And so I did a recent search of clinicaltrials.gov just to get a sense of what's out there. So as of the 6th of this month, there were 207 registered studies, 134 were interventional, 73 were observational. Of the phases, 10 were phase 1, 32 phase 2, 10 phase 3, and 11 phase 4. 40 interventional studies are active, 37 are active, and 4 of them are patient registries. So, they're great. They're going to add sort of information, but not in the same terms of treatment outcomes. And you say, well, 207 studies doesn't sound bad, and about 134 are, some form of interventions. Interventions can be lots of different things, though. So some of them are medications. There's several DBS type of studies that are ongoing, and other types of interventions. But if you look under Alzheimer's, as of November 6th, there are 912 active studies. And for Parkinson's, there are 957 active studies, motor Parkinson's disease. So you could see that it's really kind of falling behind. And in fact, for multiple sclerosis, there's 762. And for amyotrophic lateral sclerosis, clearly a terrible disease, there are 240 active studies. So, in the world of dementia with Lewy bodies, there's just not a lot of studies going on, and we desperately need to change that. So this is from a paper, and we had an opportunity to put some of these ideas in paper. There's been several trials that have happened, and they've largely been negative. A few of them have had some positive results about various aspects. So Brad led a nice study with aminophridil, and had some positive signal. The pimavanserin study suggested that maybe, well, definitely in PDD it would help, and maybe in DLB it would also help. Other studies, again, have been largely negative at their primary outcome, and some of them are ongoing. There are 3 studies that are essentially completed in terms of enrollment. We're waiting for data readouts, nilotinib, CT1812, and neflamapimod. I'm not going to talk much about NEF because John's going to talk a little bit about NEF in a little bit. I'll talk a little bit about CT1812. And for those people that are going to Amsterdam for the DLB study, we have an oral sessions where the results for those 3 trials will be presented, no matter what they are. I do want to talk about one study that happened, closed, and they presented the data back in 2022. And I think it was a failed study, but I think from every failed study, you can learn lots of things. And so this was a study by ASI E2027. It was a cyclic GMP compound. So it basically works through nitric oxide pathway and may have an important role in plasticity. The hypothesis was that inhibition of PDE9 would increase cyclic GMP and enhance symptomatic benefit for LBD. They recruited 83 people, were screened rather, and 34 were enrolled. They had either DLB or PDD, and they either had amyloid pathology or didn't have amyloid pathology. And so you can see the outcome, it's a negative study, okay? So it didn't really show a signal per se, but looking at post hoc analysis, it suggested that mild DLB who didn't have a lot of amyloid may have had some clinical effects, right? And so we're going to talk about this a little bit more, during the course of this conversation. And then this afternoon, I think John's going to give some really eloquent information on how we could use this to really, design a clinical trial. Is that it's possible that biomarkers and using that for stratification is going to make a huge difference in being able to sort out who has a response and who doesn't. So this program was discontinued. It's not going any further. But from every failed study, you learned so much about how to design the next study. It was safe, and that's also helpful because DLB patients are exquisitely sensitive to almost anything you give them. And so the fact that they were able to get through the study without any significant adverse events was very promising that you could manipulate systems and get these patients through a trial. There's a lot of interest in repurposing drugs. So this was a very, very nice sort of modified Delphi process led by John O'Brien. I got to participate in the Delphi panel. JP, you were part of this too, right? Yeah. And so they basically looked at all the evidence out there for drugs that are already on the market and what ones might be interesting potential targets. So the top one, Ambroxol, looked like the most promising, and there's actually a large study going on in Norway right now to test this. Ambroxol itself is a really challenging thing to use in a clinical trial. So it's a mucolytic. It's not available in the United States, but it is a mucolytic, but you need, it's a large dose. So it's up to 24 pills a day that people have to take. Anecdotally, I've had a couple of people try to do this. They contacted a compounding pharmacy in Germany, got it shipped here, and even with compounding, it was 12 to 15 pills a day. And they're large pills, and so it was really difficult for the patients to do it. So Ambroxol itself may not be the right drug, but it just gives you an idea that it gives a sense of a target. And so repurposing also has a great potential because we know all about the safety of these drugs. They're generally generic and readily available. And so it leads to the possibility of designing new studies. I want to briefly talk about the CT1812 study as an example of some new compounds. So this was a collaboration with Cognition Therapeutics. We got a grant from NIA. At the time, it was like the largest grant, I think, for a DLB study. This was at the time, was a first-in-class small molecule that worked at the sigma-2 receptor. And it works by binding and altering the oligomer receptor complex. And so the idea was that this was going to help clear the synapses from toxic oligomers. And so there was a study in AD and there was a study in DLB. We recruited 120 people in the phase 2 study. The enrollment's completed. The last person will come out sometime in late November, early December. And so we'll have a primary top-line data readout sometime in the end of December, beginning of January. And we're presenting this data in Amsterdam. So the study with DLB was called SHIMMER. The study in AD is called SHINE. And so I'm going to show you the SHINE data because this was presented already. And so see if I can get yeah, here's the pointer. It works good. So you can see the placebo group, you can see the treated group, and you can see there is a difference in baseline numerically. It didn't reach statistical significance, but there were only 50 people in each arm. But the effect size for the ADAS-Cog difference was about the same effect size for the monoclonal antibodies. Now we didn't have enough people to demonstrate statistical difference in this particular trial, but so that's the top line data. So then I've had an ability to now look at the data a little more detail. When you look at it by p-tau 217 levels, you can see that those people who have low p-tau 217 have a statistically significant benefit, where the people above the mean value had no benefit at all. So again, stratifying biomarkers may be a really important strategy in our DLB trials going forward. The Rewind LB, which is neflamapimod, is a collaboration with EIP, now Servo Med. And we also had an NIH grant to do this study. Again, a first-in-class molecule that works at the p38 alpha system and protecting basal forebrain cholinergic neurons from degeneration. It was a phase 2b study, 160 people, fully recruited, and we'll get the readout sometime in December-ish, and will be presented in Amsterdam. And we're going to hear a lot more about this in the next session from John. So I'm not going to talk any more about this because I don't want to steal any of his super, super loud roaring thunder. But where else are we going? And I wanted to give you the idea that we've talked about prodromal disease. Well, could we do a prevention study in DLB? And so we were just funded in a U01, also from NIA. Thank you, Lori, wherever you are. And novel vaccine against alpha-synuclein. And so this is a collaboration with the Institute for Molecular Medicine in Huntington Beach, California. So what Michael has developed is a really novel platform, the multi-TEP platform. So it's 12 promiscuous T helper epitopes. One is entirely novel, and the others are drawn from hepatitis, influenza, and the other one's escaping me at the moment. Tetanus, sorry, I couldn't think of it there for a second. Anyway, the B cells and the T cells have seen, except for the one novel one, have seen all of these things before. And so the idea is that you'll be able to stimulate the innate immune system. And so there are 3 epitopes of synuclein which are attached to this multi-TEP platform. Lots of preclinical work has been done. We're now doing the final IND enabling safety and toxicology studies. We'll do the GMP of the drug and do the regulatory documentation to the FDA. That's for years 1 through 3 of the grant. In years 3 and 4, plus a likely no cost extension. So year 5, we'll be doing the first in human studies. So the phase 1A will be in 24 healthy controls, and it'll be a single ascending dose to look for immunogenicity. And then the phase 1B study will be in, so we had to decide what we were going to do, right? And so how could we demonstrate potentially prevention in this? But we also want to be able to look and see if we're actually hitting target. So what we decided to do was to do PSG confirmed people with REM sleep behavior disorder that have a positive skin biopsy, okay? So we wanted people who had a prodromal condition of DLB, but we wanted to be able to demonstrate target engagement in a human, and so we chose skin biopsy. The beauty of the skin biopsy, if you haven't done the skin biopsy, it's about a quarter size of a pencil eraser, and you can do it over and over and over and over again in the same exact space. So the idea is that we'll know exactly where they had their prior skin biopsies. We'll demonstrate that they actually have synuclein in their skin, and we give them a vaccine, and then we'll bring them back at the end of the study and repeat the skin biopsies in the same site and see if we can demonstrate any changes in synuclein. We're going to probably look for some additional outside funding to expand this, and the next phase would then be do it in DLB MCI. But right now we're trying in a prevention study. Just quickly, as some of the preclinical data, we get nice immunogenicity in the preclinical data. We have all the nice pharmacokinetics. It's an IgG, largely an IgG directed molecule. And so here's a triple staining. This is for amyloid, this is for tau, and this is for synuclein. And you can see that we get nice engagement, and we can see structure in the transgenic mice. We get removal of synuclein, we get improved motor function. Looks all promising. So to summarize my section, clinical trials in DLB remain a top priority. Despite the increased number of clinical trials for DLB in recent years, the total number of randomized clinical trials lags far all other neurological diseases. We do not yet really know how to address fully the range of all of the symptoms. How do we address fluctuations? How do we address the dysautonomias? How do we address some of the behavioral symptoms, agitation, psychosis, apathy, which is generally a treatment refractory symptom anyway. Past studies have largely focused on trying to do symptomatic things, but I think we're now changing the face of the game. The face of the game. We have 3 studies that have completed enrollment that we're really excited to see the readouts that are disease modifying in one way, shape, or form. Recent and ongoing studies remain largely focused on cognitive outcomes, but we also may try to do novel outcome measures, novel repurposed drugs. So I think that's really exciting. But the newest studies really offer the greatest disease modifying potential. What's not on the slide is I also think that NIH has been a phenomenal partner in trying to support studies in DLB, both the basic studies that help us understand biomarkers and signals, but also funding these really novel early stage clinical trials. And the Lewy Body Dementia Association has been a marvelous partner in both helping develop materials and with recruitment for participants. So thank you.
Oh. So I get to go next, and I'm Laurie. But you already heard my bio. I'm the chief of the clinical interventions and diagnostics branch. Excuse my nasal sound. I'm still battling a cold that I picked up when I went to CTAD. So it's not gone yet. And in addition to leading the branch, I also lead the late stage pharmacological interventions portfolio. So I'm the PO for most of those and for many of the things that you'll see coming up. Okay. So I'm really here to talk about our infrastructure and our initiatives that we have going on. And I'm going to start by talking about our clinical trials consortium, our network, excuse me, which is the ACTC, the Alzheimer's Clinical Trials Consortium. And this is just a snapshot from the website. And I'm going to go into a little bit of detail about it. And you can see right there, actcinfo.org, if you want to actually take a look at some of these things. But it was initiated in December of 2017, so it's in its second iteration. The PIs are Paul Asen, Risa Sperling, and Ron Peterson. It's a cooperative agreement, so that means it's a collaboration between the PIs and the NIA, and I serve as the project scientist for ACTC, and there's a separate program officer, my colleague Christina McLinden, who manages all the administrative and progress reporting and the budget-related things. And so what we developed the ACTC for was to conduct clinical trials really from phase 1B. So you need something that needs a network. A regular MAD/SAD study is not going to be appropriate for ACTC, but really large 1Bs up to phase 3, both farm and non-farm interventions for AD and ADRD, and for the cognitive and neuropsychiatric symptoms associated with those, and across the disease spectrum. So really from preclinical, pre-symptomatic, all the way to more severe stages of disease. And really that we wanted a state-of-the-art clinical trial infrastructure to facilitate the development and implementation of the protocols, and to provide leadership really in innovative trial design methods, outcomes, analyses, and recruitment strategies, particularly in diverse and underrepresented populations, and enable broad sharing of procedures, methods, as well as the trial data and biosamples. And I'm going to go back to data sharing in just a little bit. And this is just showing you some of the structure. So these are the units that the ACTC has. I'm having a hard time reading it from here, but I wanted to just kind of give you a snapshot and hone in on, there's bioinformatics, of course. There's also a biomarkers unit that's led by Robert Rissman. The biomarkers unit specializes obviously in the clinical trial biosamples from the ACTC studies, but also it's at ATRI, which is the Alzheimer's Clinical Trial Therapeutic Unit, excuse me. ATRI serves as the coordinating center for ACTC. Rob's unit can also take clinical trial samples from other studies. So if you are interested in that, you could reach out to him directly. Obviously, biostatistics, recruitment, engagement, and retention, and also the inclusion, diversity, and education in AD clinical trials unit, which started out as a committee, but really for this next iteration became a full unit to really advise ACTC on how to be more inclusive. And that is led by Rema Rahman and Risa Sperling. And so I think that's a really critically important unit that the ACTC has. And in addition to the unit, there are many committees. So the steering committee really drives and decides what clinical trials will be run through the network. But in addition to that, we of course have a biospecimen allocation review committee, which is led by Tom Montine. So we want that to be totally independent from the trials that are running. There is an early career project evaluation committee. So we want to bring the next generation of leaders to actually understand how to evaluate protocols and decide on what should be coming into the network. So that's really very important. We have a non-pharm intervention committee, and we have an AD/ADRD intervention committee. Oh, and of course, I wanted to mention our research participant advisory board. That is a critical piece. So when Nina actually and I wrote the NOFO for the original ACTC back in the day, we said, we want to have participants on the external advisory board, but they took it and ran with it. That's Sarah Walter. We have a whole committee now, and it's really an invaluable committee. Many of them were actually participants at the research panel on the participant research panel at the summit. So if you all had a chance to see that, they really get involved from the very, protocol design from the very beginning. So it's critically important, and we're very, very happy with how that has played out. And this is just showing you the ACTC sites. So the member sites are the ones in the red, and there are 38 member sites, and they actually serve on the steering committee. They PIs make up the steering committee of the ACTC. So in addition to that, though, there are 104 participating sites, meaning that they are participating in at least one or more ACTC trials. And this is showing you the current studies, both interventional and non-interventional, that the ACTC is running. Of course, I think everyone's familiar with the AHEAD study. The new one that we'll be launching, hopefully not too much longer, is the Alzheimer's Tau platform that's led by Adam Boxer. And we have another study that's the Progressive Supranuclear Palsy Trial Platform, the PSP or the PTP, that was recently funded. Just so you know, the START trial is actually CT1812, but in a large phase 2. And there's also the ACTC-DS, which is looking at a network of the sites within ACTC that are going to be doing Down syndrome and Alzheimer's related trials. And then, of course, we have the Libby trial, which is looking at cannabinoids to actually treat agitation in late stage dementia. So I think that's a really critically important study as well. Okay, and now I want to kind of switch to our clinical trial funding, notices of funding opportunity, or NOFOs. And we have, starting off with a pilot trials NOFO. This is led by my colleague Benford Williams. So really, this is for people, if you need some data, it's not to do phase 1 trials, it's not to do IND enabling toxicology, anything like that. It's really, are there some preliminary data? Do you need to get some pilot data in, a different patient population, things like that? Will come in because we found some people were not getting through review for the R01 because they needed some more information. So this is like an R21, it's 2 years, but it's a somewhat bigger budget. And this is the newest of our suite of clinical trial NOFOs, which is the seamless early stage clinical drug development. So it's 1 up to 2A for novel therapeutic agents for AD and ADRD. And it's a phased award, UG3, UH3. So it's for first in human studies, like I said, through phase 1B or 2A. Again, cognitive or neuropsychiatric symptoms, AD and ADRD across the spectrum. Importantly, though, the candidate interventions here must be non-amyloid and non-tau. So they're really looking at novel mechanisms here. And we have data, I'm going to talk about the data and biosample sharing at the end. We have it's NIA reviewed by a special emphasis panel, so we think that's critically important. And my colleague and I, Connie Clark and I actually lead this program. And of course, I would call this the workhorse of our clinical trials NOFOs. This is the early and late stage clinical trials for the spectrum of AD and ADRD, as well as age-related cognitive decline. Again, we can do phase 1 up to phase 3. Again, for across the spectrum of disease. In addition to actually running efficacy or safety trials, you can actually look at trials to do enhancing trial design and methods. For example, the trial-ready cohort trackpad that many of you might be familiar with actually came through this mechanism, one of our earlier versions of it. And of course, they are now NIA reviewed, which has been critically important because we had lost our special emphasis panel, but now that we're an RFA, we're having it reviewed in-house again, so we're very excited about that. And you can see all my colleagues in the clinical trials team in the clinical interventions branch are involved here. Connie and I, predominantly and obviously in the pharmacological space, he does the early stage, and Christina and our new colleague Jane are leading the non-pharm interventions. And Benford has been sort of the glue that holds us all together as our health specialist, working very closely with us on this. And you've already heard about these 3 now because, you know, Jim stole my thunder, but these are the 3 trials that are currently funded by NIA through different mechanisms. And as we said, we are hoping to have readouts of these very, very soon. And this also brings me to what Jim was talking about. This is our preclinical to clinical therapy development program. It's a U01 program led by my colleague, Larry Ruffolo. It's basically takes you preclinical and early stage clinical development of novel small molecules and biologics. So there are 2 entry points here. Early stage is really optimizing the agent all the way up through IND. The late stage entry point is advancing through IND and toxicology up to phase 1. And we work, obviously because there's phase 1 testing in there, we work very closely with them for anything that's going to be in that late stage entry point. And of course, there are, you know, STTR technology transfer grants that you can also do clinical trials through, and our colleague Zane Martin leads that. Of course, as SBIRs, they are extremely, you know, limited in budget to about $2 million, so they can kind of get you started, but really everybody has to come into the R01 to actually do later stage studies. And that could be both pharm and non-pharm. And for terms of data sharing, as I mentioned, all of our NOFOs, not all of NIH's NOFOs, but all of the things that NIA does, we have pretty strict data sharing and biosample sharing requirements. And for the registration trials, we follow something called the Collaboration for Alzheimer's Prevention, or the CAP principles that really were developed back in 2016, where you're making the screening and the pre-randomization data available within 12 months of enrollment completion, and the post-randomization data and biosamples as soon as possible, obviously without compromising trial integrity. So in terms of, it'll be either after regulatory approval or trial completion or termination, or 18 months, whichever comes first. And then for smaller studies, earlier stage, we really want it within 9 months of the primary publication. I mean, at the time of primary publication, or 9 months of data lock, whichever comes first. And I want to highlight one of our, I think, our success stories for the data sharing policy, which is from the A4 trial, which I think most people are familiar with, the anti-amyloid treatment for asymptomatic AD. It was a definitively negative trial, but it was very well run. There were almost 7,000 participants screened, nearly 1,200 enrolled. It was preclinical based on amyloid PET status. Solanezumab was the drug. There was an observational sister study called LEARN that was funded by the Alzheimer's Association for people that were screen failed because of not enough amyloid. They could go into the LEARN study. And the data has been shared in 2 stages. The screening data set in 2018, so that was a year after enrollment closed. And the final data set just recently, this July, 2024. So that's a little over a year after the study completed. And the data shares clinical, cognitive, laboratory, biomarker, neuroimaging, and GWAS data. And this is just showing it. So this is a slide I modified from Gus Jimenez-Magoria from the ACTC, showing what data has been used since the A4 release. This is as September 3rd, 2024. He presented this at the NIH AD Summit. So it's been very successful, data shared by Gain and Loney. Data and biospecimen sharing committee was established. Nearly 1,600 approved requests for clinical and biomarker data. Investigators from over 60 countries or 153 have included imaging data, over almost 1,000 image series downloaded, over 2,000 aliquots of plasma. There have been 5 R01s funded using the plasma data from A4 and 68 peer-reviewed publications to date. And I think I want to highlight just one of them because this is really one of the first papers to show what we all know now is that we see differences in amyloid burden based on ethnicity. And so this was from the A4 screening data, and Casey Dieters showed that the non-Hispanic Black participants had lower rates of amyloid positivity and lower continuous amyloid levels compared to non-Hispanic whites. That race effect was strongest in ApoE4 group. And within the non-Hispanic Black group, those with a lower percentage of African ancestry had higher amyloid burden. The caveat, of course, is in addition to non-Hispanic Black participants being screened out because of PET, there were also screen failures due to the cognitive measures. So there's clearly still some bias in the data to keep that in mind. But people are seeing that across the board now, this issue with amyloid burden and ethnicity. And this is showing you what the final data set is of September 3rd, 2024. So there have been, for that, the data set, which is both A4 and Learn, there's 84,000 longitudinal participant visits, 15,000 longitudinal imaging studies, over 100 approved requests at that point from 15 countries. There was a JPAD special issue on A4, if you're interested in looking at that. And it's been shared on multiple platforms. So the GRIP platform, as well as Synapse. So it's not part of the AD Knowledge Portal, but it is on Synapse and will be on Gain and Loney coming soon. So that's it for me. Thank you.
Hi, everyone. Well, I have the honor of discussing the Research Centers of Excellence program supported by the Lewy Body Dementia Association. And there are some in this room who are part of the RCOE program, as well as some participating virtually, but many may not be aware of the RCOE program. So wanted to present background and appreciate the opportunity to share this information. So again, these are my disclosures, and the RCOE obviously is funded by the LBDA. So first, some historical perspectives. This was back in 2016 or thereabouts. The LBDA posed a question to the Scientific Advisory Council to identify some key gaps that the foundation could address. And some of the recommendations included forming a consortium of sites to fill a critical gap in infrastructure to advance the study of therapeutics, and also to foster more collaborations across centers in the US. So the RCOE began about 7 years ago. And these are the two main aims. The first one, to assist the LBDA in the coordination of the network to improve LBD clinical care. And this was thought to be important. First, you can't do good research without doing good clinical care. And everybody was kind of doing their own thing because there really wasn't any network. So this has really been, if I can say this, speaking on behalf of everyone, a very enjoyable and rewarding and informative experience just to learn from colleagues, what are you finding is working in the clinical realm, not only in diagnosis, but management. And then also, very importantly, to use this network to be a clinical trials ready network. So the site selection process, it is competitive. There's a desire for geographic representation across the US, And because some centers are more behavioral or cognitive neurology focused, others are more movement disorder focused. And again, this is good learning experience for those of us who are trained in relative silos, but to learn from our colleagues. And this is the map of the current 20 sites. I'll talk about where this is going in terms of expansion in a minute. And you can see all the sites listed off to the right. And for each of the sites, these are some of the expectations, basically 4 pillars to provide state-of-the-art diagnostic and management practices for LBD care. Advance the science by contributing to publications, as well as being involved in clinical cohort studies and in clinical trials. Also to coordinate CME and related professional education coursework, and also have LBD specific support group and other communication, community education programs. So this is the structure. The boxes in green represents those things related to the RCOE and how it relates to the big picture of the Lewy Body Dementia Association in general. And I'll get to the working groups in just a moment here. So there were working groups that were developed, and this is what has transpired basically up to this point. 4 main working groups. 1, clinical trial design and optimization. This working group was charged with, just as the title suggests, to try to inform our industry colleagues how best to develop trials. You can see some of the outcomes from this working group, those publications listed there. The community engagement working group in the publications listed there. Industry engagement, and importantly, the site capabilities. Different sites have different capabilities, and wanted to make sure that as many of the sites, if they didn't have, for example, DAT scan imaging or an infusion center for upcoming intravenous types of therapies, to try to build that infrastructure across the network. And then for clinical care and professional education, the Great Diamond Lewy Management Toolkit was created by our colleagues in Newcastle. That was adapted for use in the US. And also hospitalization is a huge challenge in the LBD community, and how best to decrease the need for hospitalization. But if a person is hospitalized, some warnings. And so, you know, the big thing is don't use Haldol. And it's just amazing, despite even the wallet card with that statement, people are still being treated with Haldol. But it's clearly better than it was before this was started. These are the working groups now going forward. The clinical trial design and optimization working group, because this is viewed so high priority, this is going to continue, and you can see the elements of the working group going forward. And then 2 new ones, one biomarkers, and this seems pretty obvious now with the advent of in vivo markers of synucleinopathy, how that gets used for clinical research, clinical care, and for trials. And then how do the current 2 frameworks work for DLB? Many of them, elements of them, may work pretty well for DLB, some may not, and this is a work in progress. And also, very importantly, we appreciate the lack of attention that non-white communities have received from a diagnosis and research standpoint. So this will be high priority going forward too. I mentioned the site capabilities. We want expert clinicians at all of these sites. They have good clinical populations and they keep growing. The ability to do multimodal imaging, attention to the current fluid and tissue biomarkers, and again, infusion capabilities. And very importantly, the RCOE acts as a help to the our industry colleagues, provide advice whenever that is sought, site involvement for trials, promote the trial visibility, and also to help with recruitment and retention. So these things are done not only by the sites, but also the LBDA. In terms of manuscripts, we do keep track of productivity, and I think this is pretty impressive what the member sites have done over the past 4 years. You can see under the RCOE heading specific manuscripts that were developed as part of RCOE activities, and then the number of publications specifically focused on DLB or PDD, and then others more related to Parkinson's disease or REM sleep behavior disorder, but still was relevant to the LBDA mission. And you can see the total manuscripts off to the right. And I won't go through these in detail, but these are the RCOE focused publications from the start. And needless to say, Jennifer Goldman, Melissa Armstrong have been very busy, as well as many others, and their leadership again is really, really appreciated. Other things in terms of achievements, many of the sites are involved in the current Shimmer and Rewind LB trials. They're also involved with biomarkers, and then the longitudinal cohorts, the DLBC, the NAPS program. There are many other programs focused on DLB PDD that are part of the Parkinson's disease biomarker program. And then some very important initiatives, the Persevere and the PACE DLB programs that are focused on patient and care partner focus. You know, there's still just a lack of good, high quality programs focused on patient caregiver related activities. And it's real credit to Melissa and Jory for leading those efforts. So future directions, the plan for expansion to 27 sites. And we've had the good fortune of being the coordinating center over the past several years, but that leadership will transition into 2025. The specific sites and the new coordinating center will be announced, revealed, whatever the right term is, next month. And we'll continue to promote use of the newer diagnostic tools, expand the involvement in the development of and the participation in clinical trials, and again, continue to focus on health disparities. So I'll end there. Thank the many site investigators who are currently involved and the future ones coming. And thank the LBDA, obviously, and NINDS and NIA for their long-term support. So I'll stop there.
So I think, Nina, you're monitoring the online questions, and we can take questions from the room. I have one to kick things off for the three of you. An improvement, a great improvement in cancer treatments based upon subdivision of populations and biomarkers. We're beginning to see that in Alzheimer's disease now. And you mentioned it, Jim, in your talk about we need to stratify populations, and you suggested based on biomarkers. So from where the three of you sit, what does that biomarker have to look like in order to be good enough to start stratifying populations for clinical trials?
Well, I think there are two ways to think about it. So one is if we had a good biomarker of synuclein, obviously if you have something you think is going to affect synuclein, you'd want to be able to make sure they have synuclein. I think what I was trying to discuss was that Lewy body is a complex disease like Alzheimer's, but it's a complex disease. And if they have a lot of neurodegenerative aspects or a lot of Alzheimer's pathology, they might respond, that group might respond differently to a medicine than the group that has less neurodegenerative markers or less Alzheimer's pathology. So I think it depends on what the mechanism of the drug is and what the target of that drug is might better inform how we're going to stratify that. I showed you examples of stratifying by the A side was by amyloid. The shimmer is by p-tau. The shine was by p-tau 217. I think John's going to talk about p-tau 181, right? So I think it really depends on the mechanism and the marker that will help you find that mechanism. But I think that's going to give us a sense of who's more likely to respond.
a marker reflects the pathology you're interested in, it's good enough.
If you're developing an anti-synuclein drug, then synuclein should be good enough. If you're developing something that's going to affect the brain, then you probably need to have a biomarker that reflects how much brain pathology there is to understand.
And I don't want to belabor discussions from A4, when some of us insisted greatly that the amyloid negatives should be retained in the study, which has led completely to a rethinking about who should be a target for treatment. You know, so if ASYN is a target, you want people with ASYN, but just with that caution in mind. Any thoughts, Brad or Laurie?
Just to add to what Jim said, so helping to determine inclusion, exclusion, who should be in the trial based on various factors. But the biomarkers that are best for tracking may not necessarily be the best for inclusion and exclusion. But also to your point, so for example, SAA, Jim and others were talking about the DLB consortium, what is it, about 25% or thereabouts are SAA negative, but they have a DLB phenotype. So is this a miss? Or will they develop a positive marker? And we don't know because the longitudinal SAA just hasn't been done, or at least hasn't been published yet.
I don't think I have too much to add, except, you know, obviously with Alzheimer's, we need to understand how the biomarkers we do have are going to perform across populations. And that's a big issue. So having a study like we have with HABS HD looking at, you know, tracking over time across populations is going to be critical. But yeah, nothing else to add from what they've said.
Questions from the room?
So I don't have a question, but I'm going to make a comment and underscore Jim's and put maybe 5 exclamation marks behind Jim's acknowledgement comment regarding both the NIA and the LBDA, and support Brad's comment in terms of what the RCOE, what they've contributed to drug development. I think the NIA's funding of both the SHIMMER and the REWIND LB study was, in retrospect, I think will end up becoming like that kind of the critical funding that really will have hopefully gotten drug development really off the ground in DLB. At the time, there's a huge chicken and egg problem for investors going into DLB clinical trials because there's no precedence. There's no discussion of, they're used to, here's the endpoints, here's what you need to do. That's what they're used to. That's what they invest into companies and drug development trials. And hopefully we come out of the trials at a minimum will show the path forward of why you should be investing in DLB and what kind of trials. And I think it's a huge kudos to the NIA and Laurie for having funded, and in the end, the peer reviewers as well, to have that foresight to be able to support that. And then that much more on the RCOE, or equally amount of, you know, when you were launching this, we met at AIC in 2019, and there was no path, who do we talk to when we're going to think about a design trial in DLB, and that by itself was hugely valuable. And along the way, you know, we've partnered both in the phase 2A and the phase 2B. The majority of our sites in the US have come from the RCOE, and it's been a huge impact. And it's to real credit to the LBDA to have set up the RCOE and the leadership of the RCOE, and I think it's been critically important. So everything that you said, Brad, was right and spot on in terms of what you've been able to achieve.
Sure.
Nina, is it a question? Push it again.
Doesn't work. Just keep pushing.
Sometimes.
Hello? Okay. We have one online question. Have we saturated all options for symptomatic treatment of DLB?
No. I mean, I think there's always going to be a need for symptomatic medications because there are always going to be people who are living with disease and feeling the effects of the disease. So there will always be a need for existing symptomatics, and there will always be a need for development of new symptomatics. I don't think the development pipeline of disease modifying in any way precludes the development of symptomatic medicines. And if you look at the Alzheimer pipeline, for which the pipeline is better illustrated, a good portion of the things in the pipeline are symptomatic.
If I could add to that, just based on the patient presentations and the caregiver presentations yesterday and some of the research that's been done in the space for patient and caregiver priorities, a lot of the symptoms you heard about yesterday don't have symptomatic therapies. So we know from our surveys, from the people who spoke, from research on quality of life and caregiver burden, that fluctuations are a major driver of experiences of people living with Lewy and caregivers. We don't have good treatments for that. We heard about excessive daytime sleepiness through several of our patient and caregiver reports and presentations. And while Brad has one study, we really don't have good treatments for that. And then for people who have autonomic symptoms, those can be very devastating, and we don't have great treatments for that. So I think from our people living with Lewy and caregivers, we know that there are major symptomatic needs. And even with the symptoms that have had studies like cognition and Parkinsonism and RBD and psychosis, there are still major unmet needs.
I guess this could be for Jim, but really anyone, including Lori, from a funding standpoint. But obviously some studies have been in Parkinson's, dementia, some in DLB, and some in a mix. So I'm just wondering, without getting too much in the weeds, like what do you think are the pros and cons of separating versus combining those into a given clinical trial?
So I think it depends a little bit on the question you're asking, right? And so in many ways, Parkinson's disease dementia is the optimal clinical trial population, right? Because they had motor Parkinson's, they had it for a number of years typically, and now they're developing cognitive symptoms. And so it's a more easily definable group for which designing inclusion-exclusion criteria and then a target. The challenge with that group on the flip side will be they'll typically be treated with lots of medicines for their Parkinson's disease, of which may lead to, drug-drug interactions and other things with whatever agent you're looking at. The DLB population often is, again, in theory, is a great population to study because they'll be largely drug naive, except for a few things that have been tried. But people with DLB are diagnosed late in the disease generally. So many people are diagnosed, in the moderate stage because they're misdiagnosed often early on. So I think it depends on the design of the trial that you're looking for, the outcomes you're trying to collect based on the molecule that you're testing. I think there's opportunities to do DLB only trials, PDD only trials, and LD inclusive trials, depending on the question that the compound wants to answer. I think for non-pharmacological trials, it should be LBD. I think that's clear, it should be LBD. But I think for pharmacological trials, it'll depend on the question. And then, how the trial plays out will guide, what's the next steps.
JP, would you like to comment on the LBD DRS, just for those who may not be aware of where that's going?
Yeah, so again, I think it was picked up on the presentations, and Jim nicely described it, is this: we lack good clinical outcome measures in measuring the progression over time in LBD, particularly at that early stage. And clearly we need to develop things which are more optimal. Now, the CIGC and maybe, tuning it, as it were, for a Lewy body focus is one way forward. And, I think that's a great idea. But, we need to have something which is nuanced for LBD. So in that context, there is an intention to develop a domain rating scale. And I know there's some individuals have been involved in that, and we're inviting further individuals as well to contribute to this via Delphi process to shape up and refine a scale. Now, this will be a progenitor scale, which then could be embedded in natural history studies, or indeed in clinical trials as an exploratory measure. But I think you'll probably be able to reflect on from the PRS. Well, hang on, I'm missing my acronyms. I'm having a fluctuation now. But the one which is in IRBD is sort of the vanguard in this space, and sort of demonstrating how it can be effective to develop a scale for measuring that change. So I think that is important. And again, the domain rating scale is going to be more global to encompass that full panoply of symptoms that patients experience, which is, and also bring in that functional aspect as well. So hopefully that will also chime with what our regulators want for outcome measures. So fit for purpose.
But just to ask you a little bit about that, you know, when we hear about the heterogeneity in this population, some people have hallucinations, some people don't. Okay. Some people have very prominent Parkinsonism, some people don't. So if you take a scale that encompasses the whole phenomenology of the disease, and only part of the scale will apply to each person, your chance to show a very large difference over time between a drug treated and a placebo treated group, or even just in the natural history, goes down, right? Because you water down, you know, the phenomenology in order to encompass all of the possibilities. So how are you dealing with that in your scale development?
Well, again, that'll come from the clinometric perspective, but you know, as we know, a lot of the symptoms actually progress together, and whilst there may be variations, there is a sort of commonality to them. And I think again, how we look at this scale from both a global perspective and then drilling down to individual symptom domains, shall we say, and asking, you might nuance, for example, in your particular clinical trial, one or two of the symptom domains. And I think the important thing to say is it doesn't take the place of, let's say, a cognitive specific scale or measure. This is in addition to that, to give that overall, hopefully, primary outcome measure. But, you know, again, across the board, what we're, in a way, you will help average out some of the sort of issues. And certainly, if you take a look at the previous clinical trials that have been in DLB or PDD, the things which come out positive is often the global outcomes. So that composite of everything rather than one particular thing. The further element which is in this is very much bringing in the patient perspective, the family member informant perspective, and then the clinician scoring on that basis, so like a CDR style. So that allows that degree of clinical judgment to come in to say, yeah, this is an important symptom, and feeds into the score.
Go ahead.
Talk a lot about the cognitive outcomes and other outcome measures. I'd be curious on your thoughts on thinking about this from the function standpoint, and where cognitive and function go together, but also measuring functional improvement. Because we don't have a measure.
I think Debbie before brought up, you know, right now we often rely on informant-based assessments to look at function. There are a couple of objective functional measures. So we just licensed one out from WCG, which is a virtual reality functional capacity assessment test, right? And so we're now incorporating it into our natural history studies. And so what this is, it's a tablet, and you have to basically, you're living in the world and you're in your kitchen and you have to cook a recipe. So you start by figuring out what you have and what you need, make a shopping list, go to the store, buy the things, then take the correct bus back to your home in order to then cook it. And so it's a virtual reality situation. So they have to function, and you can get a score. Yeah. Right. But I think the idea of trying to get objective functional measures is really, really going to be important.
And maybe to expand on this, this might be a topic as part of this workshop, because this has risen to the importance of the revised Alzheimer's Association, AD criteria. How do you define function? how do the staging systems that are proposed for synuclein and then LBD? So it'd be nice to have a commonality of how functional impairment is defined.
Deb, you had a comment or a question?
Yeah, and this kind of follows up on the issue of function. And this is not as shiny as what you've been talking about, but what about non-pharmacological clinical trials? Do you think there's anything promising in the areas of stimulation, sleep treatments that might help, cognitive therapies that might really be of benefit in DLB patients?
Melissa, just with your experience with PACE and just the involvement of patients and caregivers, again, your experience, even though it's not an interventional study per se.
Yeah, so for PACE-DLB, we are looking at the experiences of people living with Lewy and caregivers in advanced stages and predictors of end of life in dementia with Lewy bodies, and then caregiver experiences post-death. So it's really longitudinal. We don't do much in terms of intervention. Jory's study, which you referenced, is a caregiver-based intervention, which is matching more experienced caregivers of people living with Lewy with caregivers who are newer to the Lewy experience. And I think that's a really exciting thing, hoping to help both caregivers, but through caregivers also helping people living with Lewy. I know, Jim, you mentioned briefly things like DBS or transcranial stimulation and things like that. So I think those are under study, but less so than the pharmacologic management and with smaller numbers and variable results. But I do think, you heard yesterday from one of the caregivers on the call, the importance of things like education, just helping people know how to handle psychosis. And so I think there's a real opportunity for even just very basic interventions, non-pharmacologic interventions that we could even be doing now for people living with Lewy and their caregivers, as well as the fancier non-pharmacologic interventions relating to stimulation.
Toward the end, do we have time for one more question?
Yeah, so I was interested, thank you for that presentation. I was interested in shifting a little bit. Yesterday, there were some comments about educating the primary care providers. So I'm just interested with Diamond Lewy, that toolkit. How do you measure if that information is getting disseminated to the primary care providers? Because we tend to silo ourselves into our academic centers or I speak to our primary care providers because they give me patients who are moderately to severely demented. And I don't blame them because they're all overwhelmed with everything that they have to do. So what are your thoughts about education for the primary care providers? And given that we don't have a mandate to do Diamond Lewy in the US.
It's an excellent question. This is just personal opinion. I think helping primary care physicians raise awareness that there is a thing called Lewy body dementia, and to trigger a referral, that is a major step in and of itself. I know very few primary care physicians who are comfortable managing. They still defer to the neurologist, psychiatrist, and physical medicine, and I'm not sure that'll change much ever. Yeah.
Nina?
There's another.
No, I was just
okay.
going to add to when we did the Diamond Lewy work in the UK, we decided to try it out in our sort of secondary care services. So some services were randomized and introduced to the management toolkit and educated about it. So I suppose our secondary care services would be aware of the condition, but maybe not expert necessarily. And whilst the evidence was, I would say a little tentative, it did seem to reduce caregiver depression, and also the caregivers rated the patients as better globally. So I think there was some tentative evidence. I mean, I think the key thing is we couldn't mandate you must do this in every clinic visit, you must apply the toolkit. We just encouraged them to use it. But I think it was still interesting that this holistic approach did help. So, you know, that's all I wanted to say from the UK evidence side of things.
Okay, there's a comment and a question online from John Shao. Should we be developing something comparable to the MIR in FTLD, but specific for DLB? And there's a second part to that, but I guess Brad maybe could answer that and describe what the MIR is.
Sure. Multi-domain impairment rating scale. So it's an expanded version of the FTLD CDR, now with a motor component and a few other components for the greater FTLD area. But this is exactly what John Paul was talking about, the Lewy Body Dementia domain rating scale. That's the intent. Be as global, cover the major domains.
And then the second part to John's question was, what about the DLB module of the ADRC UDS, which I guess Jim could answer, perhaps?
Well, the LBD module that was created obviously was a consensus-based approach to supplementing the UDS to capture domains that were relevant to Lewy body diseases that weren't already incorporated. And we were restricted a little bit by also the restrictions of the UDS, is that you can only use tools that are either were willingly given or that we developed. So for example, we would have loved to include the Epworth Sleepiness Scale, but we couldn't get permission. So we had to find something else. So we chose the SCOPA sleep scale, which has a lot of the same sort of properties, but isn't as commonly used. But I think it enhances our ability to do assessments of Lewy body diseases by incorporating sleep, fluctuations, autonomic symptoms, the visual perceptual deficits that are seen as the cognitive profile. So I think that really enhances our ability, and there's some evidence that the module really does help characterize the LBD cases better. So I think that I would love to reconvene that work group and maybe expand it a little bit without adding a lot of work to it, so that it complements UDS 4. Because again, we designed it based on what was in UDS 3, and there are some additional measures in 4 that I think can be complemented. So that could be something for the future.
Great. And Dr. Biber will be talking about that later today as well. And then the last comment online is from Julia Wood, noting that LBDA has adapted the Diamond Lewy toolkit for US audiences, with a link for anyone interested.
Yeah, I'd like to ask a question to the panel about the clinical trial sites and the consortium. Laura, you remember back in the Alzheimer's days that it got very tough to do clinical trials in academic settings. It got to where the institutions didn't want the trials because the overhead was capped at a lower rate. Investigators wanted to be part of it and sometimes had to raise philanthropic dollars in order to be able to afford to be a site in these NIH trials. It sounds like things are getting off to a good start in DLB and, with the research centers of excellence that you mentioned, Brad. But do people feel like the infrastructure is well enough funded? I think the ACTCs, for the first time, actually give grant dollars to sites. Okay. Is it well enough funded in DLB?
Can't really talk too much about DLB. Whoops. There we go. Obviously, we're further behind in DLB. I mean, the ACTC can do DLB trials because we have a network of sites, but I think it's spot on. However we do this, sites have to have support, regardless of whether or not a trial is active. And that we found that out through our first iteration of our network, that's part of the issue. So I think whatever gets developed, we have to provide on-site support for not just the PIs, but coordinators. And we also, like ACTC now has a community outreach coordinator that's part of the funding because, in order to bring in more diverse populations. So you have to have that level of support with the network or you're not going to get the participation. Yeah,
I think that's critical or it's not going to happen in DLB.
Could I make one more comment? LBDA experience. We were really concerned purely from a DLB clinical trial standpoint. What was the effect of lecanemab to the cognitive sites? Because it's a radical practice change for everybody now using anti-amyloid therapies. And we've made that transition. And I don't know if it's really affected DLB clinical trials like we thought that it might. So in hindsight, this is probably quite good.
Right. The failure of uptake of treatment because of our fragmented healthcare system, is allowing our trials to proceed. And that's great. But, I think we have a lot more to do, and organizations like the NIH, NINDS can do this because it's a top-down approach. And without that, being regularized across the country, I don't think the enterprise will survive. And on that note, thank you to the panel and also for all of your questions.
All right. So let's get back on track. So my name is Amir Tamiz. I'm Associate Director at NINDS and lead the Division of Translational Research. I do want to thank Nina and Deb one more time. This kind of meeting is not easy to put together, and this has been super informative. And I want to thank you for all your hard work. It takes 6 to 8 months just to get from a concept to where we are today. And so if you're going to see them again on the way out, a big congratulations and thank them for what they've done. It's just been tremendous. So the session we're going to focus on today, we're going to focus on 4 topics. We are going to try to reduce everything we talked about over, especially today, down to 4 things. One is the type of target you're going to start thinking about as part of a clinical trials. How do you stratify patient populations? We talked through those. How do you evaluate progression of the disease? Because that's actually a critical part of making sure whichever target you go into interrogate is going to be having a readout in a meaningful way and in a speedy way so that it's actually going to attract investors to want to move in the space. And then how do you measure response to a treatment that you would like to study? So with those 4 topics in mind, we're going to go through quick presentations, roughly about 15 minutes each, and then we're going to open it up for discussions. So with that, I'd like to introduce Richa. Please introduce yourself, tell us a little bit about your background, and you'll be on the clock for 15 minutes.
All right, I better talk fast. Okay, so I'm Rochelle Duty. I'm a neurologist by background, neuroscientist, cognitive anthropologist. What I'm doing now is not the topic of my conversation today. I'm going to set the stage, sort of general issues, but my background includes having been, an Alzheimer's Center director, done clinical practice in the past, and then I worked for Roche in the big pharma, starting their neurodegeneration franchise and really expanding out some of what I'd learned in Alzheimer's disease to Parkinson's disease, Huntington's disease, and other. Started with a new company that just came into being on October 31st called Axiom Life that will be dedicated to neurodegenerative diseases. There's a platform approach to an active immunotherapy. We heard about one a little bit earlier today, but it's very different. And that is not what I will be talking to you about today, but perhaps sometime in the future. So to begin, I guess I'll push this button, see what happens. Okay. So just some overall design considerations as we think about what we need to do in dementia with Lewy bodies. These questions have come up. So today, when I raise them right now, there's the resonance of what we've said over the course of these 2 days. Can we actually define the population using standardized criteria? And then we had a little bit of discussion about, can we and should we also be stratifying the population? Stratifying is different
from using a biomarker to select inclusion or exclusion criteria. When we think there's a real difference, for example, dementia with Lewy bodies that starts in the limbic region and the basal forebrain versus dementia with Lewy bodies that works its way up the brainstem, should we stratify our studies so that we include both populations clearly defined? Do we need to limit our study to a certain stage of disease? And if so, we've already heard that there's a little bit of difficulty with DLB in saying whether people are early on in the middle stages, the late stages, how close they are to terminal stages. This is something that isn't well worked out. We always have the more pragmatic questions. Will recruitment proceed quickly enough? You know, there are 20 research centers of excellence. They're going to be 27. Is that enough to do a clinical trial in a timely manner? How do we demonstrate target engagement, especially when we can't image alpha-synuclein, and many of our treatments are targeting alpha-synuclein right now? If we can't image it, can we infer it in some other way? And most of the time, we don't like to proceed to clinical trials unless we have proof of target engagement. Do we know what our primary outcome should be? And again, we've heard a lot of discussion. If we use a broad scale that encompasses everything that could happen to you because of your dementia with Lewy bodies, we're going to have little movement on the scale. If we use very targeted scales, should we be doing studies in very sub-selected populations? How long does our study need to be? We didn't hear as much discussion about that. Do we know enough to generate a power calculation? Okay, so we need to know what's going to happen in the untreated population over time, how many people are going to drop out, and what treatment effect we expect out of our intervention. And finally, can we afford to do the study? Okay, because once you do all of that, then you put the numbers on it. So neurodegenerative disorders, since I'm talking broadly about it, are often defined and differentiated by which proteinopathy is involved, as well as the anatomical and neuronal vulnerability. And we raised the question earlier and several times about selective vulnerability. So there's certain areas of the brain that seem to be selectively vulnerable to certain proteinopathies. And we also raised the possibility that within us, certain host factors or genetic factors or whatever factors they might be, that could even be environmental, make us more or less prone to proteinopathies or to a certain proteinopathy. So all of these disorders, Alzheimer's, Parkinson's, Huntington's, have these things in common. They have time course that unfolds over decades, and most of them are mostly sporadic, although there are certainly exceptions to that. What about DLB? Well, we know about alpha-synuclein. We also are pretty convinced about the cholinergic deficit, selective vulnerability, nucleus basalis, brainstem, striatum, limbic system, cortex. Unfolds over decades, mostly sporadic. So it fits into the general category. So the features that these disorders share that we need to know in order to think about designing trials and what we should take from one disease to another. There are the accumulated abnormal proteins, there's synaptic abnormality, and that generally precedes neuronal loss. So there is a potential for reversibility when you have things in the disease process that are affecting synaptic function that you might be able to reverse. They all have long preclinical prodromal periods, which makes us happy because we could potentially exercise secondary prevention approaches if we have safe enough interventions. And that is the plan with our new company, Axiom. We might even go into primary prevention, because if you have an intervention that is inexpensive and looks safe, you could give it to people who don't have, for example, amyloid in their brain, or who we know are at risk for a certain disease, but they don't yet show signs of pathology. And finally, aging is a driving factor in many of these conditions. So I just want to summarize at a very high level some of the learnings that we've had from Alzheimer's disease that we've translated over the course of the last several years into treatment trials for Parkinson's disease and Huntington's disease. Okay. One thing we learned is that populations are segmented in some way on a temporal spectrum, from preclinical to prodromal to mild, moderate, and severe. Don't forget about moderate and severe, because in clinical medicine, we need to treat everybody. And the worst thing you can tell a patient is it's too late. You should have come earlier. Okay, so don't forget about it, but we may have to approach these different stages different. And this is happening now. You see it in Parkinson's disease. The new criteria that are being created are almost following exactly what happened decades ago in Alzheimer's disease. Cohort studies are critical. So oftentimes when we're trying to develop a treatment for a neurodegenerative disease, we also have to kick off at the very same time a natural history study. So just imagine, we did this with Huntington's disease. Imagine the extra cost involved and the extra logistics if you also have to find sites that are not going to be in your treatment trial, but are doing natural history study of the population. And if you don't have that, you can't even do a power calculation. You can't estimate change over time. Biomarkers clearly useful in helping us to identify what stage of the population we're dealing with. And we have learned from Alzheimer's that certain biomarkers can help us pick out who is going to experience more rapid progression. So for purposes of clinical trials, this is very helpful. Study designs are similar by stage. We do the same kind of study, but then we segment the population. The things that are similar are the analytic methods, the estimand strategies. In other words, what do you do with missing data, and the duration, okay? Treatment response clearly may vary by stage. So I want to show this AD continuum for a minute just to make a couple of comments. First, it's great that we can identify a preclinical stage. We have this thing that's a little bit artificial that we call mild cognitive impairment. When it first started to be discussed, there was a lot of controversy around it. In fact, it wasn't even an amnestic disorder in the beginning. We had to have a lot of discussions in the field before we converged around amnestic MCI being the important thing to approach when we were thinking about Alzheimer's disease. Then there was mild, moderate, and severe. This is one of the few diseases where we have to develop our treatments segment by segment. So the first treatments that were developed were for mild to moderate Alzheimer's disease, and we absolutely could not use them for MCI or severe disease. There were tremendous penalties and restrictions for doing so. I mean, there were clinicians in Canada who had to pay back the government because they gave cholinesterase inhibitors to a severe patient, or failed to stop the treatment when the patient became severe. So we get painted into these corners, and this is something that I think we need to try to avoid in future drug development, either by parallel designs or even basket trial designs. So some of the learnings, those were learnings from Alzheimer's that have been brought to bear on other neurodegenerative diseases. Some of the learnings from Parkinson's disease that have translated pretty well into Alzheimer's and Huntington's. Digital outcomes, okay? Smartphone, Apple Watch based in particular, can be implemented in phase 2 and phase 3 studies, and they can be analyzed to reflect change from baseline. In the case of a medicine that I worked on in the past, prasinezumab, which is in phase 2 for Parkinson's disease right now, the digital measure, which certainly derives from observations and assessments that are similar to the MDS-UPDRS. However, it was different. It was an independent measure. and it was conducted in a different way. You asked the patient to do it 5 out of 7 days of the week, and the adherence was very high. Okay, so patients interacted with the phone and answered questions, and also the passive monitoring of the watch took place. Well, the fact that the results were very similar for MDS-UPDRS Part 3 and the separate digital outcome gave enough confidence that that drug went on to a second phase 2 study. Otherwise, it would have been killed if it had only MDS-UPDRS Part 3. Why is that? Well, regulators prefer MDS-UPDRS Part 1, 2, and 3. Okay. But we were talking about that a minute ago, JP. You know, if you start clamping everything together like constipation and depression with tremor and rigidity, it doesn't make sense anymore. That scale was never designed to add all those things together. And you can't show clinical benefit, but we could show it on the motor, and it was supported by the digital. Another thing is that these digital measures were really very well tolerated. So a very big plus is that when you go and talk to regulators about digital outcomes, what they tell you is then applicable to all. Okay, so you don't have to reinvent these regulatory approaches for every specific disease. Learnings from Huntington's that could have been or have been translated into Alzheimer's and Parkinson's. Well, the big learning that we had was about intrathecal drug delivery. Obviously, this is not desired. We would rather never inject anything into the central nervous system, but you can do it. And you can do it multiple times, and it's very well tolerated. So now there are antisense oligonucleotides under development for Alzheimer's disease as they are for Huntington's disease. And I really wouldn't have predicted that a long time ago. Or viral vectors being used to inject ApoE2 into the CSF in order to counteract the effects of ApoE4. We've also learned that the involvement of the disease community in an advisory capacity is incredibly helpful. So, you know, we had a patient who was Huntington's positive, or he was positive for the mutation, who sat on an advisory board and advised about everything. We had another person who had lost a husband and 2 children to Huntington's disease. So very, very helpful. And also we learned a lot about assay development. And this is particularly important if you ever want your drugs to be used outside the United States, in Europe, for example. You have to have in vitro diagnostics. That's not the same thing as a really cool lab test that someone can do in their lab. You know, an in vitro diagnostic is a really big deal. You have to be able to measure something without a lot of pre-analytic handling. It doesn't matter who does the measurement. It should be an automated machine that everybody has available. You should always get the same result when you use the same sample. And the score of positive or negative or high or low shouldn't change over time. But in lab-based assays, those things are not true. Okay, so we really have to early on introduce goals and incentives for people to, if we have a biomarker that we think is going to be very useful, we really have to push for it to be a lab-based assay. And we learned a lot about measuring mutant Huntington. We don't have that test yet. You know, we heard discussions today about, well, we should really be looking at NFL. It's very promising, but we don't have an IVD for NFL. So it'd be tough to do it in a multi-center way. You know, with all of this work, there are a lot of drugs in the pipeline for Alzheimer's disease. Just showing you the fact that the outer rim is the phase 1 studies, middle phase 2, inner rim phase 3, divided by types of therapies and their targets and a lot of different mechanisms. The point I wanted to make with this slide is that the entire time I've been in this field, there have always been multiple drugs under development targeting multiple different mechanisms. And we don't do a great job about educating people to that fact. And so we hear a lot about, oh, companies are all leaving the field and no one's going to do neuroscience anymore. We need to counter that. Otherwise, the public we don't have the support of the public. Challenges for DLB drug development: despite advances in clinical characterization, it's still challenging to select the patients with the right degree of pathology. Mixed pathologies are so common that make cognitive deficits multifactorial. It might just make sense to jump right to combination approaches in this field. Outcome measures don't capture all aspects of the disease. Heterogeneity limits the utility of one measure, while composites will be insensitive. And do we really have enough molecular targets for DLB yet? I'm not sure. So in conclusion, despite dramatic differences in pathogenesis, phenomenology, and progression, drug development for neurodegenerative diseases is, I think, more alike than it is different. And for all of them, it's largely informed by the experience with Alzheimer's disease. Experience with each of these diseases can enhance some aspect of drug development for the others. The development and use of biomarkers for target engagement and treatment response, the development of digital outcomes, the construction of natural history comparator studies designed to be parallel to what we're doing in the treatment trial, patient engagement and research and development, and then models for broad partnership. There is no one government, laboratory, company that's going to solve any one of these neurodegenerative diseases. It will take everybody, and successful leveraging of the learnings from one disease to another will speed drug development for them all. Thanks.
Good afternoon, and let's see how we do this. The push. Oh, here I am. Okay. So thank you very much for this meeting. I have learned an enormous amount. So originally, we had an Alzheimer drug. We didn't know how it worked, and it has been kind of moving. So let me show you. About 7 years ago was the first time that Peterson published that Alzheimer's is not homogeneous. It has a number of neurotoxic aggregating proteins. And in the meantime, we're talking here about DLB, LBD, and PDD. We know we have mixed pathologies. As I told you, our drug started out being an Alzheimer drug. And in the meantime, though, we learned that it inhibits amyloid, it inhibits tau, it inhibits alpha-synuclein, it inhibits TDP-43. And then the question for 8 years was, how does it do that? And what we discovered is that the mRNAs of these proteins have a homologous region. That's the gray zipper you see there. That region is identical in all these mRNAs. And that region binds to a protein, an RNA binding protein. And when it's bound, the mRNA is not translated. When it's free, the mRNA is translated. When a lot of iron flows into the cell, the iron regulatory protein remains open, and all these mRNAs are overexpressed if they exist. And if they don't exist, obviously there's nothing to express. Our drug keeps the gray zipper, that homologous region, bound to the RNA binding protein. And that's really how our drug, with a very, very high specificity and high affinity of 3.2 nanomole, keeps the mRNA bound. As I said, it only took 8 years because we really didn't know what we were looking for. So we went public because I couldn't raise enough money to do clinical studies. And then we did 2 phase 2A studies, one in Alzheimer's, one in Parkinson's. The data looked promising in both. I'm not showing you this data, but because the data looked promising in about 70 patients, we decided to go into a phase 2/3 for Alzheimer's. And this is a dose ranging study. It's in 300 patients, 7.5, 15, and 30 mg. And the inclusion criteria were, in hindsight, too broad. We did not do a tau selection because it didn't exist in plasma when we started, and the MMSE was 14 to 24, because as Rachel said, it would be nice to have something for more advanced patients. So overall, we did not meet our endpoint. In the ITT population, we did not meet our endpoint. When we, however, separated the patients with the t-tau ratio into patients that had Alzheimer's or had amyloid and didn't have amyloid, and then further separated into the moderate ones and the mild ones. In the mild ones, we saw a very nice dose response curve that is statistically significant from placebo. And that is in 92 patients, which it should be here. So I'm going to go through quickly, but just to make sure it wasn't a fluke, we also looked at the same early AD population for APOE4 carriers and non-carriers, and it shows an improvement in cognition in both. We looked at patients that were on acetylcholinesterase inhibitors and non-acetylcholinesterase inhibitors. Again, it showed an improvement in both. And then we looked at plasma biomarkers. Now in our phase 2A, we did have CSF biomarkers. So we had a lot of biomarkers, including a lot of inflammatory factors. We were then restricted to plasma because it was a 300-patient study. And as I said this morning, we saw a decrease in GFAP, in NFL, in TDP-43, and in tau. Now, for your information, we saw a decrease in TDP-43 in our phase 2A in Alzheimer's and in Parkinson's. So it's there. With this data, it's safe. So we looked at safety in APOE4 and in non-carriers, and we really don't see any difference between APOE4 carriers, placebo, low and high dose, and APOE non-carriers, placebo, low and high dose. With this data, we went to the FDA. We had a meeting in October. We presented the data, and they cleared us to continue with a pivotal study. They agreed with the tau selection. In fact, they told us that there are 3 ways of selecting for amyloid in patients. One is PET tau, one is CSF beta 4240, and the other is p-tau 217 level in plasma. So that's what we'll do. They were open as to whether we want to reproduce the symptomatic activity or do a disease-modifying study. And this is the study we decided to do. So we will select by p-tau 217. The age, well, is normal, 55 to 85. MMSE will be over 20. Primary endpoint ADAS-Cog 13 and ADCL-IADL. The interesting thing about Alzheimer's is the FDA is very sure about what endpoints you want to use. These are the endpoints, period, okay? So we will use 600 patients. 30 is the dose we decided to use in Alzheimer's and in Parkinson's. And the reason we go for 600 patients is really not the ADAS-Cog. Depending on whether we see a 2.5-point improvement or 3.5-point improvement, we need 30 or 50 patients. But the IADL, we kind of backtracked from the ADL that showed a trend in our phase 2B, and we think we need about 200 patients per group. Since we want to make sure we hit it, we're going to add 100 patients per group. So in summary, for Alzheimer's, it was pretty straightforward. We have heard in this meeting, Alzheimer's is straightforward. Maybe it wasn't 10 years ago, but in the meantime, it's pretty straightforward. You can select the patients. You have ways of looking at biomarkers. You can look longitudinally. You know what you're looking at. So the study we will do will start next January, and it is the 6-month study. We decided to first go and reproduce the symptomatic activity. Now, I was telling you, it doesn't work in MMSE 14 to 20. From a clinical study point of view, it doesn't make any difference. From a patient point of view, that's devastating because every drug, be it an antibody, be it a novel molecule. Every drug tested to date doesn't work in high tau, doesn't work in moderate, and we really don't have anything. So this drug also works in early. So after the phase 2A in Parkinson's, we went to a phase 3. We were a little maybe too overambitious, but let's call it a phase 2/3 or a phase 3. We did 2 doses, 10 and 20 mg. We used Honeyar 1, 2, and 3, and off stayed less than 2 hours. So we made sure they were not too advanced. And then the FDA said UPDRS2, which is a functional endpoint and is quite hard to hit. In fact, most drugs, all dopaminergic drugs don't have it, UPDRS2. And then 3, and then whatever. So the ITT, again, didn't work. Sorry. Oh, I'm showing you what worked. We had an exploratory endpoint. We had an exploratory endpoint that was MMSE. Whoever thought of MMSE? If I had thought a little bit more, I would have used the MoCA. But anyhow, it's MMSE. And to our amazement, in the ITT population, we see that placebo goes down and the treated patients stay the same. And that's statistically significant. And then in the patients that were impaired, we see that they improved by more than a point. In the MMSE, that is a more enormous improvement. Now, we went back to our Alzheimer data and said, well, we really never looked at MMSE, but let's see if we see an improvement in MMSE, and we do. So also in our Alzheimer data, we see an improvement in MSE. So that's the positive. As I said, MDS-UPDRS2 and 3 didn't work, but in the per protocol population, which means we took out the patients that did not stick to protocol. And to my huge amazement, we had way more than we should have had. And the reason for that is we had a lot of sites that just took everybody off the street, but it's too late to worry about it. So this is the per protocol population. You see that we have actually a really nice trend and statistical significance from baseline in 2, statistical significance in 3, 4 total, and then again in this population also in MMSE. So we think that this data is good enough to go to the FDA and ask for an additional study. We are still doing the biomarkers here, but what we already have is in plasma, neurofilament light, and GFAP. We didn't take skin samples, so I'm not really sure how to go back and look at alpha-synuclein since we also don't have CSF. But we will, in the next study, do skin samples. Basically, right now, for Alzheimer's, we're in pretty good shape. We know how to proceed. For Parkinson's, we're putting together a KOL group to help us with this study and help us with the FDA. Safety is the same. We have treated over 1,000 patients, and the drug is safe. To give you the breadth, the first side effects show up at 160 milligrams. And we are using anywhere between 5 and 80, and our actual going forward dose will be 30 milligrams. So the drug is safe, that is good. So in summary for Parkinson's, we have cognition in the ITT population in the patients that are impaired. We see an improvement in UPDRS2, 3, 4 in total, and MMSE again. And we will want to go to the FDA next year. So where does that leave us with DLB? So we have good data in Alzheimer's, cognition, and in Parkinson's. We have some function in Parkinson's, but DLB is way more than cognition and movement. There are all these symptoms in between that we don't know. So we're taking a risk because I would prefer to look at all the symptoms while with different tests. I don't know. What I think is very important is that we figure out how to do this study. Our drug, from a mechanistic point of view, gives the opportunity to actually work in DLB because it inhibits APP, inhibits tau, it inhibits alpha-synuclein. How exactly we designed the study, I'm not sure. I think we have, no, I don't think, I know we have 3 studies that will report data by the end of the year, early next year, that will really inform how we move forward. And as I said, we're looking for a KOL for PD. We're also looking for a KOL group for LBD. And this is us. We are a really small team, but I think we have a pretty good clinical team. So clinical research and CMC, we are really good. This is our Alzheimer advisory board. And then we have an enormous amount of vendors and collaborators because we ourselves are too small. Thank you very much.
Hello, while we wait. Oh, Julio. Thank you, Julio. So there's someone on the back that is helping all of us, and I want to make sure that we all thank him. So the other thing is, I have to thank 2 people here. One is Angela, and the other one, Steph, for having me here. I thought, guys, I don't have any drug for DLB. We're not on the space, but they know how passionate I am about synucleinopathies, and they know me from different meetings. So that's why I guess, and I was trying to think about again introducing myself, as Amir has mentioned. So I used to play midfield when I was playing soccer, and this is a little bit of a the same. Like, you look at everywhere in the pitch, and if your team needs you in defense, that's where you go, and if they need you attacking, that's where you go, and you give the pass and you try for to score the goals. It's the same role that I'm taking in this meeting. So it's been great to talk to a lot of you, reconnecting with some of the people that we've been talking for a while, and then let's get started and let's see how I see the pitch in general. So this is what also Deb told me. This is what you can contribute to this meeting. So again, let's see if and I'm not saying many things that are new. I think there are a few things that I am adding to the wish list that we should at least keep in mind. So I'm an employee in Stockholm from Sanofi. I was also the co-chair with Deb for AMP PD, the Accelerating Medicine Partnership for Parkinson's, to which the second phase we've added other related diseases. So DLB is part of this, and I'm not talking about anything, any molecules, and this is me, not my company. Although I forgot, and I had my Sanofi thing on the bottom of every single slide almost. Okay. So I think we mentioned this, and and Rachel also said, this is the other thing. When I was looking at Rachel's slides, and we didn't coordinate, although Amir had us talking all together. I saw the things that were coming, and I feel like my presentation it's very it's complementary, but also supplementary to what Rachel was talking. So a little bit of the DLB, and there's a mix of pathologies, and depending on the stage of the disease, there's different interventions. I think we have molecules, or at least we're paying attention to all of these aspects. There are probably more things that I'm not even listing here, but these are broad categories. Proteinopathies, inflammation, neurodegeneration, and vascular contributions to the disease. Something that is very important for disease-modifying therapies is the progression of the diseases. So we need to keep progression in mind, not just the cross-sectional. So this is someone that knows. I said, I'm trying to talk about the key challenges for the, and she did all this for me. So thank you, Susu, for helping with all of this. So there are basically five challenges. We categorize it in 5 different challenges. So for DLB specifically, and thinking about overall neurodegenerative diseases, we've been doing some of the research and early development for diseases like Gaucher disease. Okay, so it's a monogenic disease, just one gene affected, but also very clinically it's very diverse. So how do you do that? And now we have a molecule that gets into the brain, and now we're running the trial. And we've used, that's a molecule that basically many people know me for, venglustat, GBA-PD. It's the same molecule. We'll continue to develop it, but only for a rare disease. We were working on SMA before Biogen, and we dropped that because we couldn't convince our board to go for it for other reasons. So we're very well plugged into the rare space and also the large disease indications. So diagnostic complexity for DLB, it's one of the aspects. The other one is the heterogeneous pathology. I'm not saying anything new here, but you'll see that in the how to unlock this. I think there are a few things that are new. Very few biomarkers, and for biomarkers, we focus a lot on fluid biomarkers, but there's a range of biomarkers that we should be paying attention to. The fluctuations, I think that's one of the biggest deterrents for anyone that needs to power a clinical study. If you have the fluctuations, how can you account for this? And it's our limited understanding, I will say. And then safety concerns. I don't think we mentioned them a few times here and there, but we haven't not mentioned them as much as I would like to hear it. So how do we unlock this? And what are the aspects that maybe we met? Some of this we mentioned. So for biomarkers, we mentioned having more biomarkers and fluid biomarkers progression, like how do they compare 1 year to the next, etc. But also the digital tools. And Debbie did a great job earlier today, and I think we're going to see that in the next 10 years. The same way as I got a friend back in Argentina, getting diagnosed of hyperthyroidism with the watch because their heart rate changed, and then basically she got go see your doctor because your baseline heart rate has changed in the last month and a half or something like that. So then she went to see the doctor, and it was a hyperthyroidism. So the same thing we're going to see for all of us, whether we can share or not our data with the or we can see it ourselves. That somebody's going to tell us you're taking less steps versus last year or in the last month, and then you can make your own decisions whether is this because I was sick or I broke my ankle or whatever. But this longitudinal data, it's going to exist in the cyberspace. There is something else that it's coming that I really liked it's invisibles. So these are units that you plugged into your in the bedroom, and basically they can track how fast you get up from bed, how are you walking, etc., and whether you have or not REM behavior disorder. They can measure your. This is a technology that I like, that I want to see more data for. And then connectivity. That's another piece of the biomarkers that we are not talking about. The way I see the disease, and we talked about this also, it's like there's a biochemical deficit that translates into a cellular deficit. Neurons are sick and then they start dying. Then we have circuits compensating. This is one of the biggest differences between preclinical and clinical. Animal models have very few ways to compensate for these deficits. We have a cognitive reserve and a reserve for everything, even for motor, that is way larger. So then one circuit is gone, but then the other one is compensating. And then when the second or the third or the fifth circuit is gone, then that's where you see the clinical phenotype. So we need to go early. And then that's what I was asking also, is there a way to push the systems to try to see differences before they occur, before they become so evident. So trying to find this connectivity and whether it's fMRIs, DTIs, EEGs, I don't know what it is, but and it also talks about specific areas. So if one area is affected, but then maybe synuclein, with the plus minus SAA, we cannot see what is exactly what is happening and how that translate later on more pathology. And again, it's a wish list, by the way. So understanding disease progression and pathophysiology. So the natural history studies, good data. This is, I have to emphasize that good data, get us to good outcomes. And then enhanced cross, I have this, cross disease studies, and I think we've seen that this is happening. So people are looking at, in Alzheimer's disease, or what we used to call Alzheimer's disease. I think, that it's being redefined a bit more, making sure that we have all the biomarkers for every single neurodegenerative disease. And again, this is one of my dreams. I dream about this. We should have this as a big umbrella. So it's Alzheimer's, Parkinson's, DLB, but it's also MS. It's also Gaucher type 3. It's also it's ALS, it's Huntington's disease. And then we're starting to build that map. And it's a roadmap for all of these indications, and which circuits are breaking and how are we going to fix them, and how can we prevent them from either breaking or helping the compensating mechanism to just stay a little longer. Clinical trial design. I don't have to belabor this. I think Rachel did an amazing job, but having that biomarker-driven selection, I think is going to be critical for all of us. And then consider the adaptive and platform trials. This is something else that something to keep in mind when we are designing trials. Early intervention. I think we always want to go as early as possible, but let's not forget everyone else. And then consider risk reduction approaches, which, by the way, we were talking about this during the lunch break. Everybody should be sleeping well, eating healthy, etc. We don't need to be reminded of this. Aging is, if we call aging a disease, we're all going to get older, hopefully. And then resource and data infrastructure. I think this is another place where the Alzheimer's field, and I would say let's try to use the resources that are available as much as possible. If we can use those repositories, if we like the repositories, and I'm not going to talk about which ones we like and which ones we don't, but have that. And then also not only yesterday there was the conversation about brain donation. I will go a little bit further from that. If someone is considering brain donation, why not donate CSF before, and even a few years before that as well? So I think it's good, both CSF and blood samples. I do want to talk, I don't want to belabor on this, but this is happening for neuronal synucleinopathies. It's already happened for Alzheimer's. How can we combine these two in some staging system? We discussed it earlier today. There are two systems that at least have been proposed for synuclein. And I have that caveat there. It's research use only. I think we need to be cognizant of, we're not ready to roll this out, as this is, how we're defining or calling Parkinson's disease today. This is for us to identify disease populations. Sometimes some patients or some caregivers want to know, do they have synuclein pathology? Yes, you have it or not, but that's for them to decide whether they want it or not. But it's research use only for now. So I will encourage us to try and include the DLB in some aspects of the neuronal synuclein disease, and or have the DLB, which is a mix of Alzheimer's and Parkinson's. Again, I was thinking about what are the pros and cons of doing this, and I think that in the Alzheimer's, and this has been done also for Huntington's disease and other indications, and it comes from the oncology field. So it's not, we're not inventing anything, we're adapting it to our needs. And then what are the pros and the cons? And today I can tell you that the advantages of this are much better than the challenges that we have for this from personalized treatments. It's copathology. Like, we need to understand this better in order to be able to provide the proper treatments. And having the voice of the patients or the caregivers always being heard. Again, I like mostly on the pros side. I don't know if it might be a selected population, as it happened to me a few weeks ago, talking about other aspects of our current state of affairs. It takes a village. I just wanted us to remember that. And it's this and the empathy. I think those two aspects that we need to be reminded of. Just listen and influence and be influenced. It takes a village. We're all trying to do the best with the tools, with available tools, and prioritizing accordingly. No, thank you. Right, so I'm John Allen. I'm founder and CEO of ServoMed. Until a little over a year ago, it was EIP Pharma, so a lot of our publications will have EIP Pharma on it. I'm a physician, scientist by background in the industry for more than 30 years now. So I'm mainly not going to go through the neflamapimod clinical data as much as in this context talk about what that teaches us about the disease and drug development. I think when you have a very specific drug with a very specific pharmacological and biological effect, it can really drive disease understanding. And I think it'll become more obvious as I go through this. So do I click? Okay. So our drug is neflamapimod. It's a small molecule oral p38 alpha kinase inhibitor. There's a lot of science behind this. It comes from, something's cut off on the bottom here, from the lab of Ralph Nixon at NYU Langone, who's been our primary academic collaborator. I'm not going to go through the science other than just to say the axis of p38 alpha and Rab5, which is the primary target from a disease pathogenesis standpoint, is downstream of neuroinflammation and the various aggregated proteins. So fundamentally, from our standpoint, we don't actually really care about the protein driver, pathogenic driver upstream, more that the patient or the context we're in, there's cholinergic disease and the pathway underneath it. Ralph Nixon's lab has shown this. This is published in Nature Communications. In the Down syndrome model, there's a reversal of the cholinergic degenerative phenotype and normalization of behavior in tests associated with cholinergic function, as well as some of the molecular targets of effects there. They've actually replicated this in the Rab5 transgenic mouse as well, showing this reversal of the cholinergic degenerative phenotype. And then the published phase 2A clinical study, the results are here in the ITT analysis, which includes both a largely ineffective low dose and the higher dose. There's significant effect on CDR sum of boxes and on motor function or gait by the timed up and go test versus placebo. And then at the higher dose level, there is an effect on the cognitive test results as well. And later on, I'll talk about why we think there is a difference there, with the results being most prominent in the patients who did not have AD copathology assessed by plasma p-tau 181. And I'll go into a fair amount of discussion on that as well. It's important to recognize what we're seeing is actually on a number of the tests an actual improvement. It's what Rochelle was talking about in terms of reversal. If you are in the stage of disease where there are neurons where you're targeting synaptic dysfunction rather than neuronal loss and death and slowing that per se. And that's most apparent on the tension composite measure, which should be considered the most specific for the cholinergic system as well. But we see an effect that starts at week 4, peaks at week 8, and then maintains out to week 16 of treatment. And one of the distinguishing features of DLB in our view is this synaptic dysfunction stage is actually prominent in half or perhaps more of the patients, as opposed to in AD, where it's really primarily in the preclinical stage. And that may relate to the basal forebrain system and how it's and when in the process it manifests clinical disease. So lesson number 1 is a specificity of the DLB consensus criteria for diagnosis. We had the standard inclusion criteria in the phase 2A study, including including actually a DAT scan. And what we identified was a population that was robustly had DLB with exactly the cognitive deficits that you would expect in a
in a DLB patient population rather than an AD patient population. The only area we did not see deficits was in terms of executive function, in particular in terms of the naming test, the letter fluency and the category fluency test, which Jim Galvin told us about later on, that in fact in the literature that you don't see this in the mild to moderate population. It's something that develops later on in the process. But in terms of attention, working memory, the types of deficits that you would see, the criteria were successful in that regard. I think there is to tie into the literature, which I will do repeatedly here, it is actually, when we think in terms of DLB and diagnosis, in the literature, the gap is in terms of sensitivity. We miss DLB diagnoses, but patients who meet the clinical criteria actually at autopsy, in a high percentage of patients do in fact have DLB. And then more recently, with skin biopsy, in Chris Gibbons's publication, 48 out of the 50 patients were with DLB by clinical criteria were skin biopsy positive. And you heard from Doug in terms of the SAA positivity as well. I think the question, as I raised earlier, of the patients who are in CSF don't have SAA, but clinically have DLB, the data would argue they still have cholinergic degeneration and deficit. And that's these publications cited here, but it actually is a collection of papers now that very consistently patients who meet DLB clinical criteria, in fact, have either significant basal forebrain atrophy and or cholinergic terminal loss by FEOBV PET scan. And so from our perspective, we're targeting cholinergic degeneration. The DLB diagnostic criteria are actually great and sufficient to give us a patient population that we want to be able to target. And this concept, I think, goes along with both preclinical data and increasing clinical translational data, that there's a deep association between Lewy bodies and basal forebrain or NBM atrophy. And I'll point to the last paper in particular, which is effectively the title, that the MRI signature of CSF seed amplification alpha-synuclein positivity is actually atrophy of the nucleus basalis of minor. And if you combine that with one of the papers Doug also pointed to earlier, that the clinical symptoms that are associated in an AD population or generic dementia population with the seed amplification positivity is in fact the ones you go along with a cholinergic deficit. So visual hallucinations, attention, executive function, visuospatial dysfunction, and motor dysfunction. So that was lesson one. So lesson two is implications of AD co-pathology. In the phase 2A study, at the time we originally ran the study, there was no plasma assay test available. After the completion of the study, there were two publications in particular that initially came out that identified p-tau 181 as a way to identify AD co-pathology by CSF, or in the case of tau, by tau PET scan. And so we went back, tested the baseline samples. A little over half the patients had DLB without co-pathology, and 45 or then 40 had DLB with co-pathology. You look at the right-hand side, this is looking out of the statistical analysis difference to placebo and down is better. And this is mean and 95% confidence interval. In the all patient population, again, we had significant effect on CDR sum of box and time, then up and go. For both, the results, the magnitude of the effect goes up in the patients who have don't have elevated p-tau 181. That's in the middle for each figure, and then here and here, and then in the ones with elevated p-tau 181, on either measure, there's effectively no effect on a mean level. So very clear segregation of treatment response. And then if you look across all the endpoints and those without AD pathology who had below the cutoff, very consistent across all the endpoints, including on the memory endpoints, moderate to even large treatment effect size that are mainly significant versus placebo in even with relatively low numbers of patients. And this was published in Neurology last fall, with more detail. Now, what does p-tau 181 cutoff mean? At the time we ran the study, there was with the assay, there was nothing available with respect to DLB. We were actually using it, that 2.2 cutoff was prospectively defined based on an AD cutoff for CSF biomarker confirmed AD dementia. But in the last really 9 months, there have been several publications that go to that specific cutoff, seems to go best along with tau pathology by either PET or CSF, and in particular with A+, T+, which goes along again with the top, maybe even with AD as well. And then in unpublished data, we've been working with Charlotte Turnison, a 2.4 picogram per mil cutoff actually goes along with medial temporal lobe atrophy by MRI. And the overall conclusion is that the patients who have elevated DLB patients with elevated p-tau 181 are the ones who have either by tau or by MRI have temporal lobe neurodegeneration. And a general model that we're following is that those DLB patients who don't have elevated p-tau 181 have cholinergic disease, they don't have hippocampal atrophy, and that's what makes them responsive to a cholinergic directed therapy. And that represents about half of all patients with DLB based on all the data that's available at this point. And I think this is a specific opportunity to go after this group of patients with limited neurodegeneration and synaptic dysfunction being the primary driver in the cholinergic system. So next to clinical endpoints, where our perspective is that CDR sum of boxes, if you're going to pick one primary endpoint, and that's all you can do, that's the one we would go with. So in the phase 2A study, both the CDR sum of boxes and actually the timed up and go tests as well performed significantly better than the cognitive testing. And that is, we believe, is because it can pick up motor effects as well as cognitive effects. The CDR sum of boxes has the advantage that inherently it's not affected by fluctuations because it's meant to reflect the prior 4 weeks, as well as it's the informant. And then within our test study, a clear limitation was that, in a sense, for the cognitive tests where all the patients were on cholinesterase inhibitors. In fact, the tests we picked were the ones that are responsive to rivastigmine treatment from prior publications. And then again, this absence of an executive function deficit. But I think it generally goes to Jim's comment and other comments we've heard that cognitive testing in DLB is a little bit challenging. We also ended up picking the CDR sum of boxes for our the phase 2B study that's ongoing now. We did multiple power calculations. CDR sum of boxes was easily the one based on the phase 2A data that gave you the most statistical power. And if you look at our baseline data, both in Rewind LB and in Ascend LB, the phase 2A study, even in the patients, now Rewind LB is only including patients without p-tau elevation, the CDR sum of boxes score is actually robust, in particular in comparison to the AD phase 3 trials. Again, going back to that, the patients here, without having as much degeneration, still have significant clinical burden and a sufficient clinical signal to be able to actually detect a treatment effect. And then, that increase in DLB levels is consistent with a paper from Jim Galvin's group in 2021 that relative to AD, in particular on judgment, reasoning, and the three functional domains, the scores are higher in DLB, you get more signal. And this may be one of the fundamental things that a lot of these complex features on behavioral and motor function, et cetera, they read through into the functional domains on the DLB, exactly in a sense what CDR sum of boxes is supposed to capture. And then recent publication that it actually does follow robustly. There's CDR sum of boxes, there is progression over time. And then the last one is around GFAB, where, as I indicated earlier, I fundamentally believe that this is a great endpoint in DLB. There's 2 publications over the summer in AD and dementia generally, both on autopsy and PET scan, that it's not correlated to amyloid plaque, but to tau pathology. And they argue that what the astrocyte is doing is actually connecting amyloid to tau, that neuroinflammation, which is has always been part of the general concept. And then there's good data in PD correlating specifically to cognitive impairment and motor subtype. And then in DLB, as you heard, it's the first marker that comes up. And in particular, even when amyloid plaque is not there, before AD copathology, and it is associated with cognitive decline. And the Bolsovic paper actually makes this argument that it may actually be, it may be measuring DLB specific disease processes, which, as I'll come to, I agree with, because I believe it reflects in that early stage population cholinergic degeneration. So we did look at GFAB in the phase 2A study. At baseline, it is elevated both in the patients without AD and then further elevated in those with AD copathology, but it is elevated in the ones who don't have it. And then there is a, nope, she's not putting that. There is actually an, I'm sorry, I got those turned around. Very nice correlation to baseline CDR sum of boxes, which again is confirms some of what's in the literature. What we see is a specific effect in the patients without AD copathology, without elevation. See it on the left, significant p-value of 0.015. Placebo goes up marginally over 16 weeks, goes down in the neflamapimod treatment patients. We don't see that in the ones with elevated p-tau 181. And that effect is correlated to the outcome on the CDR sum of boxes. So if you look at the left-hand side, on neflamapimod treated patients in this group, the ones who have GFAB reduction, none of them worsen. 4 out of 9 actually get better. The ones who are non-responders in a sense to GFAB, 4 out of 5 worsen on the CDR sum of boxes. And if you do a simple plot of GFAB versus CDR sum of boxes change, it's actually significant at a p-value of 0.036. And we don't see that effect in the placebo group where it's more noise. Which again argues for a drug effect, but also that what you're measuring in GFAB is actually what leads to the clinical effect, which I think much longer discussion. There's a intimate relationship between neuroinflammation, cholinergic degeneration, tau pathology, and the astrocyte at the center of that, which is what I think GFAB is capturing. Again, all around arguing that GFAB is a good measure also of the cholinergic degeneration process in that context. One last point that doesn't come out of the phase 2A study, if I had one ask, is that we have a robust measure of NBM volume that we can apply across multiple clinical trials with firm cutoffs of what's abnormal. It is what correlates in a whole set of mainly individual center trials to clinical outcomes and disease progression. And we do have data out of one of our AD trials that there is a significant increase of basal forebrain volume, specifically NBM volume, as well as functional connectivity using both structural and functional MRI. We included that in our Rewind LB phase 2B trial, which is ongoing. But we expect to use that in a subset. We expect to use that MRI measure in a full group in phase 3. Primary endpoint in this trial is boxes. We're measuring secondary endpoints at timed up and go, cognitive test battery, CGIC. Tertiary endpoints, we're measuring fluctuations, UPDRS part 3, NPI 12, so we can look at sleep as within that as well, as along with the other measures that's in the NPI 10, and EEG and GFAP. Top line data in December and full presentation at ILBDC. And our hope is, at a minimum, we're going to show the world that we can actually develop drugs in DLB. Thank you.
All right. Well, thank you so much. So this meeting in Amsterdam must be a fun one because we're going to get a lot of information disseminated. So we have 10 minutes. I'm not in competition with Alice. She said she took 9 pages of notes. I only took 2 pages of notes, but I have many questions I would love to ask. But before I ask them, are there questions in the audience or online that we need to go to? Go ahead.
Maybe it's just my ignorance, but I have a question to Maria about the mechanism of this drug. So you say the drug kind of stops the mRNA, so it stops the production of APP, tau, alpha-synuclein, and TDP-43.
And prions.
Yeah,
and
but I mean,
Huntington's,
these
yes.
are all physiological proteins.
Yes.
So
Oh.
so it's
It
yeah,
doesn't
so
go back
that
to
doesn't
zero.
take-
It
Huh?
doesn't go back to zero. It's iron dependent. So when iron is high, okay. So this is the stem loop, okay? This is this gray zipper. This is iron regulatory protein 1. Okay, when iron flows in, iron regulatory protein 1 opens. The stem loop opens and the RNs to the ribosome, right? When iron is very high, this IRP1 remains open. When iron goes back down, it closes. So for reasons that are iron dependent, our drug does not stop, it regulates. The actual level of APP or tau or alpha-synuclein go down to about 40%.
Yeah, but how can this be good?
Ask
These are
God.
proteins we need. Well, for me, I'm afraid it doesn't make much sense. But
No, it
okay.
does. I mean, I can show you the
mean,
data.
Yeah, okay, thank you.
Yes.
Give me back my mic. This is something I've Pablo and I have discussed, and you're probably going to hate me for raising it, but I have seen a lot of really interesting data here. Is there a way to maximize some of the data for, within the limits of IP? So all this data that's being generated in the course of developing drugs, in the course of testing the animal models, and sharing it with the basic science community and the clinical community.
I'm not sure what you mean by sharing. CPATH, for instance, asks us to give samples. We give them all our biosamples. We publish as soon as feasible. What do you mean by sharing?
I mean, for your clinical data, the demographics, the results of all the tests your assessments for each patient, and sharing it in a common repository or sharing it with, rather than having each individual investigator coming to ask you for it.
Yes. I hate you irrespectively of the question, by the way. So
you're going to get it.
That's yes. So there are a few aspects. So one, it's placebo data should be shared across. That's my and I'm on a mission, by the way. So yes, and we should make sure that everybody gets this from even from an IRB perspective, because I think many times the consents do not allow us to share samples for sure, like that will be super hard to share samples, I will say, but data, it should be allowed. That's my, especially for the placebo arms. The drug arms, until we get to an approval, after the approval, yes, it's a part of our corporate responsibility and for all the big companies. I was pleasantly surprised to see earlier in one of the presentations that, things that are funded by NIH, they should be, putting the data back and even the samples. So I think we need to make sure that we enforce that, across. And this is part of our, commitment as a public-private partnerships, and we should do it.
So just to add on to that, and unfortunately, Dr. Ryan spent a lot of money collecting it. And if we could pool it with our other databases, it would just increase the sample sizes and provide more valuable data for people, for all researchers to look at, regardless of the medications.
Can I make a quick comment on the A4 data, just because we play with this data all the time. So all that data is available, including treatment status for each participant. So yeah, anybody can access that data via data request to the A4 team and can control for things like treatment.
Yeah, and I know they're trying to share it everywhere on Loney, and it is on Synapse. I'm not sure what the data use requirements are, but the imaging data and genetic data and clinical data are all there.
Anything else? So I see 2 minutes on my clock. So I'll have one question. So this is a great opportunity where we have industry representatives, academics, and government. And for a lot of reasons here, the path to get something out of academia into where you are, for example, John, is arduous. I admire the fact that you've just figured out how to do it, go through rounds of fundraising and all sorts of things. It's actually quite traumatic. I've been there. So if you had to reflect back, what is it that you would think we would benefit from globally if we had it in this community? Can you identify this one thing that if we could reverse time 10 years, that if you would have had it today, you would have said, oh, wow, this would have really changed the equation for me?
I think if 10 years ago, everything we know now, we'd known 10 years ago, that would have accelerated. So I don't know if there's one thing. What I would say is that what I'm seeing, I think that's really exciting for DLB community, is that how applicable a lot of the work that's been done in AD ends up being in DLB, and in many ways may actually work better in DLB than in AD, because I think it is a more in pure DLB or DLB without AD copathology, it is perhaps a more defined single pathogenic pathway around Lewy bodies and cholinergic degeneration. And what you see is I just run PubMed every 2 weeks now and just say dementia with Lewy bodies, and that pops another incredibly interesting paper, because the group in the community are just applying what they've learned from AD. And so I don't know if we can ever pull back that time clock, but it is just I think it's great, this transfer of knowledge out of AD into DLB, what's happening in real time.
Perhaps a more radical suggestion. I mean, I would like to see further breakdown of the silos, So for example, if academic researchers wanted to use Roche's Neuro Toolkit, Roche would try to accommodate that. But for Roche to be able to run that Neuro Toolkit, they didn't have the funding to do that for every researcher. So a different source of funding or shared funding. Similarly, if I've heard many times, industry should put this biomarker in and put that biomarker in, put this biomarker into every study. That's great. Can someone fund that? This idea that, there's an endless pocket of funds in industry. There's not, there are more molecule and they're not suffering for lack of molecules either. There are more drugs to develop than companies can develop. So, the decisions have to be made. Is it cancer or is it DLB? But the way we fund things, we fund them in these very tight compartments. And I would love to see NIH funding flow into industry trials and industry technologies or special approaches be available to researchers in academia.
I can second that. And sorry, I can second that, but also it'll make it trickier because we should be sharing that data. So this is something that we cannot like, but I like that. Yeah. Mm-hmm. Yep.
Well, I can tell you this, some of our best applications we get are the ones that are informed by industry partnerships, where they come in and say, I have this, and the other partner is bringing that. And that combination is really potent. The peer reviewers love it, and we have a much easier way of funding these type of applications. So we do want to wrap up the session. Please join me and thank the speakers for today.
Let's please get all of the speakers up at the table for the next session.
Okay, folks, last but not least, don't leave yet. Are you leaving first? Are you?
No,
Yeah, who's next? Yeah, you're first. Go. Yeah.
Are they like that? Oh, yep. How do I go back? Hey. There's still some folks here. This is great. Last session. Should I go ahead and get started? Okay. Hello, everyone. It's great to be here with all of you. I'm Sarah Biber, and I'm the Executive Director at the National Alzheimer's Coordinating Center. And everyone keeps saying this, but it's really true. I have learned so much over the past 2 days, and I hope to continue some of the conversations that I've started here with folks as we move forward. And I'm excited to highlight the work that NAC is doing to help empower the research community to tackle Lewy body dementia. So over the past 25 years, NAC has collaborated with the Alzheimer's Disease Research Centers program to build one of the largest and most comprehensive longitudinal AD/ADRD data sets in the world. So the ADRC program currently consists of 35 centers across 24 states. And the uniform data set, which NAC has collected since 2005, is standardized and longitudinal and consists of rich multi-domain neurocognitive, clinical, and phenotypic data and robust criteria-based diagnoses that are considered gold standard by the field. So together we have compiled more than 52,000 participants with up to 19 years of data on some. So this includes participants who are healthy, at risk, and with dementia symptoms. We have diverse, pure, and mixed etiologies, including LBD, well represented within the NAC cohort. And our 35 ADRCs are actively following a cohort of more than 19,000 participants via annual visits. So NAC also houses a large quantity of standardized neuropathology data, with 58% of participants serving as brain donors. NAC data has enabled major breakthroughs in the field and has been used to generate over 1,300 publications over the past 3 years. The global research community has been increasingly leveraging NAC data to drive discoveries in ADRD. We've seen a 26% increase in the number of publications and a 228% increase in the average number of data requests since 2021. We're very excited about that. So to further empower the research community to tackle the most pressing questions in the field, we've been focused on building a one-stop shop for all ADRC participant data. So NAC's new flexible and modern cloud-based data platform is more multimodal and interoperable and provides free and easy access to increasing quantities of data that are standardized, high quality, harmonized, and integrated. This includes new data streams that we're integrating and sharing by establishing or expanding interoperability with other NIA-funded repositories and initiatives, such as NICRAD, you're gonna hear from today, from Tatiana today. And then also you can go, to nacdata.org to learn more. But for the rest of my talk, I really want to focus, of course, on LBD data. So there are currently, within the NAC repository, so there are currently 3,000 participants, around nearly 3,000 participants with some form of LBD represented within the NAC cohort. That's as determined by clinical evaluation at a UDS visit. So of these, 68% have primary LBD, 30% were determined to have contributing LBD, and 2% non-contributing LBD. And if we look at the cognitive status at their most recent UDS visit, we see that 76% were found to have LBD and dementia, 22% LBD and MCI, and 2% LBD impaired non-MCI. Additionally, there are around 1,000 of our participants with LBD that were found to have Parkinson's at their most recent UDS visit, once again, all determined by, really in-depth clinical evaluation. So to date, there are around 1,400 deceased participants represented within the NAC database with primary or contributing LBD as determined, once again, by clinical evaluation. Of these, 60%, 857 participants have neuropathology data available. And if we review our neuropathology data, I mentioned we have quite a large neuropathology data set of nearly 8,000, around 8,000 neuropathology data sets overall. We can identify 1,000 participants with evidence, clear evidence of neuropathological Lewy body dementia. So as that's defined by the presence, in this case, of neocortical diffuse Lewy bodies. So this does not include individuals with Lewy bodies found only in other areas of the brain, importantly. And of those, 1,000 participants with that neuropath data, we see that 419 of those, so 41%, have had a primary or contributing LBD diagnosis as determined by clinical evaluation at their last UDS visit. And 601 or 59% of these participants had a different disease or diseases that were or were cognitively normal as determined by their clinical evaluation at their last UDS visit. So there can be, I want to note importantly, a long lag sometimes between, the last UDS visit and death. Sometimes that can be, 5 years or more. So that's very important as we're thinking about this data and what that means. Also, if you're, requesting our data, one of the things you can ask is you want to only request, right, neuropath data on individuals where that diagnosis was made within the past year, right? So these findings, there's many ways to interpret this, but one, this does indicate that many participants that have neuropathological evidence of LBD are not being diagnosed with primary contributing LBD through clinical evaluation. We've heard a lot over the past 2 days of how difficult this is to determine clinically. That's even true, right? With these incredibly robust and in-depth clinical evaluations that are happening as part of the EDS visit. They may not have been exhibiting cognitive symptoms, or these symptoms may have been missed during evaluation and testing, or right, they developed these LBD symptoms after their last UDS visit. As I mentioned, there can be quite a long lag for that. So I think it'll be really interesting to look into this. I hope somebody will take this data and do some research on it. I want to also mention that we have, and this was discussed earlier, that we have a DLB module that was developed by James Galvin, amongst others. And this may be included as part of the UDS fails visit and used to evaluate those suffering from or at risk with dementia with LBD. It includes, really detailed sleep data, fluctuation data, and other additional psychological tests, amongst other things. There are currently 517 total participants across 10 ADRCs in the NAC cohort that have at least one LBD module available. In some cases, right, this is happening longitudinally, so we have multiple on an individual. And so I think it'd be really interesting to look at how that impacts things. We do know that, for the neuropath data, we have 24, this is relatively new, this was launched in 2015, this module. We have neuropath data on 24 of these participants, and of those, 23 had DLB findings with neuropath, with the presence of diffuse neocortical Lewy bodies. So there's a lot. This is kind of a little gold mine of data that's just waiting for folks to jump on and take advantage of. I don't think a lot has been done with it yet. So I hope that this will inspire some folks to do that. And just remind everyone that you can freely access all of the NAC LBD data alongside all of our other multimodal data available at NAC via the NAC data front door. So it takes 15 minutes to submit a data request via our quick access file data request system. You'll get all of this data within 24 to 48 hours. And lastly, as I mentioned, someone should take this data and do something exciting about it. And maybe you should even submit it for this special issue that we're doing with Alzheimer's and dementia, focused on the 25th anniversary of NAC and the ADRC program. And so we'd love to have something written up about LBD, potentially as one of our commission pieces, or some actual numbers cranked to investigate what's going on with this module. I think that'd be fantastic. I've already had some discussions about this, some folks here today, but if others are interested, please do reach out, because I think there's some really interesting findings kind of waiting there for us to uncover. So thank you everyone for your time, and I'll pass off to my next panelist.
Okay. You sit and wait. Oh, sure. So Tatiana Ferd. And so I took my 5 minutes very seriously. So I think 4 slides, but I'm going to talk a little bit of a preamble here. So my apologies, you're going to be waiting for me to click forward, and I'm going to take a little bit of time to do it. So I'm here actually representing, I've listed 2, but the more I think about it, I really think I want to also pop in PPMI as sort of another source of samples. So what I want to give you is a sense of why, partly why I do what I do, and why I think this could be valuable as we're thinking about how to explore DLB. So NICRAD, I feel like there's probably only a small number of you who don't work with us in NICRAD. We're an NIA-funded repository. And if you don't, I don't know how I've missed meeting you. So we're an NIA-funded repository. And I just have to remind everyone, we started 30 years ago, and started in the days of needing large amounts of DNA. And so we have over 70 studies, a real breadth of studies, and I'll try to give you a little feel for that. BioSend is a newer repository for us. New means about 10 years, and that's a similar, I always sort of call it the comparator from NICRAD is BioSend for NINDS. And then the third group that I work with is with the Michael J. Fox Foundation for PPMI. And the reason I bring up all 3 of them is one of the things that we want to be able to do, and I think is important for everyone in this room, is to handle samples in a similar way. And there isn't a good way to show that in a slide, but that means whichever repository you're working with, you're using similar tubes, you're using similar processing at the site, you're doing similar processing with us, it's the same instruments, it's the same staff, and the way the samples are going to go out is going to be in the same way. And what I really hope is, I've been sort of arguing about this or suggesting this for years, but I actually think you're probably the room that probably has the greatest potential to be able to go across the repositories. For years, I've said, I'm really hoping someone will come and want 10 from here, 5 from there, and 20 from there. I hope with some zeros on that. But I really think this is the opportunity we've been waiting for, because as you'll see with numbers, there aren't very large numbers, perhaps for some of the work that's been described in any one repository. But if you start looking across, I think that's how you're going to be able to start getting your numbers together. So I wanted to sort of give you that sense of uniformity. That's probably one of the most important things I can get across in this presentation today. So I'm going to start with BioSend. So BioSend has had, of course, DLBC. So has the largest number, I think, of widest breadth of samples in the context of DLB. So I just want to remind you, as you look across here, it's DLB, blue says DLB subjects, but I want to make sure you look above, which says completed visits. Okay, so just as a reminder, the individual who makes it all the way to 48 months, we certainly hope that individual has been there all the way across. Okay, so I want to make sure you understand that these are obviously individuals working their way across that pipeline. And you'll see smaller numbers of individuals identified as DLB MCI. What I want you to get a sense, because of the breadth of studies we've talked about over the last 2 days, there's a wide range of samples. So there's plasma, there's serum, there's whole blood, there's RNA. Thanks to Sonia, there's also sequencing. My gratitude to her. She's looked across both repositories. We have a great wealth of whole genome sequence data that is available across the repositories here. There's CSF available from about half of the individuals at that annual visit. As with many studies, it starts to go down. But again, it's the longitudinal collection of samples. And in many cases, the comparable groups that you're going to want to look at are sitting here as well with similar time points, similar collection of samples. Importantly, there's beautiful clinical data. This is all sitting in DMR as part of the PDBP and the DLBC. And there is SAA data generated by Amperan. So there's a great deal of samples from which you could do new studies with, but there's also a lot of data that has been generated that you can also work with and request through the DMR. So hopefully giving you a sense of that. If that's excited you, you can start with us. You can also go we can get you to the various BRACs, but just want to give you a feel. There's really a great amount of data and samples that you can do work with. So it's a little bit different for NCRAT. I just want to say, because there hasn't been quite that same emphasis, probably the closest thing I can probably bring you to is NAPS. And in talking to Brad, I hesitated whether I should put that here, but there is the ability to request NAP samples. So we bank samples for studies where they may not yet be available to be requested. But I just want to flag that NAPS is. I'm the comparator, is that the right word, with Sarah. So when she was describing samples that you can request through NAC and thinking about what's available, we have a number of samples from the ADRCs. I gave you a little bit of that history because much of what we're going to have from the ADRCs is DNA already sequenced, but also plasma. So increasingly in more recent visits, there's plasma. Also would potentially have subjects with an ALA FTD, also in the NCRAD family study. And this is where, if you want to work with someone at NCRAD and try to help you look across studies, where might there be subjects, we'd be glad to work with you and help you identify where there might be individuals in different cohorts that we can work with you. So really just want to stress also a wide range of samples there. I've put a plug in for PPMI as well. If anyone, I didn't put a separate slide in for them, but if anyone wants to know more about that, glad to chat about it. The one thing I want to stress, because we've talked a lot about data, and I promise not to read you every box, but I'm hoping these slides are going to be made available. One of the things we do across all of the repositories, and for those of you who've worked with us, both to receive samples, and for those of you who've worked to bank samples, equally important to getting samples is making sure that the data generated from them is made available. What you don't want to do is the same experiment over and over again on that plasma sample. So really what this slide is walking you through is when you receive samples from us, they're blinded. I trust you to return data, but I really trust you more when you can't analyze it without returning that data. And so that's sort of the basis of what we do is you're going to return the data that you have, and that's going to unblind you. I do want to flag that increasingly reference pools are something that people want to be able to do more experimental work with. And sometimes it's very hard to find them. So both of the repositories are trying to grow our reference pools to make that available for you if you want to be able to do more exploratory work. And I think that's probably where I want to leave it there. I think we'll talk about gaps. Really interested in the discussions, beginning to get more skin collection in the different repositories. Really see that as an option. I'm trying to have that also be done in a uniform way, but really want to be the partner and want to make sure we're collecting samples that you want to use now, but also in the future. So really glad to be here for those discussions as well. Thanks so much.
So I have to catch a plane right after I talk. So I'm going to miss the panel discussion, but I put my email on the first slide, and please reach out if you have any questions or want to chat some more about the AD Knowledge Portal and what we do at Sage Bionetworks. Any emails are fine. So I'm Laura Heath. I'm an associate director in the Alzheimer's Disease Translational Research Group at Sage Bionetworks. And I guess we'll just get started here. So the NIA has really created this kind of Alzheimer's disease data ecosystem. And this is, just to be clear, this is very much an Alzheimer's focused data repository. And over time, I think we're up to 14 different NIA sponsored programs that are all depositing data into the 80 Knowledge portal, along with a community data contribution group or option. And not only do we house, this is mostly multi-omic data, but we also have some data explorers called Agora and the Model AD Explorer, which both allow you to search by gene and see differential expression results by transcriptomics and proteomics. There are gene rankings that are associated with the Treat AD program and different mouse models and their differential expression results as well. So this is just kind of a snapshot of how everything is organized. You can see that there are all these different data contribution programs and there are community data resources as well. They'll contribute their data into what's called Synapse, which is a tool that was built by Sage Bionetworks. It's a data cataloging and storage space. It's actually much bigger than this 80 space. It's an NIH blessed repository for sharing your data across all kinds of different realms. And once it's in Synapse, we have a strong governance team at Sage that will go through and make sure everything is ethically and properly shared according to whatever IRBs or consent forms that your institution has. We also have a strong data curation team who will annotate and catalog the data and make sure it's going into a place that's organized and correct. And then it surfaces in the 80 Knowledge portal. So this kind of sits on top of Synapse. And it allows the data to be actually searchable. We have a number of facets and search bars that you can go through and look for data based on your modality, or we can't quite search based on disease status quite yet, but we're working on building a cohort builder that will allow some more kind of flexibility in looking for data. But right now, you can look at the study pages and the program pages, which is the way a lot of people kind of search through their data. And we also, connect to our results explorers, and we're starting to really push interoperability with cloud-based workspaces. These would be trusted research environments, so you wouldn't actually have to download data to your own computer. You could load it up into Gavatica. And at the moment, they're offering, I think, $100 worth of free credits or something like that for you to try it out. And from there, you can build your own, have your own RStudio or Jupyter Notebook and a whole suite of kind of multi-omic data analysis tools, or you can direct download to your own computer and work from there as well. So the kind of data we collect it's quite a bit different from what the NAC collects, which is really rich epidemiological and clinical data. We primarily collect multi-omic data, so genetics, transcriptomics, single cell transcriptomics, epigenetics, metabolites are more and more common now, proteomics, like Nick was talking about. Most of that data lives in the 80 Knowledge portal. And most of our featured data sets really are from autopsy and from the brain. We're starting to collect a little bit more data from the periphery with the inclusion of some new programs, but most of it is postmortem. And the metadata that comes along with this data is a little bit limited at the moment to kind of your basic demographics and some neuropathology and maybe some diagnostic data. We also share output. So not only can you upload raw data files, people in our consortium and those of us at Sage who work in science will share, processed and aligned genome files, transcriptome matrices that are ready for analysis and that have been batch controlled for certain data sets, not for every data set, but it'll go along with the publication. We try to publicize those as much as we can. And of course, everything that we try to do is under fair data standards, meaning data should be findable, accessible, interoperable, and reusable. Each one of those components requires kind of a team of people to make happen. And we currently don't have much data on Lewy body disease. So like I said, our metadata is pretty limited. It's often just Alzheimer's control or other, and it's limited to the amyloid and Brock neuropath variables. But just recently, we had the diverse cohorts initiative with the AMP-AD, where we collected brain tissue omics, multi-omics from as many individuals from across 5 different data centers who explored their network of brain banks and cohorts, and it reached out to 16, I believe, to collect specimens from people who were not white and non-Hispanic, non-Hispanic, sorry. So we ended up with about 600 individuals who were not just white people who fit those criteria. And from there, we generated transcriptomics. We're in the process of generating metabolomics. We have a solid single cell data set now and proteomics and whole genomes from all of these individuals. And we harmonized their outcomes. And along with this initiative, we collected a little bit of extra neuropaths. So we did get some Lewy body disease indicators for these people. It's not easy. You have to go back to all the individual neurologists sometimes, and sometimes they're reluctant to go way back into their records. They just don't have the time to do it. But in some cases, it is easy. And we harmonized with the ADSP, which is the Alzheimer's Disease Sequencing Project, which is or in their phenotype harmonization group, which is run by Timothy Homan at Vanderbilt. And their data harmonization methods are very much in line with what's happening at the NAC. So we also have some alternative versions to fit some of our collaborators as well. Dennis Dixon, who you've heard about at Mayo, had a specific way. He amended one of the typical Lewy body measures that they use at the Mayo Clinic commonly. And so we included that as one of our variables, just in an effort to collect as much data as possible that could be as accurate as possible. And so, like I said, we are working on actually expanding interoperability. So Sarah had the 80 Knowledge Portal little sticker on one of her slides, and we're working on being discoverable through the data front door for individuals who are in NAC and part of those ADRCs who also have multi-omic data in the 80 Knowledge Portal. And eventually we hope to expand our interoperability with NIGADs as well, since they hang on to a lot of the sequencing data. Although for all of these, you still have to go through various data use agreements for each individual repository, but for the 80 Knowledge Portal, it's actually pretty easy. You submit a data use agreement and an intended data use statement, which is really quite general, and it gets reviewed by our governance team. And again, we're also establishing interoperability. We have access to Cavatica, and we're working on building access with Terra out of the Broad. And that's it for me. Takes a lot of people to make all of this happen. Everyone just says like, oh, you guys should all be talking to each other, but it's actually quite difficult sometimes. There's a lot of governance and interoperability and engineering that goes along with that. But these are really great folks to work with. So I look forward to making the 80 Knowledge Portal talk more efficiently with everybody else.
Thank you. I'll start off with questions. So thank you all for your presentations. And touching a little bit on what Tatiana briefly mentioned, I'm wondering if you're having listened to the discussion today, is there a part of your data repository that one, you would like to emphasize given the interests of this group, or two, that you see an opportunity to expand your repository to take in that particular type of sample data?
I'm glad to go first. So I tucked in skin because I do think in this context, I certainly hope, and I think there's maybe mixed feelings in this room exactly where we are with skin. But I would say I think we're certainly close with skin, and I certainly hope that we'll soon be out of the needing less CSF and moving ourselves towards skin. I think skin has the opportunity to be used for screening. And if you're thinking about cohort building, I mean, again, I work in the PPMI space too, and that's very much where they want to go. And I think that's where many of us would like to go. I think from my space, it's around how many sites do you need to do on the body, how many punches do you need to do? And then what do you want to be able to do? Do you want to do SAA with them? Do you want to do IHC? And I think to me, those are sort of the questions we're working our way toward. And then will we have the ability to collect that remotely? But I see that as something that I think for this space and this audience, for a number of audiences, is going to be something that's going to be, I'm curious. I'm looking at Brad as I say this, and maybe he agrees or doesn't agree. But I certainly hope that that's a place that we're going to be pretty soon.
That would be great. A related question: if the skin sample goes to NCRAD, has SAA done, in the interest of participants wanting to learn the results, will we have to get all the the paperwork and consenting done up front so that it's accommodated? But will those results come back to the site so that it can be shared?
So increasingly what we see ourselves as a role is to help studies do that screening. And I think if you're taking individuals in and out of studies, you're increasingly going to need to tell them why. So a couple different things that I think would be important in this context. So we have not been setting up SAA. I just want to be very honest about that. If we want to set it up, we want to do it in the quantitative context. I just think where it is right now with CSF as a binary, I think Amprion is great to do that. And we've got a good relationship with them. So as you know, we've got studies where we're passing toward them. I left at 2 to get on a call with Amprion because part of what we're trying to do, and I'm not embarrassed to say this, I thought it might come up and I wanted to make sure I knew the answer, is for PPMI, we want to be able to get results back from them in 2 weeks. Now, I'm not setting that up. In that case, it's PPMI that's setting it up, but I think many of you are going to be interested in that as a potential screening. So the question then will be, do you want to do it in their CLIA lab or in their research laboratory? Okay, so and maybe is this more than you want me to cover? Is this all right? So the research lab is not going to want to do a 2-week turnaround. You're going to have to do that with the CLIA lab. Okay, so I think the thing that we can bring, and I think this is the advantage I find about having these 3 repositories, is at different times, different repositories are doing things at the forefront that help the others. And right now, when I think about this community and think about skin, PPMI is really trying to move that window. So to the beginning of your question, I think we want to be able to do rapid turnaround. So in this case for PPMI, we're doing it in CSF, but we want to be able to flip it into skin when skin is ready. That's sort of maybe my first comment. I think my second comment is, I think increasingly, the relationship we have with participants, we need to be able to return results. I think it's important, though, to be able to describe adequately to them, what they're getting back and the limitations on that. So if you're doing it in a research context, you need to be able to explain what that means. If you're doing it in a CLIA context, what that means. And so for those of you who don't know, in different studies, we're increasingly setting that up. And one of the things I've done, if this is helpful to anyone, is we have 10 genetic counselors now with us, 4 of them Spanish speakers. So that, and I've taught them, I've encouraged them, whatever the word we want to use is, what you do in returning genetic results is important in returning a number of other types of results, and the conversations you have a lot of parallels. And so I feel like we're trying to raise that capability so that whether we provide it or work with other studies to be able to do that, to be able to describe research results, answer questions about that. And so I see that as an important space in which we're going to need to be able to provide at least support or information. Did that help? Okay.
Okay, so along the same lines, I mean, I guess I mentioned that we have, around 2,000 participants with suspected or confirmed LBD within our repository. So I think there's a huge opportunity there. And I want to, we mentioned that, around 500 of those, we also have this additional LBD module data on. But in addition to that, I noted in my talk that NAC is becoming a lot more multimodal, right? So for these individuals, there's going to be, in many cases, additional types of data available. That could be anything from standardized MRI and PET data through the new SCAN initiative to additional standardized MRI and PET data and fluid biomarker data through Clarity. There can also be, we're starting to bring in additional data streams, everything from EHR data to digital data, et cetera. So you're going to increasingly have more and more data types that you can use to really understand the complexities that might be going on. Also, we are transitioning to a new version of UDS right now, UDS v4, which is to include things like like social determinants of health data, like collected in a standardized way, as well as information on use of disease modifying drugs, as well as some additional neuropsychological data. So there's lots more data coming together to really paint a more thorough picture of what's going on with these participants that I think can really help LBD researchers as well as other researchers, right, ask and answer new types of questions using this data. So I'm really excited about that. With regards to, we're also pulling in fluid biomarker data and analysis results in partnership with NICRAD. So any participant that has fluid biomarker, ADRC participant that has fluid biomarker data at NICRAD or genetic data at NIGADs, we're pulling that and those analysis results, that metadata into our platform. So you can go to one place to search for all that. If you want to dig deeper and get access to the samples, you of course have to go to the experts at NICRAD. But that is, we're through that data front door, we're enabling folks to search across data, not just for ADRC participants that lives and is housed directly at NAC, that lives in other NIA funded repositories or with other, I know it's powered by other NIA funded initiatives like Clarity and others. So I think that's really exciting and creating a lot of opportunities. With regards to return results, that is something we're thinking about more. So we're starting by making sure ADRCs can easily access all the results for their participants. So we're doing that through new portals called the ADRC portal. So each ADRC has a portal they can log into to see all the different kinds of data and analysis results that variables are participants. In some cases, like our partnership with Clarity, we actually will be returning ATN results to ADRCs to return to their participants if they choose. And so I think that's, a step in the right direction. And it's something that we could, we're learning a lot from and can build off of moving forward, in particular, as it may relate to LBD. So I'll stop there, but hopefully that's getting folks even more excited to go jump into the data and see what we have available. And as I mentioned, that will only becoming more and more multimodal over the next couple of years.
I'm going to add one more thing and then I'm done, I promise. So I didn't know if I could pick more than one before. So the other thing is just, I think, to build on what Sarah just said, is right now the relationship we have in NICRAD with the Alzheimer's centers is we run plasma-based biomarkers. So we're doing on both Quanterix and on with LumiPulse returning. LumiPulse, we're returning A-beta and now switching soon to p-tau, and then doing NFL and GFAP on Quanterix. Our new ELISA got installed this week. And so what we're envisioning is, as increasingly we're moving toward approval of plasma-based biomarkers, what we anticipate is the next thing people are going to want to be able to have is then sort of likely, an Alamar and ELISA type of platform that they'll be able to use for research. And so I think that's the other thing to be thinking about, is what needs to be on that platform. I think a lot of what we saw that at least we think we're right now interested in is going to be sitting on that platform. I think that's going to be added value. I think the one thing that is clear in the field is there's a lot of movement and it's just rapidly turning. And so how do you balance when it's time to move to another platform? When is there enough evidence, enough data? When is it, when you have central repositories and data sources like ours, when does it make sense for us to make that jump? When is it research and it should be in like a discovery lab versus when it should be something that can be returned to centers? And so I think that's something that meetings like this are really important to see. What are people going to need to be able to have as part of research characterization? And then what are they going to need to be able to return on?
And I feel the need to put in that those samples that Tatiana showed, the longitudinal samples for BioSend for the DLB patients. There also is longitudinal clinical data and longitudinal neuroimaging data for all those people in the PDBP biorepository. And we have in PDBP made an effort to harmonize the instruments that we collect on the DLB subjects with the NACS LBD module, so that these data can be actually cross-platform compared. Which then leads me to my next question. And going back to Laura's talk, she was mentioning how all these different projects were brought together in AMP-AD. As some of you know, there are multiple AMPs. There's an AMP PD, there's an AMP lupus, there's an AMP, there's diabetes and metabolic disorders. And there's a big effort some of those AMPs are on the same platform, some of them are different platforms. There's a big effort now to get some cross-platform talk so that you go in to, you access data and you access AD data and PD data and lupus data and diabetes data. So my question to you all is there some low-hanging fruit? And, you know, for the goal of big sample sizes, is there some low-hanging fruit you see to crosstalk with other repositories or other resources?
I think they're totally, so that's what sort of what I was alluding to is I think there's few repositories, whether they're data or samples, that has enough for the kind of sample sizes that we were talking about over the last 2 days. I mean, I think that message came through very clearly. And so I think the idea that you could work more smoothly across AMP-AD and AMP-PD, I think would be incredibly helpful. I think right now it's quite separate. So even if there was a process by which you could apply through one request to both, I mean, that would be quite helpful. I don't know what the rest of you think, but that would be helpful. We have separate, I would say on the biorepository side, we've actually had our first forays where we've had NINDS have NCRAD do a review of the FTD samples that we have. If there were ways for us to have, you know, especially in this space, a common request process that would get you the samples out of both, I'd be very open to that, because I think in the AD space and the PD space, you know, it tends to be, you know, each repository has its strength. But I think Sonia really highlighted that she came to both and she needed samples from both. And I think if there was a process for us to be able to have, whether it's a common review or an ability to do that, that would be incredibly helpful. I think, I don't know what the rest of you think, but it would reduce the bar for people to be able to get samples. In my world, that would be very helpful. But then on the backside, be able to get the data from them as well.
One of the low-hanging fruit I already mentioned, which we're going after, is really just, you know, bringing in now ADRC participant data from across 6 different repositories, right? So you can access, it's still for the same individuals, but you have, you know, now 12 different data modalities that we're pulling together for those individuals and making available. So I think that's one really critical low-hanging fruit that you can do. We're developing standards for the field, right? These standard data elements, as you noted, right, are sometimes used in other studies. And I think there's huge opportunities to build larger cohorts, you know, using, you know, data harmonization approaches. And there's a number of folks who have done that very successfully. And so I think there's more room for that, especially if you're, you know, targeting something like really specific like DLB, right, where you could figure out which would be the repositories, right, data sets. It would make most sense to do that for, and then harmonize across those with, you know, the elements that you can, of which I think there'd be significant overlap. We know that UDS, you know, is not just used in the ADRC program. You know, when we develop these new UDS instruments, they're actually used, you know, all over the world for other research studies. So we know just for UDS V3 alone, it's been used in over 175 international research studies for all sorts of things, right? So there's an opportunity. We don't pull that data in at NAC, but we could, right? And there could be other opportunities to expand that way. So I have other ideas too, but I think those are, you know, some nice low-hanging fruit that could be very, very impactful in LBD space, and of course, in many other ADRD areas as well.
Okay.
We'll repeat it for you.
Something that we should not forget about. TDP-43, it's ALS, FTD, especially for DLB, you know, think about DLB in general.
Yeah. ALS and DLB are also, you know, represented within the NAC cohorts. We have, you know, as I mentioned, a wide range of mixed and pure etiologies represented. Yeah.
Two questions. I suppose the first one, how are you linking in with international repositories and that crosstalk? Again, we're talking about our power of numbers. So that's my first question. The second bit is that I get a bit overwhelmed with data and I've gone, oh my goodness, is this repository, is that repository? There's a bit here, there's a bit there. And this is following on from a conversation last night, you know, the power of AI to potentially be that front facing, that if I go, I want, you know, 200 DLB patients who are SAA positive, who have a score of this, who have biosamples in this and happen to have imaging and some longitudinal data. I just type that in and bang, it goes, and there it says, here it is. You know, do you like that? That would you know, because I know working with the UK Biobank, we have one, you know, postdoc that spent months just doing the search terms, going through, creating and collecting the data. And yeah, it was just like, oh my goodness.
Yeah, I mean, for our data front door, one of the components we're planning to build as part of our renewal is actually an AI-powered tool that would allow folks to search across at least the data that we're bringing in and allow them to figure out what's available to, you know, do we have the data to match their question, right? With regards to connecting to larger research studies, so I mentioned a couple different ways I thought we can do that in terms of looking for common data elements, right, and harmonizing across different studies. That does take some work, right? But you know, if there's really important questions that need to be answered, those are the ones you go after first, and you build the harmonization that you need to be able to, tackle those questions effectively with that data. And I think that's, you know, it is overwhelming, right? So I think we need to think about, you know, can't build interoperability with everything right away. We have to do the most impactful things first, right? So thinking about DLB, what are the critical, types of data that need to be combined and what numbers to really meaningfully answer the questions, right? And so I think you start there with the highest impact stuff. We're also looking at things like bringing on additional types of identifiers, like the PPRL is a common one that's being used in various real world data initiatives. And that would also allow us, to tap into other larger repositories, to be able to bring in, you know, build bridges with other larger pools of data.
I do think the fundamental challenge we've got, and we keep trying to solve it, is we do have data in multiple large warehouses. And so you have data at Loney, you have data at NAC, you've got some data that's at the knowledge portal. And we keep trying to figure out a way, can we put enough information where people could go to one place and then so like we've gone through the exercise of GAIN. I feel like we keep trying it, you know, GRIP is trying to do this now. I mean, we keep retrying it because we all
A one-stop shop.
Yes. Where you could have enough information about, even if you didn't have every data set, but you at least knew, had a way to know all the variables sitting in all those locations. To my knowledge, that does not exist. And it's really challenging because in part, we all survive because we have, our space in these structures, but we make it incredibly difficult. And so I think even if I keep thinking, is there a summary way that we could place that? And we keep trying for different approaches. To my knowledge, we're still not there. But I think that's the question: is what would it be that you'd need to have in a common place? It doesn't have to have all the data. I think that's partly what GRIP is trying to do. They're not trying to put all the data in the same place, but have people be able to go to one place and say, here's what people have. Now here's a link to go request it. I think even that would be helpful. Go ahead. Yeah. That's what I'm sort of suggesting but you have to have some core infrastructure that we all have. To my knowledge, I don't know if this is what you were going to say, Jim. I mean, that to me is, and that's one of the challenges of finding the data. Like I'm really proud of the approach that we take, that you return data, but the place you want to return data from samples is the place where all the other data from that study is. And so in some ways you exacerbate the problem. So for some studies that's Loney, for some studies that's NAC, for some studies it's someplace else. And so we continue to make it hard for people to find what they're looking for. And AI is like I think our first chance to try to grab that, but I think it's asking a lot of AI to be able to dig down into each of our data sources and realize what's there. If you could, indexing is a nice word, I think would be very helpful.
Thoughts about common, because how do I?
NAC. GUIDs.
Oh, so yes. So
Well,
GUIDs
are they all GUID?
Well,
is every single study GUID?
No, it's not. Yeah, I mean, you know how many times I stood up at the ADRCs and begged for GUIDs? I mean, I probably could have had a child in the amount of time I begged for it. But I would say, the other thing I always rely on is I get DNA from just about every study. So you may not know the same participants in that study, but I do. And so if there was a way for, that to help drive anything, we've helped, ADNI and the Alzheimer's centers realize where they had common pathology, where ADNI had done pathology on an ADRC participant, or where an ADRC had done pathology on an ADNI participant. I mean, we do know, and we snip fingerprint everything at our place. So we know across all the repositories who's participating. So we do know it. I mean, anyone doing DNA has that ability to do it, but we at least have it in everything we have. I just, we never got ourselves settled on a GUID, but so DNA is our next possibility, but
Well-
we have to be careful to use that.
We do have GUIDs. Okay. So everybody in PDBP has a GUID. NINDS has a GUID generator. NIA has a GUID generator. And
Yes,
the
that is true. If
GUIDs
they give different information, they can get 2 GUIDs. You're absolutely right.
That's
If
right.
they don't give
The
the same
GUIDs are
information.
different, but there is a cross translation. So the GUID tool will tell you if you have 2 different GUIDs, but it's the same person and they're in the 2 different databases.
How do they tell they're the same person?
Because the system that generates the GUIDs for NIA and the one that generates it for us
Mhm.
uses the same generator. The GUID it spits out is different,
Right.
but the generator is the same.
For those of us on the receiving side of GUIDs, I think it does give us a little bit of hesitancy when we see 2 GUIDs linked to a single individual
Sometimes
participant.
they have
Well,
given
it's-
different information. I do think sometimes it's human error too.
I think there
Yeah.
is some QC that probably needs to happen there. And that was one of my points, was just a lot of us generate data for all these data sets. Our site certainly does, our ADRC, our DLBC. So there's those issues, which are just quality assurance issues. And I like the idea of DNA, although obviously there's personal identifiers. Yeah, they're a big part of that. I'm not ready. I just wanted, because you made a quick allusion to this. If skin biopsies work out great. I'm not ready to give up on CSF because what happens when we get a biomarker for TDP43?
I wouldn't get rid of it. I don't want to screen on it.
inflammation?
Yeah, I'm hoping not to screen on it.
Yeah,
but
screening, I'm quite comfortable. And maybe ultimately we can get away with blood and skin biopsy and everything else. But I can do a lot with a single CSF biopsy.
You're absolutely right. You're right, Jim. I shouldn't have been so.
No, that's
I
all
shouldn't have
right.
been quite
That's
so.
all right.
But I love the idea of not having to screen people with an LP. I'd like to grow my trust on something
Yes.
easy
No,
and
I
then ask them.
For a second there. Yeah, I mean, they do the screen test and then they go and say, well, did the PSA really indicate what we think it indicates? And I think neurodegeneration is going to be very similar. Serious disease, getting a spinal tap is relatively minor.
Says you.
Yes.
What do the patients say?
Well, I mean, right. If you have somebody with cancer and you say you have to do a CSF tap, it's no brainer. And they use an old needle that gives you a headache. So, I think it's just it's educating people.
So I will say for PPMI, we've just started,
Yeah.
we've just switched, for those of you who aren't familiar, just switched to Amendment 4 in PPMI, which is to screen not with a DAT, but to screen with CSF.
Yeah.
And so it's my group that does it. We're the screening core. We've got between 40 and 45% agreement to go get your LP for screening. We were at about 60% on DAT, and we're only a month in. So we think we can bring that higher. So I say that knowing that, I think if you can explain it, as
Yeah.
you all who do it all the time, if you can explain why it's important, what you're going to learn from it, you're going to share back with them what you've learned from it, then I think you can get people to travel even and do it. But I sure would rather send a nurse over and get a skin from him if I could.
Biopsy and a plasma sample and portable DAT scan
And at this point, I need to give 2 thumbs up to LBDA because they did a deep dive into CSF and why patients didn't like to do it. And they have posted videos and encouraged people. So we really do appreciate that. Any last questions?
There are no online questions, but I would like to invite those who stuck with us here to this ending part wasn't necessarily supposed to be a panel where we just address questions to the speakers. They were kind of letting us know what's out there in terms of resources that could be used or enhanced. But we're hoping that the group here would help synthesize everything from the other sessions to come up with crazy ideas of what we would love to have that would really advance the field and help primary care do a better job at diagnosing and of course aiming toward having treatment, what we need for clinical trials, bringing everything all together. But we focused on the data and sample resources that are currently available as a way to kind of let everyone know what's there now.
So what's on your wish list, guys? Aside from I need more money. We know that, but if you could ask for one thing that you really think would push DLB into where Alzheimer's is, what would it be?
Well, from my point of view, it's kind of simple. Forget that I need more money. I think we need to come up with a study that has hand and feet. And realistically, if we wait for the 3 studies that are ongoing, we'll be able to do it. Because from a mechanistic point of view, our drug might work, but then from an inclusion and test point of view, I hate to say that we're going to capitalize on these 3 studies, whether they work or not. That's going to be very helpful.
Go interoperability. I think it'll be great for everything. It seems like a low hanging fruit, and I know it's not trivial. So just for everyone to acknowledge it.
I agree with that.
All right. And if we could, just like JP, if we had some way of NAC used to have this 2x2 table that you could just generate yourself to see if there's enough samples there to look at your data question. But it's gotten so complicated, you can't just do a 2x2. You're gonna have to do 16x16, which is not quite possible. So I think I agree with the interoperability issue and just access to the data where I don't know how you're all gonna put it together because every single organization and data set has their own data use agreements.
Yeah.
Right? So that's my wish list is there's some silico rather than going and re the wheel.
Yeah. So one of the things we're going to be doing right away, which might be exciting to you, is that and we have to walk before we run. Like we want to have this, AI fix everything and just tell what we want. It'll just put the table to write the paper, do all the things. Maybe we'll get there, but we have to walk before we run. So one concrete step that we're taking, as I mentioned, we're establishing this interoperability by working to bring in data from 6 separate repositories, right? Bring 12 different kinds of data together for ADRC participants, right? And we have to be able to make it easy for folks to see whether the data is a match for their questions, right? And so what we're actually in the process of building right now, and we're hoping to have a prototype available actually as early as the spring, is you're going to be able to go to the NAC data front door and go to our cohort browser tool, which we're building, which is sort of like the version of the tool you mentioned, but kind of on steroids. We'll be able to go and say, okay, I want to know how many participants, right, have, such and such genetic APOE positive, right, have this certain, blood biomarker signature, are female, right, have or had suspected to have LBD, whatever it is, right, and have these, the readings, the following readings for these 77 SNPs, right, and I want to know what is the size of my cohort, right, and now at first, I eventually want people to click a button, and all that data will get, dumped into a cohort or, sent to their, favorite analysis environment. But to start off with, right, you'll get a list of NAC IDs and you can then go to NICRAD and you can go to NIGADs and you can give them your list of NAC IDs and you can get that fluid biomarker data if you qualify, and you can get that genetic data if you qualify, right? So it's not as seamless as we would like it to be, but it's a really critical step in that direction. And we're really, that's going to be becoming available in this coming year. So I think that'll be really helpful. Yes.
Okay, so if I want to do a study, Okay, I can put in my wish list of who I want, but I really don't know in this specific instance, we don't know what we want, right? So since we are really not sure which LBD patients will respond to my drug, how do I go about that?
So, I mean, in this case, I'm talking about ADRC participants, right? So those 52,000 participants, we have 19,000 active. So the way that you could do it, I mean, you don't know, right? You could request all of the data and you could say, I want all of the data for all of those participants. That's our quick access file data request system. And soon you'll also be able to know the fluid biomarker readouts for the top, 10 biomarkers as well for those individuals and the top 77 SNPs, right? The readouts for those too. So you can take all the data, do a more discovery-based approach, because maybe you don't want to have too many assumptions. And maybe you want to pull in some of the digital neuropathology data that's going to be available from Clarity, or maybe you want to pull in standardized MRI and PET data from SCAN, right? There's all different sorts of things are available. So you can take that more discovery-based approach. The cohort browser tool I just mentioned to you is if like you really have a very specific idea of what variables you need and you want to understand whether there's enough data there, right? That gives you enough power for your question you want to answer, right? Does that make sense?
I think a big problem in general, I mean, with the NAC, with all the LBD cohorts we have, is lack of diversity as well. We're studying such a small group of community, and it freaks me out that we may one day hopefully find a cure. It's not going to be applicable to all, maybe, and a lot of people aren't even going to have access to it. So what good is to have a cure that's not going to work for many, and it's not going to be, accessible for many? So I think that's a big problem. And in the NAC too, we have great amount of data, but it's from such a limited group of people.
Yeah, I think it's a super important point. It's something we've thought about a lot, and we have some stuff in the works that we're doing to try to work with the ADRCs to address that. It has gotten better in the past few years, so I do want to note that too. Our active participant pool of nearly 20,000 folks has 32% underrepresented groups represented there, so that's quite a leap up from where it was even 5 years ago or something. Maybe was 28% then, is my recollection. So that's good. It's not where it needs to be, and it's actually going to be a big focus of our renewal, working with the ADRCs to support more diverse recruitment, sharing best practices. We actually just recently launched an Indigenous ADRD advisory group that's focused on, working to develop best practices for respectfully and successfully engaging Indigenous populations. There's a number of different efforts that are underway across the ADRC program. The Clarity Initiative, which was just funded, has put a huge investment into more diverse recruitment. So there's actually, Beth can speak to that as the MPI of that, but there's, a huge, emphasis. There's a whole, one full-time person that's going to be at each ADRC that's really going to be focused on further amplifying diverse recruitment. It's going to really diversify the whole ADRC program to have that effort. It's going to be incredibly impactful. So I think, we're also looking at that in that cohort. We need to make sure that we develop methods, right, that ensure the generalizability of findings, right? It is what it is. It's never going to be a perfect match necessarily for what the US population is. We want to get it as close to that as we can, right? But we also need to have methods so that we don't draw the wrong conclusions, or we build AI. We know whether there's whether that's biased, like those findings, we need to be able to test that out. So there needs to be strong methods that help us understand how to take findings from that cohort, right, and make them generalizable to all populations too. So those are just some of the things we have underway. I don't know, Beth, if you want to talk about what Clarity's doing, but
We don't have any more time.
no time.
Unfortunately,
Okay.
I was going to let Rochelle, if you had a last comment.
Well, it was the request for the gap. So for me, the thing that I need is, I need all these data and everything everyone's doing to result in an understanding of subtypes, staging, and a quantitative understanding of how the disease progresses. And I would add a request at the same time, if you do this for DLB, please do it for MSA.
And we did get
A couple
2
of
last minute comments online. Oh, you got them?
I got them.
Okay.
So we have one that says it would be great to have biomarkers that could predict when subjects will convert from RBD to PD, DLB, or PDD. And the second one is WISH repository of screen failures and screening data across sponsors. Okay. And with that, I think we're one more.
I just want to add some thank yous so you can close and then I'll do the thank yous.
Okay, well, I was going to close and thank you, so go ahead.
Okay, so we want to thank LBDA, Angela, Keith, and Natalie very much. And Sandy Moose from the Lewy Body Research Foundation. I also want to thank NIAID who hosted, this is their building and resources, and Julio particularly who helped with all the AV, and Marlene Stanley and the NIAID Meet team. I really want to thank Grayson, who we couldn't have done without Grayson. And Soledad and Lori from NIA, from NINDS, Amir, Deb, of course, and Sonia. Thank you. And from Strategic Results, Rachel and Ann, our science writer, Dale, who's online, and all of the speakers, moderators, and our online audience. Thank you all so much. And we hope there will be continuing conversations as a result of this meeting. Thank you.
Thank you, Nina.